Good morning. Esteemed speakers, presenters, members of the Healthcare Conference Organizing Committee, ladies and gentlemen, welcome to the second day of the 13th Annual Healthcare Conference. For those of you who are not here for the opening last night, my name is Ben Mead. I'm the Marketing and Communications Manager at Health City Cayman Islands, and it's my pleasure to be your MC for today's proceedings. Before we start, a few housekeeping items. We do encourage you to place your cell phones on vibrate or silent. We will have a charge of $5 for every ring that goes out loud, and we'll go to the volunteers who put on this lovely conference. We also ask that if you have to visit exhibits while the presentations are taking place, that we ask you to be mindful that presentations are taking place and the noise does travel from the hallway in, so we encourage you to keep it at a minimum and to respect the presenters as they are doing their thing. We're all here to hear the presenters, see the booths. Let's strike a balance. Our first presenter for today is a colleague, Dr. Ravi Kishore. Dr. Ravi has over 25 years' experience in the field of cardiology, and he's the Interventional Cardiologist, Senior Adult Cardiologist, and Electrophysiologist at Health City Cayman Islands. He will be presenting on the Holy Grail of Cardiovascular Risk Mitigation. Ladies and gentlemen, let's welcome Dr. Ravi Kishore.
Good morning, and I have the distinct pleasure, or I may say displeasure, of waking all of you up. I thank the organizers for giving me this opportunity to present a very important topic in the era of preventive medicine. It will be encompassing the cardiovascular risk and how to mitigate, what is the, where are we in terms of reaching this goal, and are we, how far away from this goal, and what are the factors which are possibly preventing us from reaching that goal in an effective time frame. I got it right. There is an ergonomic disadvantage. It's only the side screens which are available, and if I use a pointer on this screen, you will not know, so please bear with me. This is a workaround. So cardiovascular disease fundamentally is a very broad area. I mean, you have disease of the arteries, which is coronary artery disease. All of us know that, the blockages and heart attacks. You have electrical disorders of the heart, atrial fibrillation. You have aneurysms, so on and so forth. But the focus of this talk, considering the time limitation, is only going to be on what we call as atherosclerotic cardiovascular disease, which is a spectrum of diseases which arise because of atherosclerosis. And I'll be focusing only on the coronary artery disease part of it, not on the peripheral artery disease or the renovascular aspects or the stroke. The presentation objectives is we will be discussing the burden of cardiovascular disease in a general term, the global burden, the relevant epidemiology in conceptual sense, and what are the current strategies for the prevention of atherosclerotic cardiovascular disease, how do you assess it, and how do you screen people for the same? And what is the very important concept of residual risk, which is something which the main focus of preventive research in the heart area is on? And what are the newer targets? All of us know about the cholesterol, LDL cholesterol, but is there something which we are missing? So some aspects on the newer targets, and a brief overview on the calcium score, which is coming very rapidly into the realms of preventive cardiology. And finally, a small counterpoint on screening. Is screening providing all the necessary benefits we are supposed to have? And I shall conclude the talk subsequently. Now, coming to the burden of atherosclerotic cardiovascular disease, this is the 2018 American Heart Association statistic. This is focused on US. So this will just give us some idea as to what is happening in possibly the most affluent and the most with the best developed healthcare globally, and you can draw a parallel to the remaining regions. So heart disease continues to remain the #1 cause of death in the US. And coronary artery disease, which accounts for 50% of the heart disease, accounts for 1 in 7 deaths in the US, killing over 366,000 people a year. And the estimated annual incidence of heart attacks is 720,000 new heart attacks and 335,000 recurrent attacks. So approximately every 40 seconds, an American will have a heart attack. So this is the statistic in a developed, affluent nation with a very good healthcare. So this is really going to reflect on what is happening in the rest of the world. How do you focus it where? Oh, yeah. I'm sorry, this is a slide which really needs the use of a pointer, so people sitting there may not really know what is happening. Oh, I'm sorry. Okay, so this slide represents the cardiovascular disease burden across the time, location, cause, and the risk factors. This is a global statistic. Now, this is the global, so what it's showing is the change in the cardiovascular disease burden, say from 2010 to 2019, over a time span. What is happening? What you see in red here is where the disease continues to increase or become more prevalent. This is in small sections of the world where there is economic issues and population burden. You still see that there is an increasing burden. But in the rest of the globe, you are seeing a distinct reduction in the cardiovascular disease burden, which is important, which means that whatever we have been doing over the last 3-4 decades in era of prevention seem to be working. So there is a reduction in the mortality, in the number of deaths, certainly across the globe if you take on the whole. But however, the number of deaths keep increasing because the reason the number of cardiovascular deaths is higher is because longevity is more, and when you live longer, there are going to be deaths, and the commonest way you die is the cardiovascular. So in that sense, although the curve is quite shallow, the number of deaths are increasing, but overall mortality rate has definitely come down. And certainly, the burden is much more in highly populous countries like India and China. It's purely a reflection of the population dynamics and to some extent the economic burden. Whereas in the developed countries, it is certainly the burden is coming far lower. And if you look at the kind of cardiac disease which is responsible for the mortality, more than 50% is due to coronary artery disease, that is to blockages in the arteries of the heart, which results in heart attacks. And if you do the same statistic, examine the same statistic with respect to the risk factor burden, over the last few decades, what has happened is there is, the ranking of the risk factors has not changed significantly. It continues to be cholesterol, hypertension, diabetes, so on and so forth. What has happened is the smoking, the impact of educational smoking has certainly been very effective, and the smoking has come down, whereas one of the new epidemics now is the obesity epidemic, which is possibly becoming a very important risk factor in this whole scenario. Now, if you look at this slide, this shows the changes in the age standardized mortality rate and deaths. again, from 2000 to 2019. This is the WHO statistic. Now, what is obvious here is that, I'll just give you the summary of the slide. What you see on the left side is the age standardized mortality rate, and what you see on the right side is the deaths. Now, in most of this is basically examined as a globally low-income countries, middle-income countries, high-income countries. So it's basically based on the economic strata and the global data. Globally, there is definitely a significant reduction in the age standardized mortality rate. And although the deaths are going to go up because of the increased longevity. It's only in the high-income countries you have a distinct reduction in both the age standardized mortality rate and a reduction in the number of deaths. And this is a reflection of very effective healthcare, very effective preventive strategies, and very effective and timely intervention in cardiac disease. Now, in the Caribbean, I tried a lot to get the right, some kind of data, but unfortunately, I couldn't access the data. But what is available is, there is a statistic available on a 2015 publication that the Caribbean region is no exception to the global pattern, with a mean of 32% of total mortality per year from cardiovascular disease. This is all heart disease put in perspective. It is not just the coronary artery disease. The reason why we may not have accurate statistic is that the traditional risk scores which are used, which I will be alluding to in the next few slides, are not applicable in the Caribbean because this population has not been studied in the cohorts of the population which was used for deriving the screening scores. So we may not be able to use these screening strategies in the Caribbean. For that reason, the accurate data may not be really available. In fact, if you use these particular models, some of the traditional models like the Framingham, the Assign, the QRIS models, you could actually underestimate the risk of intermediate and high risk cardiovascular disease. Now, what is the preventive strategy which we are all familiar with? The entire credit for this, the concept of preventive strategy in atherosclerotic cardiovascular disease, should be given to the Framingham study, which very briefly, Framingham study is a longitudinal prospective study which is still ongoing. It was initiated by the US Public Health Service way back in 1948. And the cohorts are being added, the next generations are being added. And using that data, most of the risk scores have been derived. So the strategy is using these risk scores to assess the risk of an individual patient, individual person, or individual population dynamic. And once you identify the high-risk population, you target the risk factors in this segment. And certainly, whatever data that has come out from Framingham study and whatever it has taught us, all the issues on cholesterol, hypertension, diabetes, smoking, and the education consequently through the various societies across the globe, Cayman Heart Fund here, it's been a very good association between the societies and the public health systems to use these risk scores in giving an impact on the preventive strategies. So you target the risk factors, and that is what is going to help in mitigating the risk. Now, what are the traditional risk scores which are pretty popular? The most common is the American College of Cardiology, American Heart Association pooled cohort equation. This was derived from a cohort of population. All the risk factors were analyzed, followed up, and based on the disease pattern, they derived a scoring system, which is available online. It's an online calculator where you can feed in the data, and then that's going to give you a 10-year estimated risk of having a cardiovascular disease. So using that risk, you can target the patient's risk factors. So that is the basic principle. So, but this score is useful in US. It's not really applicable outside of US. Even in US, it's not applicable to the broader population of other ethnicities like Asians and Hispanics. So that is because the cardiovascular disease burden is ethnicity dependent. And so that is the problem is one size does not fit all here. There is a risk score from Canadian Cardiovascular Society, which is based on the Framingham risk score. It's a modified risk score. And the other one is the European Society of Cardiology has a score and a score 2 risk chart. I'm not going to go into details of the risk charts because that itself is a major talk. And I'm going to give you an overview of these, that's it. So the score chart has a particular advantage over other risk scores in the sense that it has factored in the ethnicities and the part of the economic status of the country. So there's been slight modification on the ACC-AHA risk score. And the UK uses the Q-risk tool to assess the cardiac risk. Now, what are the caveats of the risk scores? As I mentioned, the focus has been only on the traditional risk factors, what we know: hypertension, diabetes, smoking, cholesterol, obesity, and other minor risk factors. So maybe that provides only a modest discrimination for the atherosclerotic cardiovascular disease events. It can underestimate risk in a patient from different racial and ethnic backgrounds. The lower socioeconomic brackets, it can underestimate the risk, and it can overestimate the risk in higher socioeconomic group who have a very good access to healthcare and to preventive strategies. And a very important disadvantage of these risk scores is they have not taken the SDOH. It's an important concept currently. It's the social determinants of health, which play an important role in the incidence of disease. This briefly encompasses access to exercise, say you don't have enough playgrounds, access to good nutrition, access to good timely health care. So these are the social determinants and mental health issues. All these are very important influencers on the overall cardiac risk. And none of the risk scores have seriously taken the social determinants of health into consideration. So all these factors may be one of the reasons why your predictive ability using a risk score may not be perfect. So is the risk-based approach working? Okay, we are going through all these risk scores. We're taking an effort to sit with the patient, work through the risk score, calculate his risk score, tell him that, look, your 10-year risk is so and so. Is that working? Now, this is the data from UK. It's an old slide, but it gives a very nice view that the death rates from the circulatory disease in England from 1993 to 2000, there's a distinct fall. There is no question that there is whatever we are doing is very clearly working. Yeah. So, I mean, the way it's going, we should all be guaranteed to be immortal by 2026, which hopefully will happen. So this is a very, very important study, which I will spend a couple of minutes more than what I should. So this is again from that iconic Framingham database, which we have accumulated data of over 60 years now. So this, in this study, very recent publication, it examined the temporal trends in the remaining lifetime risk of cardiovascular disease among middle-aged adults across 6 decades. So what it did, just to give a simplistic, explanation for all this written. So they divided a cohort of patients in the last 60 years into 3 time zones called epochs. the first 20 years, the middle 20 years, and the latter 20 years. And they looked at the remaining lifetime risk. Now, what is remaining lifetime risk? It's a new statistical concept where you define the risk of developing an outcome over the remainder of one's lifespan at any given age. For example, when you do the ACC-AHA risk score analysis, you give the 10-year risk. Okay, you're not giving beyond that. So at the age of 45, at the age of 50, what is the risk of developing in the rest of his life a cardiovascular event? So this is what they focused on, and they divided the time zones into 3 and compared the changes in mortality in these 3 time zones. So what did this show? So this is the graph. It's very obvious from the graph. Now, what it shows here is that this is the first epoch or the first time zone. This is the first time zone. This is the second time zone. This is the most recent 20 years. What you can notice very clearly is that there is a definite reduction in the risk of dying. People do die. I mean, you have to die. So there are people. So your age of death is possibly going. It's getting delayed. What's happening now, but you still have a remaining lifetime risk. And this is very clear both to male, female, and to the whole population. So in spite of the fact that whatever we are doing is working, which is very clear from the data, it's not working enough. So to gain that immortality, we have to do something else. So that is what is the residual risk, the concept of the residual risk. Bear with me, yeah. So the summary of this particular analysis was that the life expectancy clearly rose by 10 years in men, 11.9 years in women, across the epochs, that's the time zones, whereas the remaining lifetime risk of ASCVD also declined between the time zones. However, what is important clinical implication of this analysis is that it underscores the need for continued and more effective primary prevention efforts with better screening for risk factors and lowering them more effectively for us to achieve that holy grail of immortality. So this is where we come to the concept of residual risk. Now, residual risk has been defined as the risk of cardiovascular disease events that persist despite treatment for or achievement of targets for risk factors such as low-density lipoprotein, cholesterol, LDL cholesterol, blood pressure, hypertension, glycemia, education on obesity, nutritional health, everything. I mean, once you have exhausted all this, you still have a residual risk. And this is, so what is responsible for the residual risk? Are we missing something? So the explanation, the possible theories. So the emphasis thus far has been on traditional risk factors. You know, like I kept on harping about hypertension, cholesterol, diabetes, smoking. It is so much in the lay media, the press, that all of us know about it. Everyone, you know, this is what all the executive health checkup screens emphasize on, and this is where you, when you see a patient and you talk to him about preventive, this is what you focus on. So were we doing enough? Was the LDL target sufficient? For example, you know, if you look at the lipid profile, are you happy with the LDL cholesterol with respect to the overall risk of the patient? And was the target low enough? Were we missing something in the whole lipid paradigm, which is actually a bigger influencer? And was the risk approach really accurate? That's what is the next few slides will focus on. So so then came the concept of the risk enhancers. When we realized that the conventional risk factor based approach was not working, slowly we started adding the risk enhancers. So what are some of these risk enhancers? So one of the very important risk enhancer, in my opinion and in my experience very clearly, is the family history of premature atherosclerotic cardiovascular disease. So this definition is ambiguous, of course. It's a man-made definition. So males, if you have a first-degree relative who had a premature cardiac event, heart attack or stroke, atherosclerotic event, it could be any of those. It's just not heart attack. Males less than 55 years, females less than 65 years, if you're first-degree relatives, mother or father. There is a primary hypercholesterolemia with the cholesterol consistently between 160 and 189. Metabolic syndrome. Metabolic syndrome is, again, a clinical situation where there is a combination of obesity, hypertriglyceridemia, diabetes, and hyperuricemia. So many, it's a constellation of factors fundamentally, but dominated by diabetes, hypertriglyceridemia, and truncal obesity. Chronic kidney disease with a eGFR of 15 to 59. Chronic inflammatory disease, this is really very, very important. You have a patient without everything else, all the risk factors are completely fine, but she's a rheumatoid arthritis or he is a rheumatoid arthritis, psoriasis, HIV, SLE. So this inflammatory component, which adds on to the risk, is something which we are understanding now very clearly. History of premature, I'll just discuss this a little more detail in the next slide. In the lady, history of premature menopause before 40, history of pregnancy-associated issues like preeclampsia, high-risk ethnicity, South Asian. It's a very high risk for coronary artery disease. We notice on the island, the population from Philippines seem to have a more severe coronary artery disease, more severe diffuse disease, and incidence of events much younger in their age. Lipid biomarkers, I'll discuss them in the next slide, and the social determinants of health. These are important risk factors. Female-specific risk factors is something which is, again, increasingly being emphasized now. The CVD is the leading cause of death of women in US and worldwide. And the recent data definitely suggests a stagnation in the improvement of this risk status, in the risk of deaths are not coming down. In fact, there may be an uptick in CVD mortality. Actually, after COVID, there's been an uptick in the female CVD mortality. The risk scores generally seem to overestimate the risk. One of the reasons is the representation of females in most of the studies which were used to glean the data for the risk scores had underrepresentation of women. And that is being addressed too in some of the new cohorts. And some of the very important female-specific risk enhancers are autoimmune disease, early menarche before 11 years, or early menopause. This definition is varying, some have 40, some 45. Polycystic ovarian syndrome, consumption of oral contraceptives, and very importantly, hormone receptor, the HRT. Infertility, grand multiparity, and adverse pregnancy outcome. These are all female-specific risk enhancers, and you should focus better preventive strategies in these ladies. So let's go back to the cholesterol, LDL cholesterol. From time immemorial, since I started my medical school, this has been the focus, and the data is very clear. The data is very clear. The graph is very clear. The lower the cholesterol, the risk of your coronary artery disease is less. This is proven across multiple statin trials, multiple databases, the Framingham study. So there's really no doubt about it. It's not a hoax. It's very clearly, in a lot of lay press, it's taken as a hoax, the whole concept of cholesterol and statin, but it's not true. It's a real. This is one of the most clearest data that we have got in cardiology, and possibly one of the reasons why there is a reduction in cardiac mortality is the knowledge that cholesterol and heart disease are linked. So were the targets appropriate? So in the sense that, all of you would be aware, earlier, way back, when we were starting people on statins, we used to use a target of 100 milligram per deciliter. And then came, the next year, it came as 70. When we realized it was not working, the LDL goal came down to 70. And when that was not working, the current goal is 55. That 55, the lower the better. The lower the LDL cholesterol, the better. So one of the reasons why there is the downtrend in the cardiac mortality is that the knowledge that you need to have, the cholesterol goal has to be lower than what used to be the standard for reduction. So this is again obvious from the recent studies. You could see that there is a very significant reduction in mortality as the LDL cholesterol comes down further. And there is no clear threshold at the lower end. Now, how low is low? How low should you go? You have people with LDL cholesterol of 30, 35, 32. Should we go to that level? So what the data shows, what the scientific data shows from one of the best data we have is from the Fourier trial. All of you have heard of the drug Repatha, evolocumab. So the Fourier trial looked at Repatha, and the people on Repatha had achieved a LDL cholesterol of even 30, 32 milligram per deciliter. And the mortality was clearly much lower in this segment of people without any side effects. So it's not just how low you go. What is also important is how long it was low. So here comes the concept of LDL burden. It is how long your arteries were exposed to high cholesterol is an important risk factor. Now let's say your LDL cholesterol, you have heterozygous familial hypercholesterolemia. Your LDL cholesterol has been about 140, 150 from childhood. So your arteries have been pummeled with cholesterol-rich blood for 40, 50 years. And that can be more toxic on the vessel wall. So that is the LDL cholesterol burden. How long and how low? So you have the target. So this is very obvious from this very interesting slide, which shows 3 different types of studies. This is a Mendelian randomization studies. No details, because it's a difficult concept to explain, except that you have a median follow-up of 52 years. It's a genetic-based analysis. This is a cohort studies with a median follow-up of 12 years, randomized controlled trials, which is with a follow-up of 5 years. You can see that the Mendelian randomized, the chance of you having a coronary event is very low as the follow-up is longer. So the longer you have a lower cholesterol, the chance of you having an atherosclerotic cardiac event is lower. I hope I conveyed the message there. So the risk reduction is based on the total duration of therapy. This is what is the summary. Again, this is a complex slide, but in general, what you notice is that if you have a lower cholesterol for a longer time, the chance of you not having an event is much higher. So you start early, you start the preventive strategy to lower the cholesterol early, decrease the LDL cholesterol as low as possible. Eventually, you'll really be able to reduce the risk of developing ASCVD. The goal of immortality by 2026, right? So what's the best time to start LDL lowering treatment? Really, we are not sure, but it is very obvious that you have a LDL cholesterol very high. So the guideline is if the LDL cholesterol is more than 190, it's a class 1 indication to start statin therapy, irrespective of anything else, age or anything. So it's a decision which is complicated. It's a shared decision making, but it's important to understand if you have to prevent an event in an individual, you have to identify the risk early on and start the treatment early on. So there are a number of strategies to control the LDL cholesterol. It's not just the statins. You have, I'm not going to go into details of pharmacology. It is just telling that there's been huge advances, with the latest advance being FDA approval of inclisiran, which is a drug which you can take once in 6 months, injected subcutaneously once in 6 months, and that is lowers LDL cholesterol to levels like Repatha. So this is some of the advances. So we have various options. I'm not going to go into details of the statin intolerance, which is supposed to be more of a myth than a reality, but that's a different session altogether, but I'll not go into those details. I'm not mastering this. Do I tell it to you? So, but the 50% of heart attacks occur despite normal cholesterol level, which is a question. You know, doc, I don't have any, I don't do anything, I have low cholesterol, I don't smoke, I don't drink, yet I have a heart attack. So this is a question which we keep getting asked, all the physicians. We get this retort from the patients. So what is my risk? So this is where the rest of the lipid panel comes in. Yeah, that's me. Where do I point this to? Oh, just switch it off. Can you put the slides back on, please? There's still 25 minutes of this harangue left. Okay, now this is a patient, our own patient, with a 60-year-old male with 3 PCIs in 2 years. I'm sorry, it may not be very obvious, but the LDL cholesterol in this patient is 27. It can't be lower than that, right? 27 on 40 milligrams of rosuvastatin, and yet he's had 3 angioplasties since 2 years. His lipoprotein A is normal, apoprotein B is normal. Everything seems to be normal except the triglycerides are a little elevated, 226. Can you move the next slide, please? Oh. Yeah, I got it here. So there is this residual risk now. So this is the study, Improve It study, which has shown that in spite of lowering the cholesterol to significant levels, you still have a residual risk. So the residual risk is due to increased triglycerides, elevated lipoprotein A, high sensitivity CRP, non-HDL, and other untreated risk factors. This is what has now not been noticed, and this is what is possibly responsible for the residual risk in spite of good, effective cholesterol lowering. So should we look beyond the LDL cholesterol? Are we missing something? Yeah. So a very brief lipidology lecture now, okay? So you have HDL cholesterol. We all know it's a good cholesterol. LDL cholesterol is what we are all taught as the bad cholesterol and is what is the main target for the risk. But is there something beyond the LDL cholesterol? So the concept is that there are a set of atherogenic lipoproteins which promote the formation of the atherogenic plaque. So these could be a lipoprotein little a, I'll discuss it briefly, IDL, this intermediate density lipoproteins, VLDL, and chylomicrons. So all these are what are called as a triglyceride-rich lipoproteins, and these are possibly responsible for the risk accentuation in patients with coronary artery disease. And if you look at the composition of the atherosclerotic plaque, the major component is possibly formed by the TGL-rich lipoproteins and lipoprotein A. LDL is contributing to a part of the plaque, but certainly there is a big contribution from LPA and the remnants. So beyond LDL cholesterol is what we are looking at. Now, in what way are the triglycerides really responsible for the risk. So very briefly, it's a very interesting concept. So the lipoprotein particle is transported in the transport mechanism. It carries one LDL particle for each protein. Now, if the particle is composed of triglycerides, there's less space for the LDL cholesterol. So which means more particles had to be there to transport the LDL cholesterol. And the more LDL circulating is what is going to produce the toxic impact on the vessel wall. And ApoB100 is another structural backbone of the lipid complex, which is what, when measured, it possibly may give a better reflection of the atherogeneity of the blood rather than using the LDL cholesterol alone. In fact, if you have a patient with high triglycerides and you measure the ApoB100, the population, say the patient with a high triglycerides and ApoB100 is going to be at a higher risk than the patient with a high triglyceride and a lower ApoB100. So this is indicative of a high atherogenicity. And raised triglyceride concentration are therefore an additional risk, causal risk for cardiovascular disease. Inflammatory components of atherosclerosis are modified by the triglyceride-rich lipoproteins. Elevated triglycerides associated with higher CV events and overall mortality in large Italian cohorts at low moderate CV risk. This is a recent study based on which triglycerides are coming back into fore. And in a large statin-treated cohort from a Copenhagen general population study, elevated triglyceride-rich lipoproteins levels were associated with much higher mortality. So some non-traditional risk factors, drivers of arterial inflammation, is the summary of this slide, where the triglyceride-rich lipoproteins are possibly the drivers of risk for the active atheroma or the acute coronary syndrome precipitation in some of these patients with normal LDL at recurrent cardiac events. Now, what is lipoprotein A? See, lipoprotein A is a type of lipid which is actually a combination of apolipoprotein A, apolipoprotein B, covalently bound to the LDL cholesterol. So very briefly, it's a very complex molecule, and we still are not sure whether we are measuring it correctly, whether the measurement techniques are accurate. But what is clear is that it's genetical. So one-time measurement is possibly enough, and a high lipoprotein little a is definitely an important contributor of cardiac risk. And the recommendation is that in the lifetime, every one of us should measure the lipoprotein A at least once. And this is the most irritating part of it. Yeah, I'm sorry, yeah. So the lipoprotein A has shown a very clear risk association with aortic valve stenosis, heart failure, total cardiovascular mortality, stroke, peripheral arterial disease, and all the cardiovascular events. And this is the UK Biobank study, which has very clearly shown the association of LPA with cardiovascular disease, fatal cardiovascular disease, coronary artery disease, stroke, at a level of 70 milligram per deciliter. But what is recommended is if it is more than 50 milligram per deciliter, it is possibly a higher risk, and you have to target all the risk factors very aggressively in this patient. So the recommendation is LPA measurement should be considered at least once in each adult person's lifetime. So can we treat elevated LPA pharmacologically? Unfortunately, we don't have a drug for this. Possibly niacin, as studied in Denmark, might make reduce LPA by about 10 to 15%, but there is really no drug which has clearly been shown to impact LPA. So in summary, we have, in terms of the lipid management, what are the targets? So you have in the residual risk, you have the residual cholesterol risk where the LDL target should be as low as possible, maybe 55, not just 100. There's a residual inflammatory risk, which is assessed by measuring the C-reactive protein. I have not gone into details on that because of the time issues. So CRP more than 2 milligrams is possibly a risk factor. And the residual thrombotic risk, it is there, but we don't have a biomarker asset, and that's one of the targets of the current studies. However, for the residual thrombotic risk, if you look at some of the disease studies on the peripheral arterial disease, the rivaroxaban low dose has been used to prevent this component of the risk, but it's not been proven as yet in large randomized controlled trials. The residual triglyceride risk, triglycerides more than 100 is taken as a risk, but I think that's too low, maybe 150, 200. You have a new drug which has been, which is now FDA approved and widely used in US, Vascepa. It's a purified form of a fish oil. You need to take 4 grams per day, but that is one of the drugs that is being touted as an important therapeutic option to reduce the residual cardiac risk. And the residual lipoprotein A risk, we don't have a proper medicine, but when you see a patient with a high LPA, you have to modify every other risk factors appropriately. So a lot of people who have high LPA get into panic, but we have to try to assure them that just what it means is that you have a higher risk and just manage all the risk factors appropriately. Well, is the battery not working in this or something like that? Okay. And a brief discussion on coronary artery calcium. All of you are aware that it's a very important screening tool now. Coronary artery calcification is fundamentally contributed by smooth muscles of macrophage apoptosis. This is the hallmark of atherosclerosis and consequently ASCVD. And a coronary calcification detected on imaging is a surrogate of a plaque, atherosclerotic plaque. As you can see on the CT scans, it's a very simple test done in few minutes. And it's an ECG-gated study, and the calcification burden is a reflection of the other plaque burden. It only means that you need to be more aggressive in risk factor management in these patients. And there is a strong correlation between the coronary artery calcium and the atherosclerotic plaque. So as the CAC increases, the plaque burden is more, which only means, it doesn't mean that you have to subject him to a stress test and angiogram and other things. It only means that you have to tackle his risk factors more strongly. So on the CAC, the current role, it's an important risk enhancer in people with borderline ASCVD risk. So you have a patient with a strong family history, he's 45 years, he's concerned, he's mildly elevated cholesterol. So you can use calcium screening to assure him that his risk is low. It can also be used as a guide to initiate or de-escalate aspirin or statin. It can be an important motivation tool in statin cynics. You know, people say, I'm not going to take statin, come what may. And his calcium score is 1,000. You can sit across the table and convince him, look, to reduce your chance of having a heart attack, it is better to take a statin. And it can also be, you can use it to de-escalate. You have a person with a 140 milligram cholesterol. You're not sure whether you should give him statin. If the calcium score is 0, you could possibly avoid giving a high-dose statin to this particular patient. But it's important to understand that CAC alone cannot be used as an indication for stress testing or invasive angiography. And a 0 coronary artery calcium is an important negative risk factor, especially in males. Not so sure about females, because I've seen ladies with a 0 coronary artery calcium having cardiac events. So this is coming to the guidelines in patients with intermediate risk of ASCVD by pooled cohort equations. CAC can be used to reclassify the risk upward or downward, and it can help in deciding whether we should give him aspirin or give a higher dose of statin, lower dose of statin, or no statin at all. So this can be skipped. So now, are we on the right track? Now, this is again a very I'm sorry you're not, I don't think you are able to read it very clearly, but in summary, this is a very recent publication, just this year, Don Kava's trial, done in Denmark. And Denmark is very famous for doing highly eponymous cardiovascular trials, beautiful trials. They have wonderful medical care, wonderful medical system, very organized healthcare system. And so they analyzed 2 sets of people. They subjected one group to extensive cardiovascular screening, having ECG calcium scoring, ankle brachial index, checking for lipids, sugars, and there was one with usual care. And at the end of 5 years, what they found was something which will shock the administrators who we like to do executive health checkups and make a lot of stuff, right? Yeah. So that there was no difference between extensive screening population and people who are not screened. So the extensive cardiac screening possibly did not contribute to reduction in mortality. There were some caveats in the study. It included predominantly male. There were very few females. They gave an explanation for that. And maybe it was not longer enough term. But however, the message from this trial is very clear, that random screening may not be beneficial. So maybe you should target the screening to certain high-risk populations and use the data more intelligently rather than on a knee-jerk fashion. So conclusions, ASCVD is a complex syndrome affected by several factors which we discussed. Traditional risk scores form a foundation to establish a baseline risk for ASCVD. They give you a good information. Significant improvement in ASCVD prevalence and mortality statistics, but the residual risk exists. And the residual risk can be addressed using the risk enhancer concept. We are so near, it's so far from the Holy Grail. Yeah, that's the usual thing. Thank you very much. It's a nice Jamaican prop. So don't fall for all the stuff you hear. Huh? Thank you very much.
Now we move on to another important topic and an element of science that can be quite fascinating. Dr. Lundie Richards and Mr. Jonathan Smellie will be presenting on genomic sequencing for cancer diagnosis and therapy. Dr. Lundie Richards is the consultant medical hematologist, oncologist, and Jonathan Smellie is the principal molecular biologist for the Cayman Islands Health Services Authority. We do invite you, gentlemen, to come on up for your presentations. Let's welcome them. Just making sure we have the clicker all sorted.
Is there a laser pointer?
Pardon?
Is it laser pointer? Yes?
Yeah.
Okay, cool. Okay. Morning, everybody. Sorry to introduce a topic like this before 10 a.m. My name is Jonathan Smellie. I'm the principal molecular biologist and co-founder of the Cayman Islands Molecular Biology Lab. And I'm here with Dr. Lundie Richards, consultant hematologist and specialist oncologist, to discuss the implementation of cancer genetic locally in the Cayman Islands for the first time. So let's get started. Right here. Okay. All right. So to kind of ease us into this, this is a kind of graphical representation of the entire genome, right? And since about 2001, this is really what we've been interested in studying. So you have here all 23 chromosomes, and within those chromosomes, if you get a bit deeper, you have nucleotides, which are the individual letters, the A's, T's, C's, and G's that everybody is familiar with. So in our genome, we have 3 billion of those letters. And between each and every single one of us, we have a difference of about 4 to 5 million letters. So that's what makes up the variation that you tend to see between people. So your height, your hair color, all those different phenotypic characteristics that we easily identify. And those things can also be related to our clinical outcome as well. So that's why we're interested in studying those particular differences. So to go a bit granular, those differences are called in our field a single nucleotide polymorphism, right? And single, meaning the individual base letter, nucleotide, of course, and then polymorphism, a difference. And you want to look for ones that are common within certain subgroups of the population, depending on the disease. So we have common single nucleotide polymorphisms, which are ones that have at least one per 1,000 people in the population, and it's greater than frequency in that population than 1%. So those are not necessarily implicated in the disease. You can assume that because they're in healthy people as well. They're really highly represented in healthy people. And then if you're looking at a subset of individuals with a particular condition, and then you're able to pull out single nucleotide polymorphisms that are associated with that condition potentially, that's what we would call a variant that's associated with that condition. So what are the different types of variant? The different types, these are just 4, which are somewhat digestible. So there's a missense mutation. So you have your base pairs at the top there, your nucleotides, and they're read in codes of 3. And those 3 create amino acids, and those chains of amino acids are put together to make proteins. And proteins are really the functional components that drive all the different processes within your cell. And so you have here at the top, which is what you'd consider like the wild type or the reference, and you see that it creates these different histone proteins, and then you have a change in those nucleotides that leads to a different protein being, or amino acid rather, being made. And that's a missense. You have a deletion where you'd have a removal of that nucleotide, and then those 3s are read differently. So all the things downstream from that are different, all of those different amino acids, right? You have an insertion, which is what the name suggests. You have an insertion of a different letter, and then that also changes the way in which amino acids are read. Then you have nonsense mutations. So you'd have perhaps a change that tells the enzyme that's reading that DNA to stop reading and just create the protein at that point. And that can lead to a shortened protein, and that's generally something that's implicated in disease, because if you have a shortened protein, it's not functional. If it's not functional, it's going to probably create problems. So what is cancer, and how does cancer relate to what I just spoke about? Well, cancer is actually a genetic disease, and this diagram really is the result of a lot of very impressive work by Hanahan and Weinberg, published in Nature, and it shows all the different genetic components to the development of cancer. So you need all of these things to be happening for a cancer to start, and that's why cancer is such a complicated disease to treat and understand. So it's caused by the changes in your genes which control the way your cells grow and multiply, and you'd see here some of the easier to understand ones are growth suppressors. So there are certain built-in functions in your cells that prevent those cells from growing uncontrollably. And when there are mutations introduced in those processes, then they break down, and they're no longer suppressing the growth of those cells. And then you have immune destruction. So generally, immune cells are really good at identifying cancer cells. But in certain cases, when the profile of that cell may change due to mutations, the immune cell won't recognize it anymore and won't get rid of it. Then you have genomic instability, mutation. So for example, you have ultraviolet light that creates damage in your DNA, and the way in which that damage is repaired may be incorrect, and that will introduce mutations and cause those problems. Right, so you can see that cancer is a really hard thing to tackle because there are a lot of things going on here. So kind of to come back out a little bit and reframe it, what is genomics actually? So genomics is the study of the entire set of genetic information from an organism, right? So all of the letters, all of the chromosomes in that in the individual or person. And so genetics is the study of a subset of genes that then go on to perhaps be inherited, and this individual composition and how they actually work in particular processes that you're interested in. So genetics has been around for a long time, and genomics has really only started from the completion of the Human Genome Project, 2001, and all of this detail that we're unpacking about different diseases and correlations and risks and so on have come from that work. So how does that actually happen? Like, how do you even start that process? And really, it starts with, ideally, blood. You get a blood sample from a patient, and then you want to purify the DNA from that, and then you start the process of preparing it for sequencing. So that there is actually a sequencer. It's an aluminum iSeq. It's an instrument we have in the lab, and that is used as a gold standard for clinical sequencing. And so once you put it onto that instrument, it can run for days in a lot of cases, and it's going to produce a huge amount of information about your genome. And that information looks like this. So once the instrument is satisfied that, you know, a T or a C or an A or a G is where it says it is, right? That's that quality assurance aspect. You then have to align all of these different things, because the genome is read and then sort of read into chunks, and then you have to stitch them together. And to make sense of that, you take you download data from the national databases that would have the reference of what you're putting this alignment to, and then you can say, okay, this part of the genome is here, and this part is here, and so on. So you're able to compile the actual genome that you've sequenced. And once you do that, you then look at the differences. So I mentioned before, you have 4 to 5 million differences between individuals, right? And that's what we're really interested in. So those are called variants, and variants are put into a file, and then that's your end result, your variant call file. So that's just the second step. The third is that you have to interpret this now. So this is a very, very rigorous process, and it generally involves a lot of clinicians and a lot of scientists, and you look and interrogate genetic databases, literature and research, do statistics and modeling, and your phenotypic data from your medical healthcare records. And the idea is that you can look and see trends and say, okay, we have this individual, they present with this particular disease, and they have these mutations. Now, is this something that a group in the UK or Australia or Canada are also seeing? Is there a relationship there? Remember I was saying earlier that you have certain polymorphisms that you find within a subgroup of diseases. So a really strong relationship that maybe a lot of people know about is ankylosing spondylitis and the HLA-B27 mutation or variant that has a very, very strong association with the development of that disease. And so something like over 90% of persons with that disease have that mutation. And so it's suggestive that this is involved in the pathogenicity of that illness. And once you bring all of those people together in a multidisciplinary team meeting and you discuss those findings in the context of the phenotype and the presenting illness and maybe other aspects, then you're going to make a report and a diagnosis. And from there, you can identify possible treatments, potentially go to clinical trials, or you may actually find no association at that point in time. And that's one of the difficult things about this work, is that it's always evolving. Just because you can't see a relationship right now doesn't mean in a year's time there won't be that association between those variants you've initially discovered and the presenting condition. So you have to go back and review this work to make sure that that's actually still the case. So where I was trained, this is the workflow of how this process starts. You have individuals who present at the clinic, usually to a medical geneticist, and what they'll do is provide a suspected genetic disease diagnosis and order tests. And those test orders come to us, the clinical scientists, and then we do that process I just described, and we generate a report that takes, on average, about 2 weeks per person, even when you have lots of people involved. It's because you're potentially, depending on the amount of genes you're looking at, millions of genes. And you have to classify all of these, millions of variants, I should say. You have to classify all of these variants on their pathogenicity with respect to the condition. Once you do that, you generate a report, and then you sit down with all of the physicians involved, and then they go for genetic counseling if that's available. So how is this related to cancer? Because this is more of a broad level. So these are all the different structural variations within a genome that can lead to cancer, right? I spoke about some of them. So for example, repair mechanism disturbance, when you have sun damage or environmental damage that causes DNA to break apart, and then the repair of that introduces problems, and then that can develop cancer, like for example, skin cancer. And we want to look at all of these things and see how potentially, if there are particular mutations, stroke variants, that drive the development of this cancer. So you can take some genes from that tumor, and you can look and see what genes are being upregulated, expressed, what proteins are being expressed in large volume, what pathways are actually being pushed in this cancer. And you can say, okay, these genes in particular, because of these variants, are driving that cancer. And that can help actually to choose your therapy in a lot of cases. You can look at tumor evolution. So one of the things is unchecked cell growth. And because of that, you'll have mutations also introducing from parent cell to daughter cell. And you want to see how that tumor is evolving, because you could potentially predict how it's going to look genetically at a certain time point. And that will also tell you about the mutational processes within those cells. And so in certain cases, one of the strong associations with cancer and genetics is in hereditary cancer, right? So we can use genomic sequencing in establishing a predictive model for whether or not someone's going to develop that disease. And so you have here a case study where you'd have an individual patient, early age at disease onset. You have multiple primary cancers in the same organ, multiple primary cancers in a different organ perhaps, and maybe it's related to gender, maybe not. In a patient's family, you'd have 2 or more first-degree relatives on the same side of the family, cancer of the same site, cancer types belonging to a known hereditary cancer syndrome. So those things suggest a hereditary cancer, right? So the first thing when those people present to the clinic is you do a pedigree, and you would see, are you picking up these patterns? And then you would want to look at not the cancer genome necessarily, but that individual's own DNA, because you want to see, is there a hereditary aspect involved in this? And so this can take the form of a multi-gene panel, oftentimes, and you group genes together to look into, because they're associated strongly with the development of the disease, of course. Now, panel science is quite a difficult thing, because you have to review a lot of literature and say, okay, these genes are involved, but not these ones, and then that may change over time. So it's a very fluid science. But you don't want to look at everything, because you could find things you're not looking for, and that can cause other ethical issues, right? So one of these things as well is you group panels on what are called high penetrance genes. So high penetrance genes are essentially, if you find a pathogenic mutation within a gene that's high penetrance, it's a high likelihood of you developing the disease, right? So in some cases with BRCA1 and 2, it can be upwards of 80%. And so that gives a good correlation between something predictive and perhaps taking intervention after the fact. And so this is some work published in Nature, in Genomic Medicine, where they were looking at a cohort of 636 patients. And what they were looking at are all of the genes in those person's genomes that create proteins, right? And if you look at B, that circle there, that's a representation of the different types of mutations that are identified as pathogenic and likely pathogenic, right? So I spoke about some of those, like missense mutations and nonsense mutations, et cetera, right? You can see that there's a lot of pathogenicity, meaning that these mutations being present are going to lead to the development of that disease. In mutations that are start loss, so when the genome is being read, an enzyme has to come and bind and then start that process of making those amino acids. If it doesn't even start in the first place, you're not even gonna have a protein, right? So it makes sense that you're gonna have development of disease if there's no protein to do its normal function. And then you have a breakdown here of the most commonly mutated genes, which are shown ranked from bottom to top, right? So we recognize BRCA1 and 2, there's CHEK2 that's often involved. A lot of those are very, very classically associated genes with the development of certain cancers. So it's kind of no surprise, but it's interesting to see it like that. And then, of course, on this bar graph here is the fraction of pathogenic variants that were calculated for each cancer type. So you have mesothelioma, ovarian, and cervical cancer right up there. And again, it's a really good study because there's a lot of power. There are a lot of numbers in this cohort, but it's also telling us something that we really know. So what do we currently do? Well, currently at HSA, we send off all of our tests, just like the rest of the healthcare industry in Cayman. And we're really sending them off for these two tests. So Oncotype DX and MammaPrint in particular. And Oncotype is looking at breast reoccurrence score, right? And analyzes the group of genes that can affect how early stage breast cancer is likely to behave and respond to treatment. So this is not merely just looking to see the presence of variants and so on, but it's also to see how highly are these genes being expressed in this cancer. So these two tests look at the cancer itself and the genetic components of that cancer, whereas the middle one is looking at what is called your germline, which is your own DNA to assess your risk for the development of cancer. So it's more predictive, right? And that's BRCA1 and 2 in particular. And MammaPrint looks at an activity of 70 genes and then calculates a reoccurrence score that's either low or high risk. And so that leads me to where we're heading with this. What's the plan? So we're going to be providing local genomic analysis for the assessment of risk for the developing of certain types of cancer for the first time ever in the Cayman Islands. And that means that complex analyses will be provided faster, cheaper, and with greater local expertise than ever before. And we recognize that this is a whole healthcare effort, so we're working very closely with all the individual stakeholders across the island to deliver this. But this will mean that we won't have to send off our samples anymore, and we'll be able to interface with the physicians in greater detail, and so you can get more insight and a better healthcare outcome for patients. So thank you. Thank you very much.
Thanks. As we get set for the next speaker, there are a few cars that are blocking other vehicles. A white Toyota Mark X, 198563, 198563, a white Toyota Mark X, and a Honda Fit rental car, 189563, 189563. If that's your vehicle, can you please move it? You're blocking others.
Thank you. Good morning, everybody. And thank you to the organizers for putting this important forum together. And of course, I want to single out Brooke for making our slides very pretty. Jonathan, you did an excellent job, and I don't know if I can follow on you. So as we move in talking about genomic sequences, we talk also about the whole aspect of precision oncology or precision medicine. I have no real conflicts, but Jonathan spoke about the missense and the nonsense mutations. So if you see any misspelling, it's only there deliberately that you will understand the concept of missense, nonsense mutations. It's important for us to recognize that no two persons are the same. We're all unique, and so are our cancers. Cancer is multifactorial. I think Dr. Ravi earlier on mentioned something about people who have normal cholesterol and say, but why did I get a heart attack? It's the same. You know, I don't smoke, I exercise, I eat well, I do everything right, and I'm still diagnosed with a cancer. Well, it's specifically because of the multifactorial nature of the genesis of cancer. And we can see a number of things there. And this is only a touch. There are several other things that are implicated in cancer: tobacco, chemical carcinogens, other environmental things, radiation, aging, obesity, diet. All of these have some form of implications. So therefore, we know cancer, like other chronic non-communicable diseases, they continue to pose challenges globally. People still present to healthcare with advanced cancer. So we know it's a challenge. And the whole aspect of genomic testing, which is important in terms of both diagnosis, prognostication, and so on, it's that many times it is not easily accessible depending on where we are or because of insurance coverage. And of course, when patients present extremely late, then you really question what may be the utility. And there, of course, the whole aspect of having precision treatment to ensure that once we have diagnosed the cancer, we know specifically what to use in that particular patient. So I will take us back. We remember the days when we were running around in the 1920s, correct? Those were the days when the main treatment option for cancer was really radiation therapy. And in those days, those radiation therapy were destructive, right? But by the early 1940s, there was introduction of chemotherapy. And even today, people are afraid of chemotherapy. But I can tell you that it has improved over the years. So at the turn of the century, we began looking at targeted treatments. And of course, the buzzword nowadays is immune therapy. Several patients come and say, "Doc, put me on the immune therapy because somebody says that it is easier, it is lighter, and this and that." I know Dr. Google is always telling you about the different things. So what is important along that line? It is to recognize that there's no single silver bullet in terms of therapeutics, and we have to analyze each patient as he or she comes along so that we can strategically target that particular person's cancer. Just like how nowadays we have all these, when we see war happening, you know, you can sit in a war room in country X and send off something in another country, right? So that is how we want to treat cancer, to be precise. Okay, I'm going to have just two short case discussions, and at the end of the day, I'm pretty certain you'll understand and say whether or not these two patients would benefit from genomic testing. One is a woman, XX. She's 43 years old, and she was diagnosed with bilateral breast cancer at the age of 35. She had bilateral mastectomy, and she completed the conventional chemotherapy, immune therapy, endocrine therapy, based on the histopathology, what the pathologist reported on what was seen, and the immunohistochemistry. This woman has had multiple recurrences over the years between 35 and 43. And she has basically exhausted all lines of treatment. However, she continues to have very good performance status, and so therefore we know she has a will to live. Then our second patient is a young man, Mr. XY. He's 36 years old. He presented because he was just feeling weak and his energy was gone. He was diagnosed with iron deficiency anemia. He admitted that he was passing blood via rectum, which he thought was because he had hemorrhoids. He's a smoker, and he had colonoscopy which showed polyps, multiple polyps in the colon. He has a very strong family history of cancer. His father died at 45 from metastatic colon cancer. His uncle, his father's brother, currently has colon cancer. And his grandfather died of metastatic prostate cancer. Now, Jonathan mentioned that cancer is really a genomic condition. If we look at all those little small oval-shaped circles, we'll recognize that every aspect of cancer has to do with some form of genomic or genetic change. We look at cancer from a point of view from its genesis, from why is it that a patient who is doing very well on a particular treatment strategy today, and by the end of that 6 months of treatment, the cancer has suddenly progressed. It means that there has been a mechanism for resistance, and that resistance may be because there's been some mutation. Even while that same cancer is going on, there might have been some kind of change, whether it's nonsense, missense, whatever sense it is, or anything of the sort like that. Good? I'm no better than Dr. Ravi. Good. And I think Jonathan went through this slide. There are about 4 different types of genetic or genomic changes that can go along, and I'm not going to elaborate on that. If not, Jonathan is not going to be happy. Good. So there's been a paradigm shift in cancer, and this is because of genomics. The important thing to recognize is that cancers may be diagnosed much earlier. With the use of genomics, there is the whole aspect of giving prognosis, the whole aspect of developing targeted treatments. Those are critical because you would want to know that once a cancer is identified, we know specifically what treatment strategy to use. And that's the whole aspect of genomic and precision oncology. Now, precision oncology, as we see there, we have precision medicine, precision oncology, precision this and precision that, right? It's really about ensuring that we make the right decisions at the right time about the right patient who has been diagnosed with a cancer, right? And of course, genomic sequencing holds the key to that. There are several different packages of genetic tests that can be done for different cancers. And we hear about next generation testing. Just Google it, and you get a whole barrage of different things, right? And it's about understanding what are these various genetic or genomic markers, what are those changes, those nonsense, missense, all those senses that can go along that are particular characteristic of certain cancers. It's important to also recognize that even with cancer A, you may find the same changes also in cancer B, right? And they're 2 different cancers. So sometimes some of these changes are not necessarily for one particular cancer, or even inherited things. So everybody knows about BRCA gene. BRCA, find it in breast, prostate, ovary. So you can go along and see what we're talking about. So genomic testing allows us to really, really target those particular drivers, those things we believe are really what make the cancer occur, right? And so therefore, targeting those drivers is really precision medicine. Within this, we talk about tumor biomarkers, and they talk about some of these proteins that may be expressed, whether they're in the cell itself, whether they're on the cell itself, whether they're in the cell membrane, whether they're on different organelles within the body. And some of these that are used nowadays include things like tumor mutational burden, which is looking at really the quantity of those changes that are on the tumor. And I'll demonstrate in a little while why that is important. And also what was spoken of earlier on about the instability, microsatellite instability, and the importance of understanding these, especially in cancer that has spread, we call it metastatic cancer, is that we can effectively use immune therapy to treat these conditions. Good. So I spoke about tumor mutational burden. It's just a quantity of those changes that are seen on the tumor. And of course, as we see there, immunotherapy plays an essential role in managing those patients who have a high burden, a high quantity of tumor mutations. Good. So we talk about microsatellite, and I'm going to attempt to use this. So we see on the left these nice gray blocks set up nicely here. These are all repetitive genetic fragments. But over here, in another language, we call it chaka-chaka, right? Over here, we can see them all over the place. It's really demonstrating the instability, right? But, of course, these are tumors that will respond to certain forms of immune treatment. If we go back to 2004, at the end of 2004, for lung cancer, there were only 2 noted genetic markers or genomic markers, right? But by the end of 2017, there were over 25. And 2007, may I remind us, was about 5 to 6 years ago, eh? So by now, I'm pretty certain that there are many, many more markers. But if we look at the bottom of the column on the right, we still see that there are still a number of lung cancers that we're yet to determine what are the genomic or genetic changes that are seen. So, all in all, we clearly agree that it's all about understanding what is the cause, what's the driver. If you do not know the cause, then it makes it difficult to target treatment, right? That is all. And in the middle, we find genomic testing and genomic profiling, which is able to package that to us, and most times, or sometimes at least, point us to where we may be able to do precise treatment. Good. I spoke earlier about tumor mutational burden. Now, if we look in the red on the top, we see some different figures. But what that goes to show is that patients with high tumor mutational burden, and though they are treated with targeted treatment, they are more likely to respond better, right? We find that the response rate is really 3 times higher in those with high tumor burdens and who receive targeted treatment as opposed to those who do not get targeted treatment. As we look at the middle, that looks at progression-free survival. That means that how long do patients remain in a kind of a remission status where the disease does not move on. And you see, again, it's about 4 times for those who are not. And on the extreme right, one piece of information that is very, very important. With some forms of targeted treatment, the overall survival has not yet been reached. So science and the role of genomic understanding has made that very, very important. So cancer is no longer a death sentence. It's just a phase in life that we need to address, like how we address hypertension and diabetes and so on. So, do we throw away conventional molecular diagnosis? Of course not. We cannot throw it away. And especially it depends on what our economic situation is. They continue to play important role. We're talking about immunohistochemistry, in situ hybridization, PCR, and I'm pretty sure everybody in Cayman Islands knows what PCR is, right? And Mr. PCR is, of course, to my left. So, but if you look at the red lines at the bottom, it tells you that with the conventional molecular diagnostics, there are still some gaps. And those gaps are simply because we miss some of those drivers. And so that's why we have to move on to the next phase of ensuring that we adopt the whole comprehensive genomic profiling to be a reality in today's clinical practice. It's not easy, but it is something that I think we should all move towards. Because having comprehensive genomic profiling gives most of the answers. And I said most of the answers because you'll find in another slide later on that it may not give every answer we're looking for today. So this slide, and I have no interest in Rush and Foundation Medicine 1, but it's important for us to recognize there that with using the next generation testing in foundation medicine, where either a piece of the cancer tissue is tested, that's the one in the orange, or from the blood, the blue and the red, where the genomic testing can be carried out looking for over 300 cancer genes, right? So it is a reality, and especially the one in the middle and to the right, where, for example, somebody has a cancer which is deep inside the abdomen or deep inside the chest. It would be an invasive procedure to be sticking a needle in to actually take out a little piece. It is not an easy walk in the park, but with a simple blood test, one will be able to look at some of these cancer DNA markers. Now, there are several cancers. If we look on the extreme left, we can see the names of many, many cancers: bone, kidney, liver, nervous system, prostate, cancer of unknown primary, pancreas, breast, and so on. All of these have some form of genomic change. But if we look to the extreme right, we also recognize that there are matching treatment options for these. So the whole aspect, the revolution of genomic medicine has given rise to precision oncology, which is very, very, very important. Because again, as I mentioned, we want to make sure that we treat the right patient with the right stuff at the right time. Lung cancer has been one of those that they have had a lot of research on. On the left, we can see the numbers of genomic changes. But a big proportion of lung cancer, 30% of them, have not demonstrated any particular change in their genome to date. I'm pretty certain that when I get a little bit older, there will be more of these, as was pointed out in my earlier slide, right? Now, if you look on the extreme right, we will see some different headings. And each of those headings refer to particular genomic changes and what are the different treatment strategies for lung cancer. Just to divert a little bit, some months ago, I had a patient who presented with a metastatic cancer. Wasn't sure where it was coming from, had a liver biopsy, and then my dear pathologist said, "This looked like lung cancer." I said, "Okay, fine." Sent it off for genomic testing. And then I got a call from a lab somewhere in the States saying, your patient have a RET positive cancer. I'm going to send and tell you which drug you should use. But it was very exciting because that particular type of genetic mutation or genomic mutation is not regularly seen. And to treat that, it's a specific type of drug that has to be used. We all know about breast cancer, and everybody of us here today has known somebody or have a family member who has had breast cancer. We know these ones that are hormone positive, hormone negative, or whether or not they carry the bad HER2 marker. Breast cancer, as well, as we can see there in the donut, carries a number of mutations, right? One of the frequent, I think Jonathan mentioned the whole thing about the BRCA mutation. This is what is inherited. And of course, I mentioned earlier on, BRCA mutation not only has implication for breast cancer, but also have implication for other cancers, including pancreas, prostate, right? The BRCA gene, we have two BRCA genes. One is on chromosome 17 and one is on chromosome 13, as you will see there. Colorectal cancer, same story. There are a number of mutations, and yes, we go beyond just sending samples, patients with early breast cancers, where Jonathan mentioned, we send them off to look at specific mutations that may allow us not to, or tell us if that person will benefit from chemotherapy. It's the very same way for our colorectal cancers. We do send off and we get different mutation analysis, which guides us as to what therapy to use. The other thing which I find particularly interesting is, of course, prostate cancer. And you might ask, why have I gone through these specific cancers? Because they're the most frequent ones that we treat every day here in the Cayman Islands. And prostate cancer is now becoming the order of the day that somebody who presents with prostate cancer, we should probably do some form of genomic testing, because that become the order of the day, right? And as you can see in the red, one of the biggest mutations we find is actually BRCA, right? Now, there are implications for that, and I think if those who were here last night would recognize that what do we do with some of these analyses when we get them? There are certain ethical implications for doing genomic testing, but that's for another day. So I put this slide there because I want us to recognize this is not just, sporadic ideas. There have been several research that are carried on. This is just one of the research looking at, again, providing the evidence to demonstrate that when these genetic or genomic changes are seen in the various cancers and they have targeted treatment, then the survival and possible remission is much, much higher than those who do not get targeted treatment. And I mentioned earlier the aspect of using blood to search for some of these cancers. Cancer is found anywhere in the body. And, there's a good senior person every morning on the rounds. He says, life is in the blood. He shall remain nameless. But what happens is that the blood and the lymph bathes every single tissue in the body. And in doing so, the cancer, although it may be at position X, but by bathing the cancer, then either the cancer cells themselves or cancer cells that are pegged onto other cells, whether they're pegged onto platelets or white cells, those are washed into the bloodstream, and that's the reason why it's so important and easy to use. Easy to use those DNA samples from the blood to look for it. Advances have been much more beyond the blood, and of course we'll see in other aspects, for example, using buccal swabs, one may be able to diagnose certain genomic markers that may be related to some cancers. And certainly, for example, even in colon cancer, the use of stool sampling to look for certain changes. So genomic testing and cancer diagnosis has been evolving. Now, since you asked me about those two cases that I presented, I will give you the answer. Case XX, XX means female, by the way. So case XX, she had a metastatic cancer, good performance status, but we're near to the end of the road in terms of options. I definitely believe that she would benefit. Case XY, of course, XY is male, not yet diagnosed with a cancer, but he has a very, very strong family history. And certainly we know that we have hereditary colon cancer. I mean, it's well known. And so it is important that we do genomic study in this gentleman, just to, first of all, to find out, and that will guide what kind of therapeutic options. So, for example, and I'm delving now into the field of the surgeons, so I declare I may be wrong, but this young man, he has a lot of polyps in the colon, and one of the things that may be done is that, given the strong family history that he has, and if he has these genomic alteration, maybe preemptively it may be considered that the surgeon could remove that part of the colon that has all of these polyps. I declare I'm not a surgeon. Good. So, benefit. Does everybody benefit? No. But there are people who benefit from it, and I mentioned two different types of persons who may benefit from it. Right? It is important along the line when even sometimes you have some cancers, cancer of unknown primary. Don't know. You know it's a cancer, but you don't know where it's coming from. And so the genomic markers may be able to help us, to give us prognosis, to guide us for treatment. Those are important people. We encounter some very aggressive breast cancers, like triple-negative breast cancer. And these persons may benefit from it in terms of trying to identify different markers that may be able to predict what kind of treatment strategy we may give. Of course, you mentioned the whole aspect of people who have been through rounds and rounds and rounds of treatment, but yet they still have the cancer. Then we will have, then it behoves on us to really do genomic testing to see what else is there and how can we target them. So this is an example of a patient with an ampullary adenocarcinoma who genomic testing was performed on. Now, this is the gene, and I'm certain Jonathan would understand it. I don't. It's just some nonsense to me, right? But identified here, if you notice here, that there were no known therapeutic or treatment interventions for this particular type of cancer with this particular change. However, what is there is that for other types of cancers with this particular marker, they have used these treatments before. And so it is now a time for when the physician have that discussion with the patient and say, listen, this may not be for this particular one, but it has been used with benefit in that, and so on and so forth. So there are times when you need that kind of discussion. Now, this is a person with colon cancer, right? And the person definitely have a treatable target, a BRAF mutation. And we know regorafenib can be used there. Good? But in the case that we don't have regorafenib, then these are other options that may be used. It does give us options. And of course, those who want to hear more about immune therapy, you know, with the KRAS wild type and that kind of thing. But if I continue like that, then in some jurisdiction, they'll be saying that I'm using bad language. Now, there are challenges. There are challenges. And I mentioned last night from our opening speaker from the UK Ambassador for Health last night, who spoke about the ethics of it, right? The question is, so you find a mutation in so mommy has a BRCA gene. What are you going to do about mommy's daughter who is 5 years old, who is 10 years old? What are the implications? So it's not just a little willy-nilly thing, right? And of course, it's not appropriate for everybody. And it's not a silver key or a golden key to make sure that everybody with a cancer will live longer. Unfortunately, that's not the case of it today, right? One may have a genomic mutation, but yet the results do not give us the idea for a specific type of treatment strategy, right? Sometimes some of these mutations are even poorly understood by those who do the test, but for us physicians, complete nonsense, right? Only a subset of these cancers really the treatment of them benefit from these. So we still have a far way to go. Managing big data. Jonathan spoke about pulling all this data together. Managing big data is also a challenge. The high costs, because some of these things run into the thousands. And the elephant in the room is really about research, and especially among Black people. Not enough research is done. This is a patient with a myeloid sarcoma, and a mutation has been identified. And as I mentioned before, no therapeutic option, not even a second option. But yet, we have identified it, and that's one of the drawbacks that can occur. So there's a whole revolution, an ongoing change in the field of genomics. There is the whole aspect of the genomic profiling. It's managing big data. It's managing all of this evidence that's coming about, and then all the licensing authority are pushed or forced to approve a number of different things, right? And we now have everything at our fingertips, and we can touch everything and we get the answers. This is what is happening, and it's about how do we get there? How do we manage all of this? So that is just a snip of precision oncology, and we try to do now what patients need next. Thank you.
I did issue the challenge to today's speakers to match the opening last night, and I think these presentations have shown that. Now, very detailed and interesting information. Of course, I always give the opportunity for questions. If there are any questions across the room. Going once? There's a question at the front. We'll have the microphone. We have a few minutes for questions. Just getting the microphone sorted out.
Thank you. My question, presentations. My question is about, there was several years ago, there's a database that was collected re-cancer in Cayman. And I think that this genome profiling, a lot of persons are hopeful that maybe that information that was collected, that would inform what is being done now. Is it being used? Will it be useful as it relates to tracking, cancer in Cayman? Because I think a lot of people are hopeful that it would.
Hi. So could you be a bit more specific about this database?
I don't remember what it was called, but I remember contributing to the survey. But it was several years ago. Yes, registry.
Oh, okay.
Yeah.
The registry. Yeah. Okay.
Well, I assume you're talking about the cancer registry, right? So the cancer registry. And I'm delving, Amanda is around, right? So I'm delving, and you can say, Amanda, if I'm on the right track, delving into Amanda's territory. The cancer registry, it's really registering the numbers of different types of cancers that are available. And we do not have specific data or information on the person, so you would know that Lundie Richards has a cancer, right? And neither would you know that, okay, so I have cancer X and these are my genomic features. Those are not captured.
Thank you. There's another question over here.
Hi, yes, good morning. This question, it's just a quick question with respect to Mr. Smellie. Regarding having the accessibility for the testing, as you alluded to in your presentation, how soon do you anticipate that this is going to be readily available to Cayman and the Cayman people to have those testing facilities, have those test results? Obviously, time is of essence when you have cancer. So having that, what would you anticipate? A, the turnaround period, and B, when will it be available here in Cayman?
Right. Thank you. Thank you for that question. It's a complex thing to implement because it requires a lot of different people with different expertise to come together and deliver, right? But that doesn't mean we're not working on it actively. I'd be hesitant to give an exact time frame, but definitely within about 6-7 months, this will be available. Yeah, but I don't want to give something more definitive than that.
It's good. Thank you very much. If we can have one more question.
Pancreas. What is it about, say, pancreas that doesn't allow us to reduce the morbidity and mortality over so many decades?
Sorry, were we behind something? I didn't hear that. Sorry.
With cancer of the pancreas.
You mean in terms of, that's a very good question in terms of where is so behind in understanding the genomics of it. That's what you're asking. I'm not really too sure, but I do know, as I mentioned earlier on, there are certain genetic markers that have already been developed. It sometimes has to do with the immunogenicity of the particular organ system. That may be able to be part of it, but apart from that, I'm not too sure.
One second, just so that everybody could hear the question, we'll take this last question. Go ahead.
Mrs. Smellie, I believe we only use a very small part of our DNA to code for all the things in our bodies.
So they say, yeah.
Why is that? Well, I mean, how would that? Why is when we use 2%? I think is the figure. Why would we design a system like that?
Well, there's. Jeez. Oh, that is easy. That's an easy question. Yeah. Oh. Oh boy. Okay. I would. Here's the thing: is that number, that science, comes from the currently available understanding of. It's hard to imagine with the way evolution works that you retain a lot of things you don't need over millions of years, over many, many generations. So the genome is not so linear. It's not just about, okay, we have this 2% of things that make proteins and the rest of it is garbage, because that isn't the case. Those intervening sequences that we call introns that are not explicitly related to coding, creating amino acids that create proteins, they're still important for many other functions within the genome and within molecular biology and the development of an organism. So I wouldn't push away that 98%. I just think that perhaps it could be that 2% is actually a lot larger than the 2% we currently think. I'm not going to touch the design part of the question.
Well, the parents in the room would know the hardest question is always the why, right? So credit to you for your answers there. Gentlemen, I'd like to thank you very much for the presentation and for fielding the questions. very detailed and very thorough presentations. We have offered a gift of our gratitude to you on the table. Well, after all of that, I think it's time for us to get up, take a stretch, get some hydration. Before you go, I just want to let you know, I haven't released you just as yet. When you go outside, lots to do over the next 15, 20 minutes. The Health City booth, they're offering you a chance to get relaxed and rejuvenated. I think there's a masseuse out there. You could get a quick one. You can have your blood pressure and glucose checked at the Marsh booth. You can get your flu vaccine at the public health section. They're also offering the Moderna and Pfizer vaccine, both next door. We'd like to thank the Wellness Center for sponsoring the snacks and coffee. There appears to be someone who may have dropped some earphones in a black case. If you're missing them, they're with me. We'll see you back inside at 10:55. Thank you. Dr. Azad Esack is the neurologist and neurophysiologist at Doctors Hospital. We're going to invite him up to do a presentation on tackling stroke and dementia, and specifically focusing on current measures and approaches for prevention. Let's welcome Dr. Esack.
Hi, good morning, folks. Nice to be here. Nice to see you all. Let me thank the sponsors for inviting me to give this presentation. I've always wanted to have lunch at the Ritz-Carlton. So just couldn't afford it previously. So what a great opportunity. Right. Let me hope this thing works today. Yeah. So point at that. Right. So when you're talking about any illness at all, in terms of prevention, I think it's important you need to talk a little bit about the illness. You need to talk about some of its causative factors, the burden that it places on the health service and on the society as a whole, and how really cost-effective it is to actually implement this prevention. And there are some instances in some countries where certain diseases, there is no prevention, and therefore there are certain reasons for that, and that the taxes and the royalties received from the thing that causes these diseases are overwhelming. So there's no good reason for stopping that. So look, I am going to talk a little bit about dementias, not because I'm an expert on that, or not because I have that, but because I sort of know a little bit about it. And then I'm going to talk about stroke. Okay, so point to this one, he says. So what is dementia? Dementia is not really a specific entity per se, but it's rather the inability to remember things, to be able to think, and to be able to make decisions that affect our daily activities. Now, you may say, well, that definition applies to most of us, yes? And maybe it does, but let's take it a little bit further. You may have heard from Fiona McDougall, who's sitting somewhere there, last night, about what's the census for the Cayman Islands in terms of the numbers of people who are over the age of 65 changing over the last 10 years. And that number has actually increased by 85% over the last 10 years. It's going to quadruple over the next 10 years. And this is the age group where you have both of these diseases I'm going to talk about, both dementia and stroke. So it is, as this slide shows, it is really a tsunami. So the brain population is growing, and worldwide there's 50 million people, rising to 170 million by 2050. The prevalence rate for dementia is about 6 to 8% if you're over the age of 65. And just to be a little bit dramatic, there's one new patient with Alzheimer's disease being diagnosed every 7 seconds. So the cost is enormous. What is the cost? So big numbers worldwide. It's about $1.3 trillion. That's I can hardly think of what that is. It's a lot of money anyway. And if it were the economy of a country, it will rank either 18th or 13th. And there's an error on the slide. I'm sorry about that. It's going to rank either 18th or 14th in the country. So big numbers. Right. So this is a study that was done by the London School of Economics, looking at attitudes to dementia in a very large population, 70,000 people, over 155 countries, and carried out by the LSC. And some of the findings were that almost 50% of the general public are concerned about dementia. And I can hardly read it. I think I have to go to my notes, I'm afraid. Please forgive me. Yeah, sorry. So 35% of carers across the world said that they have hidden their diagnosis from the family with the dementia. Over 50% of carers globally say that they are health. And that may be an understatement. Maybe more health carers are affected by this disease. And almost 62% of healthcare providers worldwide think that dementia is just part of the normal aging process. And the last one is the most interesting one. 40% of the general population think that doctors and nurses are demented. No, I read that wrong. I read that wrong. That should be 100% of the general population. No. Okay, so let's move on. So there are 4 types of dementias, essentially. So there's the dementia of Alzheimer's disease, which is the commonest. There's this interesting dementia called Lewy body dementia. And there's a triad for this Lewy body dementia. And I think it's as common as vascular dementia, and it's really a very underdiagnosed illness. And then there's frontotemporal dementia, which I'll mention very briefly. So Alzheimer's disease is an insidious onset illness. It usually presents with memory difficulties. The incidence is about 8% per year by the time you reach 85. And about 2/3 of the dementia is caused by Alzheimer's disease. The ultimate diagnosis is usually made on pathology, but with good PET scanning now, we could actually see that in the antemortem phase. Good. So here's the pathology. It's a normal brain. This is the brain of someone with Alzheimer's disease with neurofibrillary tangles within the cell and amyloidotic plaques within the parenchyma. And this is what the CT scan may look like. It's a lot of generalized atrophy. But a normal CT brain scan does not rule out the diagnosis. And in many instances, you do see a normal brain scan, even in older people. So, vascular dementia, second, probably the third most commonest form of dementia, usually associated with vascular disease like stroke and diabetes and hypertension. It's a very abrupt onset and has this sort of stepwise look to it, course. Whereas Alzheimer's disease takes a some smoother course, the dementia of vascular disease takes a more stepwise course. And this is what a brain scan of vascular dementia with a lot of small vessel disease around the ventricles. And this is an interesting syndrome, dementia associated with Lewy bodies, which I think has a high incidence in vascular dementia. It's underdiagnosed. It's a triad. It's memory impairment, it's Parkinsonism, and visual hallucinations. Yeah? And some may add to that hypersomnia. If you're falling asleep, beware. Yeah? So visual, it's important to recognize this illness, quite honestly, because when these patients present with visual hallucinations and you give them antipsychotic drugs, they really, really decline very, very quickly, and you have to be really careful about not doing so. So the decline is faster than with Alzheimer's disease. So this is what the pathology looks like. There are these proteinaceous deposits within the cell, both on this stain and on H&E stain as well. And these deposits, what we call Lewy bodies, occur within the cerebral cortex of these patients, whereas the other Lewy body disease we know about, Parkinson's disease, those Lewy bodies occur within the substantia nigra, different part of the brain. So how do we distinguish the dementia associated with Parkinson's disease as opposed to Lewy body dementia? Well, the dementia associated with Parkinson's disease comes after the diagnosis of the motor syndrome, and by months or years, whereas the diagnosis of Lewy body dementia, the Parkinsonism, and the memory loss come together, or very close together. So frontotemporal dementia is a rapidly progressing disease, as I seen in the younger patients. It used to be called Pick's disease many years ago. It's more progressive, it's more rapidly deteriorating. And let me show you the CT scan for that. And you can see the marked cerebral atrophy both frontally and temporally in these patients. So this illustration that looks a bit like a seahorse tells us a bit about the various etiological factors that contribute to the development of dementia. And this starts off in early life and with poor education. Then it goes on to this interesting phenomenon, which was only described a few years ago, hearing loss and dementia. And I don't know many people understand that it is an important factor in the development of dementia. And when you see the person with the dementia, it's something that you need to treat. Yeah? So there are other factors as well, such as trauma, hypertension, alcoholism, which we're going to talk a little bit about, obesity, smoking, depression is very common, physical inactivity, social isolation, air pollution, a very strong one, and diabetes, and all contributing towards the dementia. Okay? About 60% we don't know why. So the Johns Hopkins people, about 8 or 9 years ago, produced this paper linking hearing loss and dementia. And I hope you guys are listening, right? So why is that so? Well, it's probably linked to a common etiology such as microvascular disease, also to reduce social engagement because you're not hearing, you tend to keep away from people, maybe changes in the brain with impairment of cognitive load, giving rise to impaired cognitive functioning. The other factor that's not mentioned in that sort of seahorse diagram that I showed you is this concept of sleep apnea and dementia. And this is a very recent study, published in April of this year, linking sleep apnea and the risk of dementia. And you'll see it again when we talk about vascular disease of the brain. And there's a third neurological condition associated with sleep apnea, and that's epilepsy. So there are three things associated with sleep apnea. One is dementia, one is stroke, and the third is epilepsy. So there's an increased risk of Alzheimer's disease, there's a decreased risk on CPAP treatment, and there are pathological changes before the dementia in these patients who've got sleep apnea. So there are other sleep disturbances associated with dementia, and these may include nightmares, night terrors, inability to sleep, insomnia, and as I mentioned previously, in Lewy body disease, hypersomnia, sleeping many times a day, may be something to look at. And these sleep disorders may predate the onset of the dementia by months or years. Yeah. So a lot is talked about alcoholism and dementia and the relationship of the two things. I want to show you this woman who's in her 50s, who was the manager of a large British hospital, and she was brought in by her relatives to see me because her memory was going. And I want to just play it a little bit to show you.
What happened is, I'm not really could read and write properly. But the big writings, I don't like to wear glasses. The lenses inside burn my eyes. When they put me as senior manager, besides I was managing between hospital patients and
can you stop
geriatric.
Good. So what she's doing there is something called confabulation. And she's shifting from one subject to the other because she can't remember the thread of the subject. So she makes things up as she goes along. And that's a good example of confabulation in a syndrome called, this way, Korsakoff syndrome. You remember that, maybe remember that term. And it's alcohol and thiamine deficiency related. The hallmark of the disease is this confabulation. But interestingly, we now know that there is an APOE4 link, and that's the gene that's related to early onset Alzheimer's disease, patients who develop Alzheimer's disease who are less than 50 years old. So alcohol may be a catalyst in the development of Alzheimer's disease. Have I gone back? Yeah. So the treatment, in terms of prevention, no magic to it. You minimize the vascular risk factors such as diabetes and hypertension. You try and prevent head injuries. You stop people from smoking. You try and reduce air pollution. You maintain frequent exercise. You reduce the occurrence of depression, and sometimes depression can be really, really very difficult to diagnose in the patient with dementia. And you avoid excessive alcohol intake. You treat the hearing impairment, and that's new. That's something we need to be wary about. We also need to treat the sleep apnea. Yeah? And we try and maintain frequent social contact and try and attain a higher level of education. So these are just the same thing that I've just said, really targeted at individuals, treating the hypertension, looking at the hearing loss, discouraging drinking, stopping smoking, reducing obesity, and increasing physical activity, especially in the midlife. It's something that finances is something we tend to forget. when we see patients with dementia. And it's really very sad because when the dementia progresses and the family haven't got a clue what he or she, the patient with the dementia, owes to the bank or to whoever, or what other people owe to him, and what are the finance situations. And I suggest that this is something that needs to be looked at very early on when you're looking at someone who has a dementing illness. On a broader scale, there are strategies to recommend it to on a much wider scale. Okay. So this is, I think, a very sad kind of scene where you've got older people in a very stark room, kind of sleeping on themselves, and it's kind of sad. And what they then do, right? So they then wheel them into a television room, and the TV starts to look at them, you know. And then, well, what they then do is to bring the musician along, right? And this lady is praying that he will stop. And this one, well, he's giving her such a headache that he... And because he's not a rap singer, they're all kind of tired. And so they bring along the dog, right? Great. And they all wake up, right? This dog, right? And he says to the lady, hey, lady, I've kind of had a rough day. Can you just go easy on me? And of course, he goes to sleep in front of the TV. He's so tired. Right. Okay. Stroke. Let's do stroke. This is a CT brain scan showing a very large right middle cerebral artery infarct. And I want you just to remember this scan because the last patient I show, this belongs to him. So about 65 to 75% of patients who have stroke have a cerebral infarct. A smaller number have brain hemorrhage, big hemorrhage that's gone into the ventricular system. And an even smaller number have what's called a subarachnoid hemorrhage, where there's bleeding into the subarachnoid spaces. And this really carries a very high mortality, about 60% on first presentation. So worldwide, stroke affects poorer countries by and large. And if you look at the incidence, they have very high incidence in places like China and Russia. It may reflect the high levels of smoking, the high levels of hypertension, yeah, and the general poverty in certain areas. This is an illustration just highlighting some of the cost to stroke, big numbers, what happens in poorer countries, big numbers again, starting findings there. Yeah. One in four people likely to have a stroke at some stage in their life. That's really quite a scary thing. And 1 in 6 deaths from cardiovascular disease, as Dr. Ravi was telling us about, is due to stroke. And the reverse is also true. If you've got a heart attack, if you've got a stroke, you are 1 in 4 chance of dying from a heart attack. So these are some graphs that show, tell us that in wealthier countries, the morbidity, mortality is getting better with time as time goes on. But in the poorer countries, the same does not apply. Yeah, the same does not apply. So stroke is more common in more low and middle income countries. They're less well educated. Blacks are twice or in some cases 3 times more likely to suffer stroke than white people. And if you think stroke doesn't occur in young people, well, in 10% to 15% of stroke, it's between 18 to 50 years old. This just shows us the rising incidence of stroke, both all strokes and both ischemic stroke. And somebody's doing a good job by moving the slides, huh? It's really good. And so, poignant map showing a high prevalence of patients with stroke in this part of America. And can you guess why? Yeah, this is where most of the Afro-Americans live. Yeah. Okay. I like this table because it tells you a bit about, these are some World Health stats, about what happens to the death rate per 100,000 in certain countries. And if you look at the United Kingdom and the United States, in 2020, the death rate per 100 is about 20.17, 22.27. Yeah? In Switzerland, believe it or not, it's actually much lower. Maybe due to the Rolex watches, I don't know, maybe somewhere. But in Jamaica, it's actually much higher. And of course, in Central Africa, it's way over the top, 181. So here are the usual factors and certainly hypertension is way far now. Air pollution, don't think about it a lot, but it's there, and all the other risk factors that we've alluded to previously. So there are some irreversible causes of stroke, and this is age, gender. That's kind of not so reversible. That's kind of reversible nowadays, isn't it? Yeah. Yeah. The family history we sometimes like to get rid of, but it's difficult to get rid of them. And of course, ethnicity, and there are some people who've tried to change that as well. You know, MJ, okay. But there are some, I mean, sleep apnea again comes around with this thing where there's an increasing association. CPAP therapy is beneficial in stroke improvement. The more severe the sleep apnea, the slower the recovery from stroke. And therefore, you must address sleep apnea when we try to manage patients with stroke, something we don't ever do. And sleep apnea is involved in all these different considerations with obesity and diabetes and dyslipidemia giving rise to stroke. Next. Right, so why? Well, when the brain becomes hypoxic or hypoxemic, it creates cardiac arrhythmias. There's certainly a fluctuation in the blood pressure throughout the night in patients who've got sleep apnea. And because of this hypoxemia and hypoxia, you've got a strong inflammatory process giving rise to platelet mobilization and clot formation. So, next. I'm often asked about the oral contraceptive pill and stroke. And I thought I'd just put this up out of interest. This young woman came to me a couple of years ago with acute onset of headache, vomiting, visual disturbance. And she was taking a pill called Yaz. And I think a lot of people are familiar with Yaz and Yasmin, right? Yeah, anyway. So, next, please. Yeah, so this was a CT brain scan. And it shows a small hemorrhage into an infarct in the right occipital area. And when you see that in someone who's on the pill, you think of a venous stroke, not an arterial stroke. And so she went on to have, next, an MRV, which is an MRI with a venous phase. And this is the superior sagittal sinus, the transverse sinus giving into the sigmoid sinus on the left, and on the right, it's just cut off, gone, kaput, blocked it off. Yeah. So the oral contraception and stroke is important, especially with this combination of estrogen and this drug, and this progestin called drospirenone, and that's found in these two pills called Yaz and Yasmin. But if you combine this with smoking, an older woman, and migraine, it really does increase the risk of having a stroke. Next, please. Yeah. And we had about 5 patients, young women who had stroked out on Yaz and Yasmin, and we were attempting to publish the series, and we were blocked because the case against the company was in the courts, and there was a settlement of over 19,000 claims of Yaz resolved in the United States in 2019. So something to think about. Stroke complications, lots. Death being, of course, right, the worst. 28% at 1 month, 40% at 1 year, 60% at 5 years. A lot of disability, a lot of neuropsychiatric effects, especially depression, anxiety, and crying. Post-stroke crying is very common, and it's not that difficult to treat with SSRIs. Dementia, 10% acutely and 30% at 1 year. Incontinence, Parkinsonism leading to falls. Pain from various descriptions of financial difficulties. And this very unusual and very rare syndrome called foreign accent syndrome. And just out of interest, I'm going to try and show you an example of that. Okay, next. Education. If you want to prevent any disease, there are 3 things you have to remember. You have to do. You have to have education. You definitely have to have education, and you must have education. Without those 3 things, you really are. But the question is, who provides that? Who provides the education? Does it come from the Ministry of Health, the government, or the private hospitals, or the public hospitals, or the NGOs, or I don't know, the banks, or what have you? I mean, perhaps all of them. And maybe you can have some ideas about that. It's really important to try and get the patient to hospital, and many people who treat stroke now have a dedicated ambulances that bring these patients to hospital. And there should be an early warning system in play, whereas if you have a patient who's coming from the community to hospital, that everybody knows that patient is around, so radiology is given the heads up, the neurologist is given the heads up, and certainly the emergency department. So factors that reduce the morbidity and mortality acutely, I'm all in favor of the stroke unit. I started my training in one of these, and early diagnosis, again, thrombolysis, clot recovery, we'll see that a bit. Carotid endarterectomy, I'm really for this. Head cooling, contentious. Early attention to swallowing. Swallowing is really crucial in the acute phase. And it's very sad to see patients being fed patients with bad stroke, be it cortical or brainstem, being fed so early on, and aspiration being a big problem. The judicious care of blood pressure lowering, diabetes, and again, sleep apnea. Next, please. So, this is one of the very earliest stroke units in the United Kingdom, in Bristol, a French hospital. This is where I started my training, 2 centuries ago. Next, please. But it has morphed. It's gotten to something slightly better, you know. And there's a lot of rehab work going, spinal injuries, head injuries, stroke, etc. in this unit now. So that stroke units play a very important part in improving the quality of life. There's this study done way back in 1998. Next, please. And this graph shows that people who come from a stroke center, they're more likely to get back at home earlier than those who do not. Reperfusion studies, yes, TPA thrombolysis in the first 4.5 hours window is meant to be cost effective. And that's why we need to try and get these patients to the hospital as soon as possible. But I'll show you a way by rapid scanning where, and if you know where the penumbra, the area around the stroke, if it's not too large, you might be able to extend this time period, and that would be extremely helpful. And those studies are ongoing at the moment. Mechanical thrombectomy is trying to put a catheter into the arterial system and either recovering the clot or lysing the clot with thrombolysis again. But it's only cost effective if you can do that within a 6-hour period. Next. So, I am all for acute endarterectomy. We've done quite a lot of these in the past. And I want to show you an example of why is it so important. 55-year-old woman with hypertension and very high LDL, Dr. Ravi, very, I didn't see you, of course, presented with left eye pain and a very fluctuating weakness of the left arm. Hey, within hours, the arm is weak, can't move it, and back to normal again. Evolving stroke. CT scan normal, but if you've got a good ultrasonographer and you can do quick carotid Dopplers, this is what you get. So this is the ultrasound of that lady. That's her external carotid. This is the bifurcation of the external carotid and the internal carotid. That's the internal carotid. That's the vital part. And there is that clot sitting within the internal carotid. And on the day of presentation, she came to surgery, had this done under local regional anesthesia, she's wide awake, and this is what, next please, this is what we took out. This is clot, this is the plaque, there is a fresh clot, and you could envisage little bits of this just popping out, until a large bit goes, and she gets a massive stroke. So it's a very, very important thing to try and look for carotid artery disease, especially in patients who have both hypertension and diabetes. Next, please. We were able to report our cases way back and of endarterectomy acutely, and that was part, next, please. Next, please. And this is part of a larger series that we published in the British Journal of Surgery. Cost effectiveness of carotid endarterectomy, looking at over 200 patients, all done under local regional block, all wide awake. Next, please. Good. So I want to show you, is there a time remaining, 24 minutes? Oh, we have lots of time. Oh, yeah. Oh, we get to lunch sooner. Yeah. Ooh. I'll just have a drink so that. Yeah, I'll be done soon. You know, like Henry VIII used to say to his wives, I shan't keep you long. So listen, let's be serious here now. This is you know, this is the Ritz-Carlton, you know. So listen, this guy, this is a man who's a Filipino, and as Dr. Ravi told you, this is one group of individuals who vascular disease is very prominent in. He pitched up to our hospital about a few weeks ago with a left cerebellar stroke, very unsteady. The CT scan on admission was normal. He then, at the same sitting, having the CT scan, he had perfusion studies done and an angiogram, all done at the same time, and all within 5 to 10 minutes. Remarkable quick scanner. I can give you these beautiful images of perfusion defect within the left cerebellum. Normal CT brain scan. Yeah. Next, please. And this is his angiogram. Pretty pictures, and that's the anterior inferior cerebral artery that's blocked. Nice and easy to see. And this man did extremely well on thrombolysis. So I was telling you about this 4.5 hour business. And if you can do the perfusion studies and do them quickly and reconstruct quickly, then you can get an idea of what the penumbra is, the area around the stroke. And if the area around the stroke is not large, like this one, then there is a strong possibility of extending the period of time that you can use thrombolysis effectively. And there are some ongoing studies in the States now looking at that same issue. Next, please. Right, so around the time that I started doing neurology in the UK, the Oxfordshire Stroke Project came about, and this looked really at trying to get patients out of hospital into the community. And we were actually admitting patients from casualty into the community with stroke. Yeah? And it was because we had backup. We had all these people who in the community that was involved. We had the occupational therapist, physiotherapy, speech therapy, incontinence nurse, blah, 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 blah. All these people were involved, and there was a good system of doing that. But that takes a lot of effort. That takes a lot of effort and planning. I'm not sure in the Cayman Islands whether that works. And I'm kind of, I need some guidance on this, whether having insurance actually makes that easier or less easy to do, because, well, the insurance companies can tell you about that. But this is something that really needs, this is something that can be addressed, the community approach to management of stroke. Okay, next, please. Right, so this is a wagon wheel, saying basically what we've all been saying, telling us about population-wide strategies that includes exercise and reducing LDL, etc., looking at good drugs, and then individual strategies to try and reduce hypertension and obesity, etc. Yeah. Okay, I think we're almost there. Yeah, oh, right, okay. We're almost there, we really are. You know, neurologists like to talk about esoteric things. It's within their 2% of the DNA. You remember that? Yeah. It's what they do. And I have to share this patient with you because this illness is so rare. This man is 55, or was 55, a senior economist with the government, spoke lots and lots at all kinds of meetings, trained at the LSE, quite a good speaker, came with a big stroke, and that, if you remember the first scan I showed you, that's him. Big right MCA infarct, almost died. We ventilated this chap, and he eventually did very well. And so his wife brought him back to clinic to do, and she said to me, "Doctor, this man is speaking kind of weird. Why is he speaking like that? What you done with him?" I said, "Well, let's have a look." Mm-hmm.
Yeah, little weak. I think I'm little weak. I feel like I'm getting the virus. She get the virus. My next son get the virus. And you know, tell like he had virus. That's how he prove. Dr. Rufman, I tell you, you have virus. Don't say what you father, you go here. Dr. Rufman tell you put the antibiotics.
You can stop it now, please. Good. So, you can see that he's got a left hemiparesis. You can see that he's emotionally upset, and he's got a bit of stroke, post-stroke crying. But this isn't the man that was talking. This isn't the economist that talks every week. Yeah? So what's his accent? Can anyone guess? Don't tell me he's mocking me. No, that's not right. That's not fair. That's not fair. Yeah. I got Trinidadian. Japanese? No, I didn't get it. Anybody from Grenada? Anybody from Eastern Caribbean? This is a profound Grenadian accent. This man has never been to Grenada. Yeah, never. And I can tell you, we have some videos of this man speaking the Queen's English before all of this. Yeah, and this is foreign accent syndrome. Yeah, and I've had two other patients in my career. One, a lady in Yorkshire who developed a stroke and started speaking with a German accent. And I've had a young boy of 10 with a head injury with a prominent American accent. So it's just out of interest and just to try and keep the boredom away. So next. Next. Yeah. Right, so nice sunrise over Cayman, yeah, okay. Next. Right, so we're done. What I like to do is not for you. What I like is for you not to ask me any questions. I don't like questions because I can't answer them, quite honestly. But I would implore you to make suggestions and or comments on your own personal things. I mean, really the dementia and stroke. Yeah. So let's go. Thank you very much for your time and for the company.
Thank you very much, Doc, for that presentation. I know you said you didn't want questions, but does anybody have? We have a question here.
Dr. Esack, do you have problems getting insurance coverage for doing carotid Dopplers with people who have risk factors but perhaps not symptoms? Because if you're only screening people who have symptoms, you're going to perhaps miss those people who could possibly have, surgical intervention or medical intervention at a much earlier stage. But the insurance companies do not want to cover carotid Dopplers.
Well, so far so good. I mean, I haven't had difficulties with that, but usually I'm screening for people with TIAs. That's the one that, and so there's good reason for, you can't really deny someone not having carotid Dopplers who's at a TIA. Yeah.
Okay, I think we have another question right here.
I just recently, this year, found out that I had sleep apnea. I totally forgot about the seminar, the conference. So you talk about the memory. Now, I'm being treated for sleep apnea, and I have blood pressure. And I just recently found out also that I have serious circulation problem. So just listening to you, I'm a bit worried about the stroke. You talk about Jamaica and the because of that. I lost my father in December. He had a stroke, circulation problem, and lost a leg, and he was a heavy smoker. And he died from a heart attack. So you talk about DNA connection. So how long do I have?
Thank you. I'm not sure whether that was a comment, a question, or foreign accent syndrome. Thank you very much indeed.
I think on that note, it's a good time for us to break for lunch. But before we do that, we'd like to thank Dr. Esack for his presentation. A small token of our appreciation. Welcome back, everyone. Here's hoping that you had an enjoyable lunch and that you're nourished to take in all of what we're about to discuss for the balance of today's agenda. Lots of important content ahead, so we're looking forward to it. And we're going to make a special welcome to our next speaker from Baptist Health, South Florida. We thank her for joining us here, for making the trip and joining us. Dr. Yuliya Linhares is the Chief of Lymphoma Services at the Miami Cancer Institute. She is here to present on how we can optimize our health without medications. Let's give her a warm welcome.
Hello, everyone, and it's my pleasure to present to this audience. This is my first time in Cayman Islands, and I'm delighted to learn about this island, and it was just wonderful to meet people of the island. I can feel what a wonderful, welcoming, and warm community we have at this island. I really hope to be back. It was also a pleasure meeting multiple physicians, healthcare professionals, and just regular people. So thank you so much. So I had a chance to give this lecture, and I was wondering about the topic. I'm a chief of lymphoma services. I treat cancer every day. I treat mostly lymphomas. There's so many exciting new medications out there. But nevertheless, if I just talk about cancer drugs, that wouldn't be applicable to each and every person in this audience. So I wanted to create a talk that would change your lives. So I hope in 1 hour, I'm going to change everybody's life to the better and improve your health, improve your longevity, and lower your cancer risk. So please tune in. If this clicker works. So why am I talking about this again? The lifestyle modifications, changing our lives through lifestyle changes. Well, it's actually because top 10 causes of death in the United States, at least, and also around the world, are not cancer, but other ones as well. So heart disease, cancer, chronic lower respiratory illness, stroke, diabetes mellitus, all of these diseases are potentially affected by our lifestyle. And then 80% of premature deaths are attributed to tobacco, poor diet, and lack of physical activity. So if we think about the key health behaviors, such as not smoking, maintaining healthy weight, consuming 5 fruits and vegetables a day, and also maintaining regular physical activity, only 3% of total population actually have all 4 of these very important health behaviors. And if we eliminate the 4 top risk factors for illnesses, then that would lead to 80% reduction in the risk of the most common deadly and chronic diseases. So really, our health is in our hands. So here is a health study from England. Over 4,000 individuals were followed for 20 years, and they were given points for one of the 4 health behaviors: smoking, eating fruits and vegetables, physical activity, and alcohol. So the risk of death was directly proportional to the number of these adverse health behaviors. And here are the curves. Sorry, that's where the clicker comes in. So, and the individuals who exhibited all 4 of these high-risk health behaviors actually had an all-cause mortality comparable to that of someone who is 12 years older. So if you are maintaining these 4 unhealthy habits, literally you're aging yourself by 12 years. So, and if we talk about applicability to one of the most common cancers, right? So most common cancer in women is breast cancer, and 1 of 8 women, unfortunately, will get breast cancer. These lifestyle factors are extremely important. So it turns out that physical activity level at baseline is associated with longer survival in advanced breast cancer. And why is this so important? I'm saying the word survival. Well, it's because now we have cancer drugs approved based on what's called progression-free survival, meaning, let's say we're using this lung cancer drug, and it makes somebody live without cancer progressing for 3 months longer, and the drug is approved. But guess what? That patient did not live overall longer. So they still, let's say, lived for 12 months, 15 months, and so forth. So here we literally have something that if it were medication, physical activity, if it were, it would be immediately approved by FDA, and you can only imagine what price tag it would have, right? I mean, think about the price tag on insulin, on CAR T cells that cost $450,000, right? And then we have only 30% sustained survival. And here we have exercise that improves overall survival in breast cancer patients. And then if you do a little bit more, right, so a little bit more of exercise, just 1 additional hour per day, that decreases breast cancer mortality by 23% in patients with advanced breast cancer. And then, unfortunately, we do have to say this uncomfortable word, obese. I was thinking to exclude it from the presentation, but it is what it is. High BMI, obesity, unfortunately, is associated with adverse prognosis in breast cancer. And that is why, not because these patients get less treatment, but because actually they respond worse to chemotherapy and to hormonal therapy. They have increased risk of local recurrence of breast cancer due to the metabolic state and hormonal background. Also, they're less likely to undergo breast reconstruction and more likely to sustain adverse side effects with radiation therapy and with surgery. So what do we do to help us with breast cancer risk? My mom had 2 breast cancers, and one of them she had when I was just born. So I know how horrible this affects our life, and so I wanted to have my sons with healthy mom. So if we exercise for 6.5 hours a week, the breast cancer risk is reduced by 30%. And that's just one of those tiny small things we can do to reduce our cancer risk. So why is general health so important for me as an oncologist yet again? Well, it's because it turns out 30 to 40% of cancers worldwide can be prevented through changes in modifiable lifestyle factors. One of them is sedentary life behavior. So sedentary lifestyle is associated with increased risk of colon, endometrial, and lung cancers. So 20 to 40% increase in risk of very common cancers. Increased body fatness is associated with 13 different cancers, most common ones. And then the opposite of that, physical activity and maintaining healthy BMI helps us reduce risk of most common cancers. And now a little bit of biochemistry, and that's for physicians in the audience and whoever's interested in it. So why is that the case? Well, so what happens is when we're overweight and our physical activity is down, sedentary behaviors, we accumulate adipose tissue. And really, what is adipose tissue? It's not just an energy storage depot. It's not just there to protect us from cold or help us survive. It's actually an organ. It's a very active biochemical metabolic organ. So the adipose tissue has influence on the rest of our body, and the influences are multiple. So one of the pathways is change in metabolism overall. So the more fatty tissue we have, the more insulin resistant we are, exacerbating metabolic syndrome. Additionally, adipose tissue produces pro-inflammatory cytokines, pro-inflammatory chemicals. So really, obesity and metabolic syndrome are diseases of inflammation, and it's shown in multiple studies. Additionally, adipose tissue is associated with controlling of something called sex hormone binding globulin. So it's a very important protein that binds estrogens and androgens, so binds our sex hormones. And the thing is, if you don't have enough of this protein, then you have all these loose hormones circulating in your body. And really, when you have too high of a level of testosterone or of estrogens, that's what lead and predispose you to various cancers, such as breast cancer. So all these processes, when we have increased adipose tissue, lead to cancer risk and vice versa. By decreasing adiposity, we decrease cancer risk. So additionally, again, as an oncologist, why am I talking about this? And how did I even think of this, right? Well, it's because I have and I see my patients, I treat them in clinic every day. And so when I start treating them, I have to think of them getting through chemo successfully, right? So when I look at the patients who have cardiovascular disease, they have diabetes or neuropathy or kidney disease or depression, I know they're not going to do as well, because actually then they're predisposed more to subsequent organ damage, to heart failure without drugs, to fatty liver, to more neuropathy, to more depression, and then it feeds back to subsequently exacerbate their pre-existing conditions. So it really goes both ways. And yes, actually overall, unfortunately, I kind of tell when I taught residents, medical students, I said, hey, we're very likely to get cancer. You know, I may get cancer, I'm not bulletproof, but you know what? I want to be ready for it. So if I get cancer, I want to get my full drug doses, and I don't want heart failure, and I don't want neuropathy. When we have people who have these pre-existing conditions, for example, acute lymphoblastic leukemia is treated with drugs like vincristine, right, or steroids. So if we're unable to give full doses of these drugs, then we're unable to cure these cancers. So it's very important to have good metabolic health. So, and again, you think, okay, just I'm saying it's important. Well, White House says it's important. So actually in September, they're giving this conference on hunger, nutrition, and health, and they're giving billions of dollars, and I promise you, I didn't get a penny from that, you know, 4 billion. And also, Mr. Biden did not recruit me to talk here, but they're giving billions of dollars to fight these maladies of the modern age. And the American College of Lifestyle Medicine is actually giving free CME to teach physicians the lifestyle modifications and food as medicine. And so again, because of all this, I myself got additional board certification last year in lifestyle medicine. So in addition to internal medicine, hematology, and oncology, I'm now board certified in lifestyle medicine. What lifestyle medicine is about is treating and preventing illnesses with lifestyle modifications. So, okay, now everybody is back from lunch. I hope everybody is awake, so now we can really talk about what I want to talk, not the background. So, really, in the last 33 years, the prevalence of overweight and obesity increased by 28% in adults, and even more so, 47% in children. So why did that happen, right? I mean, are we different? No, we're not different. Our genetic code is the same. As a matter of fact, you know, it's very close to Neanderthal, right? So there's barely difference between us and even pigs if you compare the genomes. But then why? What happened to us? And then we look at this guy, right? So he was kind of in a bad shape, and then he's here. So is that a different person? Something changed with the code, with the DNA? No, nothing changed here. So how did he do it? So, and what he did has to do a lot with us modifying our genome. So what it is our DNA is very flexible, right? So as you remember, DNA consists of genes that code for RNA and then protein expression, right? So that is set in stone unless you do some kind of mutagenesis, right? And that leads to cancers as well. But it is not really set in stone because there are multiple modifications of DNA that can change what we call expression patterns. So, and modifications can be methylation of DNA, so it really shuts it off, it shuts it down for use. DNA is wound on these little spools here, and those are histone proteins. So histones can be modified via, again, methylation and acetylation. And again, it either opens or closes DNA for use. So those are the two modifications. And then the third one is a really cool one that I really like, is in microRNAs. So basically, here's the paradigm. We have DNA, and then from DNA, the RNA is translated, and then RNA is translated into protein. So, but our DNA actually makes this little microRNAs. They're kind of like little Velcros that bind to messenger RNA and neutralize it. So that's another way to control the expression of our genes, right? So the three main epigenetic modifications that control the expression of genes on our DNA are DNA methylation, histone modifications, and microRNAs. So, and here is a little graphic. This is the way I like to explain epigenetics to my residents and medical students. So imagine DNA is a rope with different parts, right? Let's say we have green, orange, green, orange, green, orange, right? So those are UF colors, by the way. Right? So if we modify these orange parts, and via modification we close them off, then literally now we have a green rope, right? So the orange parts are still there, but they're just not seen. They're not active. And here is the other way about. Here we have our rope, and we modify the green parts, and they're shut off. And here you are. Now you're an orange rope, right? The green is there, but we just don't see it. So basically, you can choose which rope you want to be. You're not really committed to your genetic code. We are able to change this gene expression and become what we want to be. So what he did is he changed his epigenetics. And so basically, therefore, when we look at obesity as a state, it really is not a reflection of our outer self. It doesn't matter. Looks don't matter. You know, it's not about body image. It's not about culture. It's about our inner health. So really, our body composition is a reflection of our epigenetic health. And here you go. There are actually multiple scientific studies. So here you are with this guy, right? This is what he was doing. I'm not sure he knew about it, but that's what he did. So there are multiple studies showing us that there are multiple abnormally methylated, so shut off, genes in obesity, such as insulin sensitivity, energy metabolism genes, lipid metabolism genes, genes for the hormones that control appetite, genes for hypoxia response, inflammation, and oxidative stress. So how do we gain epigenetic control? And believe it or not, I think there is a formula. And I have to say, I did create this graphic, so I created the formula. But really, these components, they're all keystones of the lifestyle medicine teaching. Because it turns out, so all these common things that we do, so our diet, our sleep, toxins in our food, physical activity, stress, and micronutrients, they all affect epigenetics. So what we can do is really go from potentially a lifestyle that predisposes us to cancer and metabolic syndrome to metabolic health. So then the recipe, right? Because we can talk about what's important, but really we need to know why it's important and how do we gain control. So first I wanted to talk about sleep because everybody gets excited about diet, everybody gets excited about physical activity, but really we forget about sleep. So sleep actually is very epigenetically active. So sleep deprivation leads to disruption of circadian clock genes. And here they are, the clock and BMAL genes. And believe it or not, so these genes control DNA expression of multiple other genes. And literally, they are epigenetic modifiers. So they epigenetically modify via generating new microRNAs, histone acetylation and methylation, DNA methylation, which leads to changing expression profiles of multiple genes. Actually, in some studies, 711 genes are variably expressed due to sleep. And if we're sleep deprived, that all leads to these modifications, increase in cortisol, and subsequent high blood pressure, metabolic syndrome, diabetes, and obesity. And in one study, actually only one night of sleep deprivation led to glucose intolerance. Only one night. So how do we improve our sleep? So this is the best slide, but this is where the money is. So first, I want to give credit for this slide to my wonderful life partner, Scott Lackey, who is here, because he's the one who taught me these techniques. Because I had insomnia for all my life. I was a medical student, I was in residency fellowship. How do you think people get through it? Of course, on 4 to 5 hours of sleep, right? And then you acquire that deleterious habit and you think that's normal and that's how everybody does it. Well, when you're trying to have a family, that's not that healthy. And when you have a partner who is actually a technologist and computer person and researches everything, then you get help, right? So family can be your doctor. So if we go into the mechanistic of things, so I haven't mentioned melatonin, right? So here you go. So we're blocking our blue light because it turns out that it's actually the blue spectrum light that signals to our brain here to suprachiasmatic nucleus, which influences the production of melatonin, which actually has the feedback back to suprachiasmatic nucleus, affecting our circadian rhythms and, of course, all those epigenetic modifications that I talked about. So it turns out that the blue blocking glasses can be very effective in helping us to not suppress that melatonin production with blue light. There were multiple studies, but some of them demonstrated that the teenagers, for example, who wore LED, so blue blocking glasses, had improved attention and alertness, and also had improved insomnia. So one of the things you can do is order your blue blocking glasses from Amazon. So other one, that's why I have Amazon for credits there for pictures, right? It's that easy. So the other one is the weighted blanket. So again, I actually have a weighted blanket, but then you want to see, does it really work? Well, I can tell you, yes, it works. And the glasses work too, because of course I've been spreading this teaching, because you can say, okay, well, right? Nobody believes that non-medical things will work, but they do work. So it turns out that weighted blankets actually increase melatonin production. So unclear why, but that's what studies demonstrate. So then other things, so I'm going to mention valerian, and that's a cultural, so I come from Eastern Europe. So valerian has been used for centuries in many countries, in Europe, in Eastern Europe, Western Europe, for sleep. There are multiple studies. Some of them are positive, some of them are negative, but in general, the consensus is yes, it can improve sleep quality. And you know what? Let's believe our grandmas. They had a good life, and they had better health. They used valerian, my mom used valerian, and she did well. So at least it doesn't have any side effects. It's not addictive. It also maybe it's placebo. You know what? Placebo effect is 60% on many things, like even headaches. But it doesn't have any side effects. So I think it's completely fine. It's a good tool to use to help with your sleep. And the other one, very interesting one, is sour cherries. So believe it or not, sour cherries contain melatonin. So if you have some cherries around and you have trouble sleeping, eat a bag of cherries in the evening, and you will fall asleep. I can guarantee you that. And there are, again, multiple studies on that. And of course, what happens with the studies is that a lot of times in the studies, people study extracts, right? There's no money in studying cherries. No one is going to study eating a bag of cherries at night. But I'm not here to advertise for supplements. Nothing that I say is about supplements. Everything that I say is about whole foods, because we're not made to eat supplements. And as a matter of fact, in many studies, they're deleterious and not effective. So we have to actually think of the way where we came from and how we can change it all via whole foods and wholesome lifestyle modifications. So other things that we have to remember, toxins, right? And the most common ones are the ones from plastics. So it turns out that the obesity epidemic coincided with Industrial Revolution. And Industrial Revolution coincided with the advent of plastics. And we all hear about BPA, phthalates, right? But then we kind of forget about it. And why do we forget about it? You know why? Because it's not in the news. Because plastics lobby is not going to allow to have water bottles in the news, right? There's no benefit to anyone for us to not use plastics. But it turns out that these compounds are all over the place. They are what's called environmental obesogens. And because they actually, so if you can tell, if you know a little bit of chemistry, right, these are aromatic compounds. So basically this ring here makes it possible for these compounds to penetrate into our blood and inside the cells. And actually structurally, if you can see, a lot of our hormones have similar ring, right? So these compounds actually affect our epigenetics and are called endocrine disruptors. It's another name for them. So BPA is associated with metabolic syndrome, visceral obesity, and insulin resistance. And that's from the studies that measured levels of BPA in the urine and blood and these conditions. Also associated with higher BMI in children. Phthalates make plastics soft, and they have estrogenic, antiandrogenic effect, also associated with metabolic syndrome and obesity, and even are possible carcinogens. And then other important compounds are pesticides, so they're organochlorine and organophosphate pesticides, and they actually accumulate in adipose tissue because they're fat soluble. They, again, have epigenetic action, and they can cause lasting metabolic disruption from early life exposure, and that's actually from mouse studies. And they contribute to global rise, again, in obesity and diabetes. So what do we do? You know what to do, right? So just try to reduce plastic use, and it also will be good for our planet. Actually, it turns out a lot of things I'm talking about here are very good for the planet as well. So other things, stress, right? We're looking at this slide, and maybe I'm stressing you out a little bit, even with this, with this color here, so we're gonna make it better for a second. There you go, much better. So again, little epigenetic modification. Color has an effect on your well-being as well, right? So stress also mediates metabolism. And there is acute stress, and there is chronic stress. So with acute stress, we activate our adrenaline and fight-or-flight response. Blood pressure goes up, your bronchioles dilate, right? You're ready to run. So it feels kind of good. But what happens when our stress is chronic? So actually with chronic stress, we produce more of these hormones called mineralocorticoids and corticosteroid hormones, glucocorticoids, which leads to retention of fluid and to basically alteration of metabolism, again causing insulin resistance. And how does it do it? So one of the very important pathways is that these hormones affect different types of fatty tissue. So in our body, there are two types of fatty tissue. So one is called BAT, so brown adipose tissue. So actually in adults, there is very little BAT. It's gone by adulthood for most. And what BAT is the fatty tissue that's ready to use its stores, right? It actually is like a little oven. So these brown adipose cells actually use lipids and burn them and regulate what's called thermogenesis, right? They help us maintain our body temperature. And then there is white adipose tissue, which is just basically storage. So that's what we don't want. And it turns out that white adipose tissue can actually convert to not brown, but what we call beige adipose tissue. So when white converts to the active adipose tissue, it's called beige adipose tissue. So basically what happens with stress is that literally we get so-called bleaching of beige adipocytes. So they become white. So it's like coral bleaching, right? So stress bleaching, right? So being bleached out. And there is more inflammation in that brown adipose tissue or beige adipose tissue. There is death of those very valuable adipocytes. So all that we don't want. But at the same time, this white adipose tissue thrives in condition of stress, and the white adipose cells become big and hypertrophied. And also, the special hormone is upregulated, and this is 11-beta HSD1 hormone that actually converts cortisone to cortisol, so inactive steroid hormone to active steroid hormone, further contributing to the stressful condition. And all these metabolic changes lead to inflammation, again, inflammatory cytokines, and subsequently to all these modulations of transcription factors. So again, whoever is in biochemistry will know about Jun kinase and of kappa B. So very important transcription factors that lead to inflammation, insulin resistance, and further adiposity. So what do we do? Again, I do need to give you a recipe, right? It's all not that bad. So it turns out there's some very simple things. So one thing, it turns out technology use actually increases your cortisol levels and inflammation. We are upregulating interleukin-6, increases your dopamine levels in little bursts so that they are increased temporarily, but actually overall dopamine gets depleted. So literally your graph of dopamine on social media goes like this. So, right, little spike down, little spike down, little spike down. That's why social media is so horrible for people with ADHD. Their dopamine is already very low, right? And then you're squeezing it out and basically just leaving the person's brain dry. Stress, right? So what should we do then? And there you go. Just turn off your notifications, right? That easy. Check your social media, whatever, when you want to check it, not when it wants to be checked. Delete apps that you don't need, right? I mean, I'm guilty of that. I have 40 apps on my phone. It's ridiculous, right? But this is very simple. And just give it a break. Turn off your phone. So the other one is meditation. And again, everybody says meditate, right? And it seems like it's this hippie thing, California. By the way, I did live in California for 10 years, probably hence this presentation as well. And yes, I do meditate 3 times a week for an hour. So what is it really about? Well, it turns out that the studies demonstrate that meditation decreases cortisol levels, blood glucose, even hemoglobin A1C, which is a marker of your glucose state over time, and heart rate. And then the last thing to do, okay, you don't have time to meditate. You know, you don't want to turn off your phone. But at least have a dinner together with your family. Because again, it turns out that the studies demonstrate, if you don't believe me, that just having social time already decreases cortisol. And actually, they did studies on family meals. And those studies demonstrate that with family meals, both parents and children have greater self-esteem, the depressive symptoms go down, they have better family function, and overall that leads to better nutrition and better weight maintenance in our children. So, and now it leads me to the next one, right? So after the family meal, what do? We have to get moving, right? So it turns out, again, physical activity, same thing, same pattern, everything is connected. So when we're laying around on the couch with our social media in the hand, that actually directly epigenetically modifies our genes through an activity, reducing insulin sensitivity, energy metabolism, impairing mitochondrial function. So mitochondria are these little batteries we have in our cells that generate energy. So we're directly affecting mitochondria with this behavior. And we impair our homeostasis. But with various types of exercise, there is actually epigenetic changes in DNA methylation of 63 genes. And this is just one study, right? I mean, there are tens of thousands of studies on this. And with exercise, we're actually increasing basal energy expenditure. So not only when we exercise, but in general, right? So your 1 hour of exercise will go very far because you're increasing your basal metabolic rate. We are actually down-regulating genes associated with obesity and diabetes, right? So when you're exercising, just imagine, right? It's not that you're burning calories right now. It goes much further than that. You're actually changing your body from the inside out to help you get in the shape that is more beneficial for your health. Exercise also affects fatty acid metabolism. So even more so, if we participate of 60 minutes of acute endurance training or 10 minutes of acute exercise, so that, right, if you want a recipe, how much of exercise, that actually increases the expression of certain microRNAs. Remember our little friends, our little Velcro friends that help us regulate genes? So it changes the expression of microRNAs. So if you don't like exercising, at least you can envision yourself being a friend of microRNA and how you're changing your body. And again, those microRNAs are the ones that help us with mitochondrial function and fatty acid oxidation and insulin sensitivity and so forth. And if we're doing long-term endurance training, it actually restores methylation profile in DNA. So again, sometimes what happens is, not sometimes, but often, actually globally, our DNA is marked with a faulty pattern. It actually is very common in cancers. When we look at global DNA modifications, basically you can have a cell that was normal, but then the good genes are shut off and bad genes are all expressed. And we even have cancer medications now that exploit that. I use cancer drugs myself for leukemia, where the drug does not kill leukemia cells, but it literally transforms leukemia cell from cancer cell to normal cell. I had a patient who had all blasts, which are leukemia cells in blood. Then I give this new drug that we have, epigenetic modifier, and then in a couple of months, he had all normal cells in the blood. They were visibly normal, but if we genetically type them, they were all cancer cells. So it really works. So here with exercise, we're doing the same. So we're restoring the normal patterns in our cells. And some of them are calcium signaling, glucose transporters, and so forth. So other very important metabolic pathways leading to, again, improved insulin sensitivity and improved lipid metabolism. And now to diet, right? Because that's, of course, what everybody has been waiting for. So again, not big news now, because you know what this presentation is about. High-fat diet actually changes expression of over 6,000 genes. 6,000 genes, and that's from the laboratory studies. And among them, of course, are genes responsible for mitochondria, which is cellular respiration, inflammation, cancer, reproduction, skeletal muscle function, and appetite regulation as well. But it goes even further. So when they do studies in maternal nutrition, so if the mothers are not eating correctly, right, and they're having high-fat diet or inadequate nutrition, it actually changes expression, so epigenetically modifies maternal and fetal genes. So we have now offspring that are predisposed to obesity and abnormal lipid profiles and fatty liver and insulin resistance, right? So really these faulty dietary patterns propagate unhealthy metabolism through generations. So I hope that epigenetic diet is going to be the diet of the future, right? And so now when we think about our menu, we're going to think epigenetically, right? When we eat, we're going to think, okay, what am I doing for myself when I'm eating this food, right? What am I changing? So, and here are some very interesting compounds that can change our DNA expression. So one of them is resveratrol in grapes. And that it improves cardiovascular metabolic functioning, improves hepatic steatosis, which is fatty liver, insulin sensitivity, and so forth. The other one, very simple one, so green tea. Green tea has catechins and polyphenols, again, that cause epigenetic modifications that lead to reduced body weight, improved insulin sensitivity, and so forth. So a cup of green tea and a little bit of grapes. The other ones that are interesting are isoflavones from soybeans, again, connected to healthy body weight modulation, healthy lipid profiles, and insulin sensitivity. And again, I would like to remark that there are many studies, and there are a lot of studies of supplements that just don't work. But if you look at epidemiologic studies, basically of certain cultures consuming these products, then we see positive associations. So I'm not asking you to buy resveratrol in capsules or green tea capsules, but just think, because we are wholesome organisms, we're whole humans, so we have to think about macro compounds that we eat. Plus, it's much cheaper, especially now with inflation. So the other one, so these are my favorites. So curcumin, right? I mean, everybody loves curry. I love curry. And I tend to think that basically what we love is usually good for us, unless someone makes us love it, like putting perfumes in hamburgers, right? We don't really like them when they're not perfumed with all this additional additives. They're not that good, but almost everyone loves curry. So turmeric is in curry, and it increases fatty acid oxidation and suppresses expression of inflammatory genes. The other ones are organosulfurs from cruciferous vegetables. So cruciferous are cabbages. So the other name for the family is Brassicaceae, right? So the other one that has organosulfurs is garlic. So basically stinky ones, right? Well, it turns out that sulfur, those compounds in the stinky food, they're good for us. So you can do your own cruciferous crusade. So, and that way suppress your adipogenesis and inflammation. So I have to say, in real life, every weekend what I do is I cut up a big head of cauliflower and I roast it. So Saturday, Sunday, it's just around for all the family as a snack, right? So instead of snacking on a little candy, you can just snack on little roasted florets of cauliflower, and it's great. So... So the other one is vitamin D. So it's the last one of these components, so minerals, right? Of course, now that you know that everything is connected, everything changes DNA expression profile. So of course, magnesium and calcium and vitamin C and vitamin B12 and vitamin B6, they're all important. They're all epigenetic modifiers. But in regards to supplements, a lot of patients ask me, so, what about vitamins? Which one should I take? And I always mention vitamin D. Vitamin D is extremely important in oncology. And the reason why is because it actually is a hormone. So here is a synthesis, right? It starts with a prohormone in the skin, and then liver synthesizes a more active version, and then kidney converts vitamin D to this final and active version of 125 calcitriol, right? So that's the active version. And guess what? It turns out it penetrates cellular membrane and binds to vitamin D receptor that is on DNA. So your vitamin D goes directly to your DNA, and it affects expression profile of multiple genes that are important for your health. So it's not just something for healthy bones. Vitamin D is actually connected to multiple processes, to inflammation, to brain health, to metabolism. So it turns out that people with increased body mass index are more prone to vitamin D deficiency, and the studies are done. What also is very important for oncologists in this audience is that low vitamin D levels are prevalent in multiple cancers, so colon, breast, leukemias. It actually turns out that vitamin D deficient patients with lymphomas respond worse to Rituxan-containing regimens. And also there is another study demonstrating that vitamin D deficient Hodgkin's patients have decreased survival and chemoresponsiveness. I'm a transplanter as well, and I'm also in charge of cellular therapy at Miami Cancer Institute. And believe it or not, when I was talking about vitamin D and routinely checking it in all my lymphoma patients, a lot of people laughed. They see Dr. Linhares, haha, are you going to treat them with vitamin D? Well, guess what? 2 months ago, an article came out that demonstrated that patients with low vitamin D levels had lower response to this revolutionary therapy for lymphomas called chimeric antigen receptor T cells. So they actually had lower complete response rates. So it's an incredible modulator. So when I have patients come into my clinic at the first visit, I check their vitamin D level. And guess what? At my institution, and this is my personal research, 28% of patients are deficient in vitamin D. And so I believe that partially fantastic outcomes I have in my clinic are attributed to this wholesome treatment and possibly vitamin D. So ask your doctor to check your vitamin D level. So here you go. Now you know what to do, right? So we're going to modify our diet, our sleep. We're going to exclude toxins. We'll remember about micronutrients. We'll manage stress and physical activity. But you know what? There is something else. Elephant in the room is microbiome. So we completely forgot, and I didn't mention that a human body is not alone. So what we are, we're holobionts. So holobiont means that you are a community. So you're not alone. You're actually a community. You're a vessel for a whole community of microorganisms. And these microorganisms are connected to all these functions. They actually communicate through your metabolism with your brain. And various microbial patterns in your gut are associated with depression and insomnia and stress and metabolic syndrome and many other things. So how does it work? Well, it turns out that our gut microbiota, the bacteria in our gut, actually produce precursors to serotonin, such as tryptophan and tryptamine. So precursors to serotonin, they also influence serotonin production in the gut. I'm not even sure if you knew that our gut actually makes serotonin, and our gut actually has serotonin receptors. Serotonin is a major chemical in neuronal signaling and is very important in depression, as you know, right? So it turns out that actually our gut is the main serotonergic organ. So our microbes also make something called MAMPs. So MAMPs are microbial-associated molecular patterns. So it's basically a certain set of molecules that act upon toll-like receptors here and also influence the serotonin secretion and production. And also, our microbes produce something called short-chain fatty acids, and I'll talk about it more. Short-chain fatty acids that are extremely important, are in themselves are epigenetic modifiers. And so via this modulation of serotonin secretion and metabolism, our microbiome communicates with our brain, and then, of course, in return, our brain is able to further modulate multiple functions of metabolism and mood and so forth. So again, I'm just talking, but actually there are a lot of studies dedicated to this. So these are not just theories or words. So major journals are publishing on this topic. So Nature, which is one of the major scientific journals, is publishing on the gut microbiota and host metabolism. Nature, another article, human gut microbiome is associated with obesity. Another article from Cell, microbiota and sleep, in case you didn't believe me. What do our bacteria have to do with sleep? Then we have Frontiers of Endocrinology, right? The microbiota gut-brain axis article. Then we're talking about, again, Nature journal, talking about how to leverage diet to engineer the gut microbiome. And then additional publications on BPA. So again, remember the slide how everything is connected? Well, it turns out that BPA from plastic actually impairs cognitive function because it alters microbiome, in turn altering serotonin pathways. And physical activity is associated with different types of microbiomes as well. So if you do a search on PubMed, which is our official scientific engine, 47,000 results come up when you look up microbiome and health. That's how important it is. But here we go. So I was looking for a graphic for this presentation, this graphic, right? Oh, so now we understand how important microbiome is, right? And we have to think more about it. And you know where this graphic is from? Purina website. So it turns out that Purina, right, wants to provide microbiome-centric intervention for pet health, and that's the main thing on their website. Has your doctor ever talked to you about your microbiome? Have you thought about your microbiome? So basically, why are we not involved? So let's think about our microbiome. So microbiome is flexible, and there is evidence to it. We can manipulate it. So this is a very famous study. It's one of the key studies in microbiome. And basically what it did is it demonstrated that microbial diversity is the greatest in people prior to immigration to the US, various species. And then as they progress through their life and generations in the United States, the microbial diversity actually goes down. And this reduced microbial diversity is associated, of course, with obesity and metabolic syndrome, right? And the change in microbiome is so that the percentage of Prevotella, which digests fiber, goes down, but then the Bacteroides, other type of bacteria, go up. So basically, here's your direct association. And then we'll have to remember about fiber. So if we think about the names, right, because you would think, well, which bacteria are good and which bacteria are bad. So I'm not going to talk about bad bacteria because there's just too much information and we don't care about them. What we want is we really want to foster the good guys. Well, it turns out that for me, I'm not a microbiologist. There are just so many and the names are very complicated. I can't even pronounce them. But if you want to remember some of them, so one is Roseburia species. And Roseburia species are important. They modulate inflammation, and they're major producers of that short-chain fatty acid that's very important, butyrate. And the other one that you should remember is Faecalibacterium presnici. So Faecalibacterium presnici. So it's a very important microbe in our gut. It's one of the main ones. And it's very important for anti-inflammatory action and is a major producer of these short-chain fatty acids, and one of them being butyrate, and actually butyrate is a histone deacetylase inhibitor. And again, if you're a physician and an oncologist, you actually know that we use histone deacetylase inhibitors as drugs to treat cancers. And here you go. Actually, our bacteria produces our very own histone deacetylase inhibitor that massively affects DNA expression, causes epigenetic modifications, and modulates inflammation and immunity and metabolism and our brain health. So how do we feed these guys? It turns out that they're compounds called prebiotics. So prebiotics are substrates that are selectively utilized by microorganisms to benefit our health, right? So they feed the good guys. The ones that have the most action are oligosaccharides in the category of non-digestible fiber. So the idea is that you're eating fiber that you can't digest, but these little guys, the bacteria can digest it, and they eat it and they thrive on it, right? And then they convert this fiber to these short-chain fatty acids. So among these compounds are galacto-oligosaccharides, and those are in lentils, chickpeas, and beans. So what I have in my house is I have 3 rice cookers, so 3. So one has lentils every day. It keeps them nice and warm, so my kids have lentils every day. And again, this is a result of, of course, research and so forth, but personal experience, because my little kid has brain gut disorder, so cyclical abdominal pain syndrome, and he couldn't eat anything in the morning, so he'd always be sick, he'll have belly pain, he'd be skipping school. And so what I did, I was like, okay, let's just try for you to eat lentils every day. And this is before this lecture and before I looked this up. And so once he started that habit, actually he stopped having these episodes of severe abdominal pain and kind of depression and so forth. And then I was like, wait a second, let me actually look this up. Let me see whether this food was medicinal for him. And again, maybe not, it's an anecdote. I'm a physician, and I don't believe in anecdotes. But at the same time, we say, first, do not harm. I really don't know anyone who harmed himself or herself with eating lentils. So the next one is inulin, and that's in chicory root. I think chicory is more popular in England, but I don't encourage you eating chicory roots, but they do make supplements out of it. But onions are very common. The other one is fructooligosaccharides, and those are in garlic, asparagus, bananas, and artichokes. Other type of sugar is arabinoxylan in whole cereal grains. So when you're choosing your cereal, you really want something that's not shelled, right? Not like white polished rice, but something that has that outside layer. So buckwheat, my parents are from Ukraine. That's the main producer of buckwheat. Also amazing superfood for that. Then pectin and pectic oligosaccharides. So one of the main vegetables, fruits we know with pectin is apple, right? Remember, eating apple a day keeps the doctor away. So actually it's because apples contain these prebiotic compounds. And then the other interesting ones are azomalto-oligosaccharides, and those are contained in miso and in honey, so also interesting. So the other ones you've seen already are polyphenols, so yet again that green tea, and again red grapes, and also seaweed and algae have some prebiotics such as fucoidan and lemur and so forth. So, and of course you can look this all up, right? This lecture is just for you to think about these things, and then now in the information age, all information is out there for you. You just have to think and remember about these things. And intermittent fasting, of course, right? So everybody is talking about intermittent fasting. Does it really work? How does it work? Well, it turns out that it really does work. And you know what? It's completely fine to skip breakfast. And again, complete anecdote, but I have never eaten breakfast in my entire life. And it's because I was traumatized by kindergarten breakfast in the Soviet Union where I grew up. And I'm standing here, so you're gonna be all right if you skip that bacon and eggs. And how does it work? Well, it turns out that the periods of intermittent fasting actually change your microbiome composition, and the microbes that are upregulated, that thrive in those conditions, make acetate and lactate, which converts white fat, and we talked about it, this immobile storage depot of fat, to beige fat, which is the fat that is able and wants to burn calories, right? So basically, when we're doing this intermittent fasting, we're changing our microbiome and we're converting white fat to beige fat, and it's all very beneficial for our metabolism. So in addition to intermittent fasting, there are multiple studies demonstrating that there are some foods that also cause beiging of white fat, and that's curcumin, capsaicin, and hot peppers. And interestingly, research is showing that they're pain pathways. So it's like with pain, you're gonna get all excited, right? Maybe your muscles contract a little bit. You're, a little bit so hyperventilating. So there's this adrenaline coming in. So it's a similar biochemical pathway with capsaicin and hot pepper. Then green tea and coffee again, and grapes. And then other process, so other variable that we can control, but not here in Cayman Islands, is cold. So actually cold changes the white fat to beige fat, and they even have studies on cooling. So you say, well, how do you do it? So there's one study showing that basically spending about 10 minutes at 12 degrees Celsius, you produce generation of beige fat from white fat in humans. So not terrible cold exposure, but something quite tolerable. So here you go. Just remember, I made this graphic and it took me a lot of time. So that's why I'm showing it for the third time. So it's called your health mandala. So if you remember this, I don't know how you will remember it. You can make a tattoo. I can share it with you. So you will live longer. Your cancer risk will be down. And I think you'll be a little bit happier as well via serotonin production in your gut. So it's all connected. So, and of course, we have to walk hand in hand. I can't do this without you, right? When I talk to my patients at the first visit, I always say we're partners. Right? I'm not authority. I'm not here to tell you what to do. I can only arm you with knowledge and I can give you the best care, but it's really 50-50. So, all of us, we have to do our 50%. And that's, and the 50% is really the principles of lifestyle medicine: nutrition, exercise, rest, and social connectivity, which all leads to these epigenetic modifications and improved metabolic health. So at MCI, we're ahead of the curve. I'm not going to just say all these things and not do any research, right, and not find out more. So actually, we have a research project in our hematology clinic. So first, in order to introduce this lifestyle modifications best, we need to know our population. So we're analyzing our clinic population for the prevalence of lifestyle modifiable illnesses, and actually our abstract was accepted to the Lifestyle Medicine Conference in Orlando, where I'm going in a couple of weeks to present our data. Right away, I can tell you it's very important to have these lifestyle modifications because only 29% of our patients are in the healthy weight bracket. So also, to make it all doable, this is not all just words. We're introducing the automatic dot phrases that are basically prompts on how to counsel on lifestyle modifications and how to document them. Because I'm busy in clinic, right? And I want to remember what to say, how to say it, and I want to put it in the chart. So if my patient tells me, Dr. Linhares, you didn't tell me about it, I say, no, I did. And here it is in the chart, and I'm going to say it again and again. And actually, all these interventions in lifestyle really do work. It just takes a doctor-physician-patient relationship. And it turns out that oncologists and patients have the closest relationship. It takes a lot of trust. And therefore, I want to use this trust in changing my patient's life, not just curing their cancer, but instead of taking away years of life, potentially with chemotherapy that ages you, I want to give you years of not just life, but healthy and happy life and active life. And I couldn't do it alone. So at MCI, we have incredible supportive services. So because the keystone of lifestyle medicine is really collaboration, right? So not only we collaborate with our microbiome, but I collaborate with my wonderful colleagues with physical medicine and rehabilitation, nutrition, we have massage, we have acupuncture, we have survivorship, we have psychiatry. So we're really not there to just give you chemo and give you different scans, right? But we use every opportunity to improve your epigenetic background, your microbiome, and convert your white fat to the beige fat. And thank you.
We're all coming away with something from today. We get lots of knowledge from this. Now, we've focused a lot on our physical health, Now is the time for us to focus on our mental health. Both are equally important to our overall health. So thank you to Infinite Mind Care for supporting the conference for many years. And we're now looking forward to hearing from Raquel Tobin and Derek Oliver. They're going to be presenting today from burned out to checked in, understanding burnout and moving from coping to resilience. Let's welcome them.
All right, I think we're good to get started. I'm Raquel Tobian. I'm here with Derek Oliver. We're psychotherapists at Infinite Mind Care, and we're very excited to be talking to you guys about this incredibly important topic of burnout, something that I know probably 20 to 30% of this room is struggling with. So before we get into burnout and what we can do, I just want to review what our goals are for today. First, we're going to define burnout. I want you to know what burnout looks like in yourself, in your colleagues, how to recognize it, how to know when you're seeing it. I want you to understand the causes of burnout. I also want to help you understand the biology of our stress response and why we burn out. That's going to be critical to helping us cope with burnout in the short term and learn how to begin the recovery process. And then I'm going to turn it over to Derek, and he's going to talk to you about long-term recovery, coping, and resiliency. So first, what is burnout? Burnout is a term that was coined in 1975 by Herbert Freudenberger. And initially, burnout was started in looking at the healthcare professions. So all of us in this room, we are why burnout was coined. I know, it's not great, but it's also why we're talking about it. So it came out of noticing that helping professions would occasionally get to this point where instead of seeing their clients or their patients as people, they started seeing them as boxes or, I just need to check a box. I'm depersonalized, I'm detached, right? It's just another thing I have to do today instead of being able to connect with them as a person. So what started as research in the helping professions expanded, and we now know that actually 20 to 30% of all professions struggle with what we call burnout. So burnout is defined by these three core components. The first one is cynicism. So that's that overtly negative view about the world, about ourselves, about our abilities. The next component is exhaustion. It's the physical, the mental, and the emotional piece of just being tired. Lastly, reduced personal achievement is a core component of burnout. So we add cynicism, and that's often what takes us to reduced personal achievement. I'm cynical, I don't think things can change, and therefore, why would I try? So what are our signs of burnout? Our signs of burnout are multifaceted. We have physical, emotional, behavioral, and cognitive signs. Physical, since exhaustion is a core component, we see people looking tired. Because they're going to be under chronic stress, we're also going to see lowered immune system functioning. So it's those colleagues that just keep calling out sick because they are actually getting sick more frequently. We might also notice changes with frequency of headaches, increases in muscle pain, changes to our sleep, and changes in our appetite, both overeating and undereating. Emotionally, this is where you start to see that cynicism component come in. People become unmotivated. They have a sense of failure, that sense of helplessness, right? Nothing I can do is ever going to change this. They are less satisfied in their jobs, and again, cynicism is what really defines the emotional component. Behaviorally, you'll start seeing shifts in people. Those colleagues or employees that you had that were really gung-ho, they were talkative, they were chatty, they were engaged. Now they're isolating, they're withdrawn. They don't speak up in the meetings, they don't have anything to say. Those people that used to really be on it, now they're kind of procrastinating. You used to get that thing when you asked for it, And now you're having to ask 2 or 3 times because that person is starting to burn out. You may not observe this in your colleagues, but certainly we see this with our family members or our loved ones when they're burning out. The substance use at home. It used to be, ugh, come home from work on a Friday, it's been a long week, I need a drink to decompress. With burnout, that might start to be, I come home from work on a Monday, and a Tuesday, and a Wednesday, and a Thursday. And it's every day, right? So that increase in substance use as a way to cope with stress is a warning sign for us to look out for. You might also notice employees skipping work, right? So those increase in call-off days, that might be in part because of the physical response of burnout and actually having lowered immune function. But they might also start coming in a little bit later, right? That person who used to be on time is now just consistently 5 minutes late, and then 10 minutes late, and then 15 minutes late, and their lunch breaks are longer, and they're kind of skating out the door 10 minutes early every day. The cognitive component of burnout is the one that I think personally scares me the most. So when we start to burn out, our brain changes, right? In response to prolonged stress, we have slower processing speeds, our concentration and focus are impaired, and we're not great problem solvers. So now that you know what burnout is, we are going to talk about what causes burnout. And this is one of the most popular theories of burnout. This is our job demands resource theory. So job demands are the first part. And job demands are aspects of our job that require considerable effort and result in physical and psychological costs. So it's things like having an incredibly high workload. It can be time pressure or deadlines. It might be long hours that start to interfere with your work-life balance, take you away from your family and your home. Or it could be things like conflict with colleagues and supervisors. So job demands are one component of what causes burnout. According to research, they're the #1 component, specifically high workload. So take note of that, because that is the one thing that if we can change it, it's the best predictor of burnout in the workplace. But high job demands are not enough by themselves to cause burnout. High job demands have to be coupled with low job resources. So our job resources are the aspects of our work that keep us feeling really energized. They keep us wanting to be engaged, wanting to move forward. They grow us. They're our personal development things. And so job resources might look like good social support from your colleagues, good supervisory support, being able to get feedback when you need it that is constructive and useful, developmental opportunities, variety, and critically, a job resource is also autonomy over your workload. So, burnout is not just high job demands, it also has to be added to job resources being reduced. Specifically, those 3 core components of burnout that we talked about, when job demands are high, they lead to exhaustion. When job resources are low, that is where we get the cynicism and low self-efficacy. And I want to point this out because many of us know people, or maybe we've been those people, where we're like, that job that you just described with the high demands, I have that, but I don't think I'm burned out. Because job demands alone don't predict burnout. They might predict exhaustion, right? You might ask your friend, hey, how are you doing? And they're like, oh my God, I'm doing too much. I'm overwhelmed, I'm exhausted, but I'm loving it. I'm really excited by the work I'm doing. Those people are not burned out. We can have high job demands with high job resources that support us coping, and that helps reduce burnout. I also just want to add briefly that while I'm talking about this in relation to our workplace, this model really applies to anyone who feels overworked and undersupported. This can also apply to those working in the home. Parenting burnout is becoming an area of research because, let's be honest, the job demand of parenting doesn't really get any higher. You never get a day off. You never even get really an hour off. And depending on the support you have, you might be in that low job resources category. I want to mention a few other factors that impact burnout. I want to stress that the workplace factors are the most important. Research supports that it is the workplace factors that drive burnout. That being said, there are certainly lifestyle and personality traits which contribute to burnout as well. And you'll see a lot of overlap with these two. For example, if you're someone who needs to be in control and you struggle to delegate, you're going to match up with that lifestyle factor of taking on too much without asking for help. Many people who are perfectionistic or these type A high achievers are at higher risk for burnout. I want to mention specifically high perseverance. So that's a personality trait that we generally value. We really like people who can push through when the going gets rough, right? We're like, yeah, that's good. Keep pushing. Things get tough, you make it through, you get on with life, that's awesome. But with burnout, that actually isn't very awesome. When we continue to push in the face of chronic stress, we're going to burn out. Instead, we need to have a different approach. We need to ask for help, or we need to find a different way to cope with our stress. So now I want to talk a little bit about the difference between stress and burnout. I want you to think about stress as being too much, and burnout as really being not enough. So if stress is over-engagement, it's that person you work with who has way too many balls in the air. They are juggling way too much stuff. Burnout is complete disengagement, right? It's that person who's not really taking on anything and not contributing much because they're burned out. If stress is your emotions are being overreactive, right? You're snippy, you're on edge, you've got increased irritability, your anxiety is higher. Burnout is the opposite. Emotions are blunted or kind of flat. So instead of being irritable and on edge, people are just kind of like, meh, whatever, I'm checked out. Stress creates this sense of urgency and hyperactivity. Burnout creates helplessness and hopelessness. Stress might result in a loss of energy, but burnout is a loss of motivation, ideals, and hope. Stress is primarily physical, where burnout is primarily emotional. Stress might lead to anxiety, but burnout leads to detachment and depression. My caveat there is that there is a lot of overlap between depression, anxiety, and burnout, but research does support that burnout is a unique construct separate from anxiety and depression. Stress can kill you prematurely, but burnout will make you feel like your life is not worth living. Now, to understand a bit more about the relationship of stress and burnout, I want to talk about how burnout is a phased approach. So burnout is not an event, it's a process that occurs for us. And this is just one model of the phases of burnout. It's supported by many of the prominent researchers in this field. There are others out there, but they all sort of follow this same progression, different words, different kind of breakdowns. Some of them have 3 phases, some of them have 8, some have 12. 5 was a nice happy in the middle kind of number to pick. So phase 1 of burnout starts with a lack of recovery. So all of us all the time are going through stress in our life. It's a daily occurrence for us. And if we're lucky, we get to go home and we get to decompress, we get to recover and deal with our stress. However, for any number of good and valid reasons, we might struggle in our life to have these recovery moments. For example, you work at one of those really high-stress jobs with high job demand, low job resources, and then you come home and let's say your marriage is on the rocks. Your recovery time isn't there. Or let's say your marriage is great, but you come home to 2 small kids and they're frankly demanding. So again, the recovery time gets limited, or you're caring for an ill spouse. And that's how burnout starts, right? When our stress is outpacing our ability to recover. Once that happens, we move to stage 2, which are changes in our stress physiology. So when we're under chronic stress, one of the neat little tricks that our body does is it actually kind of ups our stress threshold. So maybe my baseline used to be here, but now because I've been stressed all the time and I haven't been able to recover from it, my body is just like, oh cool, we're gonna operate up here from now on. So my stress threshold has gone up, and because of that, you're gonna start to see some of those changes with your sleep habits. It's gonna be difficult to relax. You might see people looking really restless or fidgety. And then, when that starts to happen, we move to stage 3. And stage 3 are our chronic stress symptoms. So these mirror a lot of those signs of burnout, and this is also the stage where we start hearing people say, I'm burned out, I'm exhausted, I'm tired, I don't know if I can keep doing this. So it's in that stage where we're having the physical, the mental, the emotional, and the behavioral changes where people really start to feel a sense that they are burning out. If we continue on and we don't recover, we move to stage 4. And stage 4 is pseudopsychopathology. So this is a lot of that cognitive process that I was talking about. So when we're under chronic stress, our brain does not function as well as it normally does. In order to function, we do things like make our worldview more narrow and more rigid. It's easier for us when things look like it's a black and white decision, right? If I only have 2 choices, my stress is reduced. If I have thousands of choices about how to handle a situation, that can be really stressful. So part of the way we cope with chronic stress is our brain kind of gets narrow and rigid. That reduces our creativity, it reduces our empathy, and it reduces our ability to self-reflect. Now, one of the interesting things about this stage is this is also where people start to get blamed for their own burnout. Because we see them doing things with this really rigid thought process, and we see them not problem solving very well, kind of not being a team player. And so we blame them for this process, and we're like, oh, it's that they don't know how to cope, it's that they have something wrong with them. And they do, they're burning out, but it's not necessarily a result of a personality trait at that point. Our last stage is clinical burnout. So this is where we get to kind of the end, right? Where we have moved well beyond chronic stress into that burnout of too much to not enough. Complete emotional breakdown, fatigue, passivity, the learned helplessness of it doesn't matter, there's no point, nothing I do will change this. We also notice the mood problems, right? That sounds a lot like depression because there's a high overlap there. And that picture on the bottom of the screen is an actual photo of a burned out employee for helping you recognize them in the workplace. So what do we do about burnout? We understand what it is, we understand what causes it, what do we do about it? So there are 6 areas of Maslow's work-life model, and she identifies a chronic mismatch between employees and their work settings in these areas. As an organization, these are the areas that you need to focus on making changes. To the greatest extent possible, make workloads manageable. Create a reward system for your employees that helps them stay engaged. Fairness in the workplace is a huge driver of burnout. Companies that have values that match their employees' values, those employees burn out less. Companies that have a sense of community and connection, those employees burn out less. And also, I've mentioned autonomy several times, but employees being able to have control to the greatest extent possible over their workload, over their functions in their job, that is going to help people burn out less. So this is also, just want to note there, that control piece. We've seen so many employees dissatisfied after working from home for years during COVID and now being told, come back to the office and do your job. That speaks to the control, right? Working from home gave employees a great sense of control. And when we take that away, you increase the odds of burnout. Now, historically, most interventions for burnout focus on the individual. I want to point out that that is not technically a solution because the root cause of burnout is in the workplace. So I want to highlight that. Yes, thank you. So I want to point this out because there might be some higher ups sitting in this audience with me. I hope there are. And I want you to pull your phone out and take a photo of this and go back and think about what you can do for your employees to reduce this, because burnout at its true root cause is in the workplace. Now, that being said, I can't change any of your workplaces. That is terrible news, I know. And the reason we focus on individuals is because we are at the heart of the change process. I also believe that the more individuals value taking care of themselves, understanding burnout, understanding how to cope with it, the more likely we are to create workplaces that foster healthy individuals, that foster appropriate workloads, fairness in our culture, autonomy, control, and all these good things. So, since I can't control your workplace, but hopefully you can control, at least to some extent, yourself, we're going to talk about what you can do to manage your stress and your burnout. So the biology of burnout, our stress cycle. I want to plug this truly amazing book. This is by the doctors Amelia and Emily Nagoski. It's called Burnout: The Secret of Unlocking the Stress Cycle. They talk about prominent research on burnout in a way that is engaging, accessible, and honestly funny. I recommend this book to everyone who struggles with burnout. It is written for women specifically, but I don't know anyone who would not benefit from reading this book. So, in order to understand how to combat our individual burnout, we need to understand what's happening in our body and our mind, and we need to differentiate between our stress and our stressors. So first, our stressors. Our stressors are what activate our stress response. This is anything that you see, hear, smell, taste, touch, imagine that might do you harm. In our modern world, our external stressors are things like our jobs, our work, our money, our family, our time, and the expectations put upon us. Outside of our external stress, we also have our internal stressors. That can be things like our self-criticism, our body image issues, our identity, memories that might come up, or worries about the future. The list is truly endless of the things we can come up with as humans which can cause us stress. Now, at any given time, our body can perceive any of those potential stressors as threats to our safety and well-being. And when that happens, our stress response gets activated. And our stress response is the neurological and physiological response that happens in our body when we face one of these threats. Nope, I want to go back, sorry. Too quick. So the best news that I have for you today about stress and stressors is that dealing with your stress is a separate process from dealing with your stressor. And the reason this is great news is for many of us in this room, when we think about the things in our life that are causing us stress, they're not going away. We don't get to get rid of them. Most of us continue to have to go to work every day because we want to pay our bills and keep a house and food on the table. Our family, we're generally not trying to get rid of them either, even though they might cause us some stress. So many of our stressors as modern human beings are prolonged and unrelenting. And the good news is that that's okay, because we can deal with our stress without addressing the stressor. So let's talk about that a bit. So first, what happens in our body when our body is under stress? So that neurological and physiological response that happens when we perceive a threat. From an evolutionary standpoint, this is a survival mechanism. Our body does all sorts of amazing things in response to stress. We get a rush of epinephrine, it pushes our blood into our muscles, it gets us ready to get going. We get glucocorticoids to keep us going. We get endorphins, which help us ignore how uncomfortable we feel. Our heart beats faster, our blood pumps harder, we breathe more quickly, our muscles get tense, our pain sensitivity goes down, our attention hones in on the threat, our other organ systems get deprioritized. So quite literally, our entire body and mind change in response to stress. So I want to talk about why that's important. And I want to start out by imagining for a moment our stress response as an evolutionary and adaptive and useful thing. So imagine yourself being chased by a vicious blue iguana. Now, so you guys are laughing because a lot of you have been led to believe that the blue iguanas are safe, docile creatures, but I submit this video evidence of a blue iguana trying to make me a snack. There it goes, yep. So, proof positive, you're being chased by a vicious blue iguana. Your body's stress response, all that stuff I just talked about, right? The epinephrine, the glucocorticoids, the endorphins, they all get online. And what do? Well, you probably go, should I fight the iguana? No. I heard they take off fingers. Should I run? Probably. He's got stumpy legs. So you run, and you outrun the blue iguana. You run down the street, you get to a house, you fling open the door, you slam it shut behind you right as the iguana's about to get you. And you go, and you breathe a sigh of relief. And then you realize it's your friend's house because that's Cayman, so of course you know these people. And they're like, oh my God, are you okay? Let me get you a glass of water. Take a deep breath. You're safe now. I can't believe that iguana tried to get you. And you start feeling better, right? Your body starts to release some of those stress chemicals. And you probably think, it's because I outran the iguana. Good for me. I got away from the iguana. My stressor is gone. However, you would be wrong. That is not why you feel better. You feel better because you ran. You feel better because you got to your friend's house and you had social connection and support. Because dealing with your stress does not equal getting rid of your stressor. That is not biologically how we work. So, most of us are not being chased by the blue iguanas or lions, tigers, bears, oh my. We don't have a lot of life-threatening encounters with wild animals anymore because we've evolved. So instead, we have things like a stressful meeting at work. And maybe you've been in one of those meetings where you're sitting there and that colleague that is just kind of a jerk is saying some things and your blood is boiling and your heart starts beating a little bit faster and maybe you even get a little red, you get a little hot, and then you say nothing and you leave the work meeting. And if getting rid of the stressor took care of your stress, that would be perfectly acceptable. But it doesn't, because you leave that work meeting and instead you stew in that all day long, right? You think about it multiple times, you go tell one of your other colleagues about that jerk in the meeting and all the stuff he said, and then you probably tell your spouse about it at home, right? Because you don't get rid of your stress simply because you're no longer in that work meeting. Therefore, getting rid of your stressor does not get rid of your stress. Now, that is actually good news. I know it doesn't sound like it, but this is why you're not all gonna go quit your jobs if you're burned out. So, the difference between stressors and stress, right? Stressors, they live in our mind and in this logical processing portion of our brain, but stress lives in our body. So in order to complete our stress cycle, we have to speak the language of our body, which doesn't mean quitting our job. So I want to talk about some short-term solutions to begin completing your stress cycle. Because every time you have one of those meetings where you build up all of that stress and then do nothing about it, you have an incomplete stress response. So these are tried and true methods to complete your stress cycle. Every doctor has told you this: exercise. I know, I'm no exception. There's a reason they say it. It's really good for you. 20 to 60 minutes a day, any exercise of your choice. It doesn't even have to be like real exercise, is kind of what I'm gonna say. Like, you don't have to go for a run. You don't have to lift weights. You can dance it out Grey's Anatomy style in your living room. Anything you do to move your body that gets you breathing deeply is gonna complete your stress response. It's why outrunning the iguana completes your stress response. not because it didn't get you. If you are burned out and you're like, I can't believe you're suggesting to me to exercise, I am here in helpless, hopeless, burned out land, I don't have the energy for that. There are things that require less energy that also complete your stress response. The easiest and most simple one ever, breathing. We're all doing it, but we're not doing it intentionally. So breathing the way we are right now, just our body keeping us alive, and that's great. But when we do mindful, deep breathing, right, really taking in that deep breath and exhaling deeply, that helps our body know that we are calm and safe again. That completes our emotional cycle and reactions. One breath is probably not enough. I will say you have to do it a little bit longer than that. Other ways to complete your stress response: seeking support and having positive social interaction. So again, when you outrun that iguana and you get to your friend's house and they're super caring and they give you the glass of water and they tell you to take a breath and they tell you, hey, you're safe now, it's okay, calm down, right? That positive social interaction is also a piece of completing our stress response. And you can do this with anyone. It doesn't have to be with close friends. It doesn't have to be with family. You can do this with having a casual, positive interaction with the barista that's getting you your coffee, with your colleague in the lunchroom, anybody. We believe that we will be happier if the stranger on a plane does not talk to us, but research says that's not actually true. Research says our well-being is better when we have pleasant social interactions, even brief ones, with anybody, including strangers. Laughter is another way to complete your stress response, but it's not little laughter, right? It's like big, embarrassing belly laughs. So things that you are like, I'm inappropriately cracking up and I don't want anyone to ever see me do this in public. That's the kind of laughter that completes our stress response. Sometimes thinking of things that have made you laugh like that will do it. Other times you might go to TikTok and just scroll until you find one. Physical affection is another key way to complete your stress response. So this is going to, I hope, blow your mind because it totally blew my mind. A 20-second hug can do as much to help your body know that it is safe as jogging for a few miles. Yeah, I mean, congrats. We don't have to jog, right? Yeah. Now, I just want to be really clear because this is a healthcare conference. The hug will not help your cardiovascular health. It will not help your weight goals or health goals in the same way, but it will complete your stress response in the same way. And you can try this tonight, right? If you go home and your partner comes home from work and they are just stressed out, maybe you get to go home to somebody who isn't, but most of us are stressed when we come home from the workday. Give them a proper hug. 20 seconds, which is awkwardly long even for the person you're sharing a bed with, okay? But what you'll see happen when you do that, when you really properly hug them, a lot of people when they're stressed will kind of be like, get off me, leave me alone. But if you just kind of keep doing it, eventually that person will go, and they will relax into it. And that is our body completing some of our stress response. All right, 2 more quick things, and then I'm going to turn it over to Derek. Creativity, that thing that you're passionate about, that you love doing, whether it's art or it's music or it's dance, get into your creative purpose. It's how we complete our stress response. And lastly, anybody who has ever said that crying doesn't solve anything is wrong. It does. Crying will not solve your stressor. It will not do anything to change it, but you will consistently feel better because you're completing your stress cycle. So give it a cry.
Hello. I initially was going to walk around, but then they were like, they're recording it, and so, okay, here I am locked at the podium. I hate this. How does this thing work? Oh, there we go. Beautiful. Okay. We are starting off with an analogy because I find that analogies are really useful for figuring things out. The analogy we're going to use is you're a gardener. You might not be a gardener, but that's okay. We're pretending you're a gardener. And like all gardeners, you're not planting things because you hope that they'll grow and die before they do anything cool, right? That's not why we plant things in the ground. It's true. We're planting it in the ground because we're hoping it's going to grow and be whatever it's going to be, a tree or a flower or a pumpkin, whatever. Now, the way to get your plants nice and hardy, the way to get them to survive, to be tough, is you actually do something that in our society might sound a little weird. You actually really drench that little plant in everything it wants right when it wants it. You give it all the water it wants. You make sure that soil is full of nutrients. You make sure it's in full sun so it has as much food as it needs. And you do that for a while. Now, while that seed is first growing, you're going out every day and you're watering it, and you're looking at the same patch of dirt and you're going, nothing's happening. But you just keep watering it. You keep that soil wet, and you start feeling like, man, is this thing ever going to crack out of this soil? Is it ever going to happen? And then one day it does. It cracks up out of the soil, and you see its little head peeking out, and you go, oh my gosh, it's growing. I've created life, right? You feel like Frankenstein. In that moment, we can get too excited. Okay, it's ready, right? But actually in that moment, we should still be in this phase where we're drenching this plant with everything it needs and wants. We're not letting the soil dry out. We're making sure there's lots of light. We know this plant, right? We found out things about it. I know it needs this much nutrient. I know it needs this much sun. I know it needs this much water. We're still really following that as this little plant is growing and getting stronger. But as all gardeners know, the summer is always coming, or the winter is always coming. And with summer comes a hot sun. With summer comes drought. With winter comes freezing cold and heavy snow. How is this little plant going to survive? Well, the way it's going to survive is at some point I have to start getting this plant used to these harsh conditions. But when it's so young and tender, I can't just expose it right to the full heat of the summer sun. It'll wilt away. So what I do is I start stretching how long its soil stays dry. And I keep a good eye on this plant. I make sure it's okay. This isn't hurting it. I maybe leave it out in the sun a little bit longer than I normally would. Even if I see it's starting to get a little stressed. Let it be a little stressed. I can take care of it whenever I need to. Now in this phase, if I see this plant get sick, if I see something happen to this plant, immediately I go back to that default like it was a seedling. I got to take care of whatever's going on with this plant that's making it sick. I got to help it get strong again. So any plans I have for getting this plant strong, they go on hold while this plant is sick or injured. I got to get it healthy. Once it's back and it seems healthy again, I can keep stretching these conditions, making it go a little bit longer and a little bit longer. Maybe even I make it go a little bit harder than the conditions will be in summer, just to really push it, make sure this plant, it can do it. It can take 5-6 days without water. Then once summer comes or winter comes, I just kind of have to let this plant do what it's going to do. I've given it all it can have. I can keep an eye on it, but it's either going to survive this harsh summer or it's not, right? Now, I want you to keep this analogy in your mind, right? And try to see how it might be useful as we go a little bit further in this. We're going to take a quick little break. So I'll tell you easy. I'll give you this one right off the bat. In the analogy, you are the plant. Right? I know, it blows your mind. But you're actually other things in the analogy, so keep thinking about it. Plants need certain things. They need sun, they need nutrients like nitrogen and stuff in the soil. They need water. Humans are actually not really all that different. We like to think we're really, really complex, right? Like, oh man, I'm this whole story and I'm the main character, but we're not really all that complex. Basically, all we need is right here up on this wheel. We got to have food, and we need enough of it. And just like plants, different people like different foods, and they need different types of foods and different levels, right? That's all okay. We have to have water. We have to have shelter. We need a consistent temperature. We're sort of delicate as humans. Now, these other things on this wheel you may not have ever thought of as a need. You may have never considered that these things were needs, but they are. First one I want to talk about is engagement. Engagement is sort of like a mammalian thing, it's a primate thing. We really like it. It's fun, it's engagement. Boom, I just engaged with you. I saw your eyes. Bam, now we just engaged. That's awkward for him, maybe awkward for me, right? But we engaged. Throwing the ball back and forth. Boom, boom, that's engagement. Laughing at a joke when someone tells it, that's engagement. We have to have that in our life to grow and feel relaxed, to rest, to have our brain be keyed into, you're safe, it's okay. The next thing I want to talk about is nurture, care. We need that from other people. We really do, right? As babies, we're born really, really premature, and it's because our heads are so big. We have to do a lot of our developing outside of the womb, right? Have you ever met a baby? Or is it good at anything? Right? It can't carry a conversation with you. It can't walk. All it can really do is cry and scream. That's it. We have to teach that baby how to be a person, and we don't have the luxury of doing that all in the womb. We have to do that outside in society. So part of the way we keep that up is in our early relationships. Our caregivers, they provide us that nurture, and they teach us about ourselves. As a baby, if I cry, and my caregiver, boom, right there, and they're trying things to get me taken care of, I'm going to learn something about the world. If I'm a little baby and I cry and nothing happens, I learn something about the world, right? So we need to be mindful of this as we move on. These are all needs for our little systems as they're growing. They're needs for you right now as well. Next one I want to talk about is structure, consistency. As a human machine, we're sort of, designed, I guess is a good word. We're designed to test the structure and integrity of the environment around us. What that means is if I paint this podium and I put a sign up here that says wet paint don't touch, somewhere between 40 and 80% of you will want to touch this wet paint. And the reason is not because you're jerks. The reason is because you want to know, is it really wet? Is that sign lying to me? Oh yeah, it's really wet. There we go. I figured it out. Right? That's that structure and consistency. We want to know, how do I get what I need when I need it? And how reliable is that? The more consistent, the more healthy we are in the future when things aren't so consistent, like the little plant. Perfect. Okay. So keep in mind that wheel, and I can go back if I need to. Our natural experiences of reward, relief, loss, and pain shape how we go about getting those needs met. What that sentence means is, if I'm a baby and I'm looking for engagement, and I go, and my mom does nothing because she's stressed out or she's scrolling TikTok or something, I might try again a little bit differently. And if nothing happens, I might, and I might kick and cry. Oh, if mom attunes to that and she comes over and gets me nurture, ooh, this organism has just learned something about how I get attention. I gotta cry a little bit. On the other side, if I go, and my mom right away goes, oh yeah, you're talking. Then I learn, oh, okay, that was enough. All I had to do was reach out. These experiences that you go through, they bring these four things, and I want to talk a little bit more about them. I'm also a behaviorist in addition to being a psychologist, and these are like simplified names for a complex thing, but I think this is an easier way to deal with them. So, reward and relief. When you encounter reward and relief in your life, you will do that thing more. If I do something and I get food for it, and I like that food, I'm going to be more likely to do that thing again because it got me food, whatever that thing is. If it's saying, may I please have a cookie? If it's having a big fit that lasts 3 hours until I'm shaking and mom's crying and then mom goes, oh, I'm so sorry, here, have a cookie. Then that's what I'll do, right? Relief. Anything that brings me relief, I'm going to do more of. I have a headache. Oh, man, I take some aspirin. My headache goes away. Oh, next time I have a headache, I'm more likely to take aspirin because that brought me relief. Yeah? Loss and pain. Those experiences are going to make you do less of that thing. So if you go up to your mom and you say, Mom, can I have a cookie? And she goes, oh, you're getting kind of chunky. You're stressing the pants there. I can't give you another cookie. That's a punisher. You're probably not going to ask that again. You're going to go, oof, right? That's that pain. Mom just said something mean to me. Loss. If I do something and I lose something, I go speeding by and a cop catches me. This actually isn't a good example because people still speed all the time. But if cops were perfect and always caught you for speeding, and you got that fine that drained your bank account $300, you would stop doing that, unless you were a billionaire and you didn't care about the $300, right? But most of us, we can't afford that over and over. That loss causes us to do less of that thing. Now, I want you to take a minute and kind of think about what your experiences in life have been. What were the lessons you learned in your young home? What were the lessons you learned in your young life? What are the lessons you've learned in your workplace? I'll guarantee you it's still being moderated by these 4 experiences. Now, this is all to say that these things become your default setting. Your default setting is like your default program, and it's your reactive place. If I'm in my default setting, and I'm happy to share this with all you, my default setting from when I was little was be the sick kid. I was the last of 5. I have significant health things, but I learned to really lean into it, right? Oh yeah, okay, because this gets me the attention. I had 4 older siblings. They were in band and play and cheerleading. I wasn't getting the attention I needed, so I played the sick kid. Oh, it wasn't until my 20s that I recognized I'm still doing this. I'm still playing the sick kid in relationships and in jobs and in all of these things, right? That default, that reactive place, it contributes to burnout. Because like Raquel was saying, our anxiety is not good at making decisions. Anxiety is not good at performing your job. And defaults put us right into that anxiety place where we react in these ways. As humans, we're a bit like computers. I've used the word program a couple of times, but unlike computers where I just install a new program or delete an old program, as a human, the way I replace a program is by repetition. The more I do a thing, the more that becomes the default program. The less I do a thing, the more that becomes less of a program. It doesn't really run very frequently. And if I can do it really not at all, it'll eventually kind of die and fall off. As we work on developing grit, this idea of perseverance, this idea of strength against the environments, because like Raquel said, often our environments don't change. And I think that's because environments change slowly. Over time, they evolve and they morph, right? Hopefully in 500 years, our society won't look like this. It'll look better. But we're not going to be alive in 500 years. We're alive right now, and we need to get strong. That grit development is going to take a lot of you moving against your own defaults, choosing to do certain things over and over and over every day until they become your new default. The tool by which we are going to accomplish this is mindfulness. I'm sure some of you have heard of mindfulness. I'm sure some of you probably know a lot more about mindfulness than I do, but I know a fair amount. Mindfulness is a tool for self-awareness. It's a tool for self-development. It's a tool for you to be able to build yourself into the kind of you you want to be. As humans, we have extra areas of our brain, which means we're not locked into our evolutionary baggage. I don't have to just do what everyone else in my family or species does. I can do something new. Mindfulness is a state of awareness of self, and what I write up here is that it's becoming aware of everything it means to be you right here in this moment right now. And I actually want to practice this. One thing I have down here, which I think is important to note, a lot of people come to me and they've heard of mindfulness and they get this idea that mindfulness is this like state of nirvana, like empty-headed, floating on the cloud thing. It's never been my experience of what mindfulness is, right? Mindfulness is, I'm sitting here for 30 seconds, I'm going to be mindful. And at the 5-second mark, I go, God, I'm really bored. And becoming mindfully aware of that. Oh, wow, I'm bored after just 5 seconds. Okay. All right, how does that feel in my body? Yeah? We're going to do this together. I want you to try to become mindful. I'm going to sort of narrate a little bit of this. You can close your eyes. You can keep your eyes open. You can do whatever you'd like. I want you to take a moment and become aware of what you can hear. Can you hear more than you initially thought you could? Stress that sense. Push it out. What can I hear? Let's move on to the second. Can you feel yourself in this chair that you're sitting in right now? What's the weight of your clothes like? Can you feel your shirt on your body? If you're wearing jewelry, can you feel it in your ears or on your wrists or fingers? Notice how you're breathing. We like nice breaths in mindfulness. Try to push that breath down into your belly. As you're listening and feeling, I want you to still be trying to do these two things. I want you to also look inside at yourself. What sensations am I having as I'm sitting here? As I breathe in, what does that feel like to me? What sort of thoughts are going through my head? I'm now going to be quiet for an uncomfortable amount of time, right? It's going to be way longer than you want it to be. And I want you to practice all of this at once. Hearing, feeling, observing yourself. All right, here we go. That's our time. You can continue to do that if you'd like. One of the questions I want you to ask yourself about that experience you just went through is, what did you notice? I can kind of narrate some of what I noticed. I noticed what happens to me when I do this in therapy happened up here. There's always that moment where I start doing this where I go, oh man, they're not going to get anything out of this. And it kind of spikes up, yeah, right away, right? Right away. Oh man, no one's going to get anything out of this and they're going to think you're nuts. I feel that in my body is sort of a uncomfortable, pulling, stretching kind of feeling in my chest, and it has kind of a heat that rises up, right? What did you notice? How did your emotions feel as they moved in your body? Think about that while I say this. This mindfulness state, as you practice it, I like to practice it daily, and I find that even if you can practice it for like 30 seconds, it'll help you. But as you practice this mindfulness state, you will start to develop more awareness of yourself, awareness of your defaults. Who here has ever done one of their defaults and only way after the fact looked back and gone, oh crap, I did that thing again that I do? I know I've done it enough time in my life. Mindfulness is about learning to get ahead of that process because our programs are set by what we keep doing. If I keep doing the dumb thing, whether I'm aware of it retroactively or not, it's going to stay my program. So at some point, I want to get ahead of it. This awareness is your tool, watching yourself in moments, in places, particularly in moments and places where you know you're going to be uncomfortable. There's a lot of information there. All right. So we're coming back to self-care because I think this plant analogy is really rife with good information. And as humans, we want to take care of ourselves. I think we often, particularly as mental health therapists, I think we're kind of part of the problem on this. Self-care becomes this really complex nutso thing, right, about how do we get it done, like it's some kind of mystery. It isn't a mystery, it's relatively simple. If I want to care for someone, I need to have some kind of a relationship with them. I need to be interested in them. I need to spend time with them. This really is no different for you as you build a relationship with yourself. Spend a lot of time together. Figure out what you like and what you don't like. Spend time encouraging yourself and validating yourself. Spend that time being that person together with you, just being there. And then in that moment, this phrase up here, you will hear that. Ignore everything else. What feels like self-care for you today? As you relax and be in this moment, you'll hear that more. One of mine is a cup of hot chocolate. I can't tell you how regulatory a cup of hot chocolate is for me. And we buy our hot chocolate at cost you less, whatever, big by the box, because some days I have 3 cups of hot chocolate because it's a hard day. Yeah, right? Some days I go to bed at 6:30. because I got home and I'm whiffed and I'm tired and I hear my vagus nerve go, oh, you need to sleep. And I go, oh, okay, cool, we'll go to sleep then, right? Self-care is really about just doubling down on the fact that you here now in this moment have an experience that is valid. And because it is valid, it can be taken care of, whatever that means. Does that mean sleeping in a little bit? Does that mean taking a hot shower? Does that mean buying myself that nice heating pad? Whatever that means, do it. Take the action and start it now. Our self-care is actual stuff we do every day. And as humans, I find that we can get into that place where we feel like because we understand the thing really well and we thought about it a lot, now we've done it. But that's not the case, right? Actually do every day something nice for yourself. A little self-validation. I'm okay that I feel this way. It's all right that I'm angry. Like Raquel was saying with that coworker, it's all right that I'm angry at that coworker. I have every right to feel mad. Giving yourself that time and that space. Okay, so now we want to talk about actual grit and the pieces of grit that make it sort of what it is. They've done a lot of research on grit, and they're always doing more. We know it's a skill, but it's kind of a complex skill. These are the 4 things that we know are most highly associated with grit because we found them in basically all gritty individuals that we research. When we find somebody that's got a lot of this, we find they have these 4 things in common. So I'd like to get into them. Ooh, what a fade. The first is interest. The idea of interest is you want to find some way to stoke the fire for your life. Why are you getting out of bed? If you're getting out of bed to go do the same things that you've been doing, it's not going to be very interesting. Learning how to inject the stuff you're interested in during the day, right? Maybe some of those double as self-care. I like music, and I like to say I pretend to be a musician. That doubles as self-care for me. I get to go and I get to play some music, and I get to breathe, and I get to do that. And I'm interested in it. I like to learn more about it, so it keeps me moving. Oh, yeah. Your relationship with yourself, I was confused by my own sentence. Your relationship with yourself, as well as that mindfulness tool, will be really, really helpful in building your interests. Time spent checking in with you, just being, will give you a lot of insight into what do I like. As I started this practice of mindfulness and meditation, I found that I really like doing nothing. It's true. I do. I love it. I love sitting quietly in a room and just breathing. It is awesome, man. When I was younger, I was always on the move. I had to do something. Got to play a video game. Got to go ride a bike off a cliff. Got to write something, right? Anymore, I find I really like doing nothing. I really like just looking at nature and breathing, right? Those moments and those times where you hear your voices talk to you, you hear your gut say something, that's when we listen, when we've been working on that. Move towards the things that you love in personally meaningful ways. What that means is, I like music, but many years ago I recognized I'm probably never going to be a world-famous musician. So what's the way I move in a personally meaningful way toward music? Because if I set my goal as world-famous musician, my music is going to stop being interesting, and it's going to start being a slog. It's going to start being this, God, I'm not Justin Timberlake. Oh, no. I'm not Beyonce. Oh, man. If I reframe that and say instead, I want to write a song that I bop to, well, that's a good goal that keeps me interested. It's personally meaningful to me. I like that piece of music that I wrote. We want to choose, this is just a little aside. Some of our interests we choose. I call those acquired tastes, right? But a lot of our interests we just kind of discover. I don't remember sitting down and deciding I love Transformers. I love Transformers. To this day, I still love Transformers. I don't remember sitting down and choosing to like art or singing or climbing. I don't remember sitting down and making any of these real big choices. They just sort of unfolded as I've been able to relax. We want to push yourself a little bit, right? And why I put this here is sometimes we have an interest, and this goes back to that acquired taste. Sometimes we'll have an interest and we'll kind of try it. Maybe it won't work out, and then we'll go, oh, well, I'm not doing that ever again. And we give up. I urge you to push just a little bit right there, Because sometimes we find something that we really love if we can just keep at it for a little bit. Don't do this too much, right? Don't push yourself to the point where you hate this, and because that's just not good. But try stuff a little bit. Try new things, different things. Bathe yourself in different experiences and see what clicks for you. All right, so practice. I talk about practice a lot with my clients. I talk about practice a lot in my life. Practice is a whole outlook on life. Like we talked about earlier, everything you're doing every day, moment by moment, is setting up who you'll be in the future. The cool thing is you have control over that, if you can just bring yourself to this moment. Your life is a sandbox. We can do just about anything in our society anymore. And you will naturally get really good at the stuff you spend a lot of time doing. Taking the reins of that, using that awareness and developing a plan will empower you to do really most of what you would like to do in life. Now, this is something I want to note. We used to say in research, behaviorism and things like that you needed tons and tons and tons of practice, right? 40 hours of practice a week, minimum, that's what it's got to do. What we're finding actually is that that's not really the case. People can practice for 30 seconds and it can help. They can practice for a minute. So find out those things that are hard for you. Getting up in the morning. How do I practice getting up in the morning? Right? And how do I practice it small? Maybe the first way is I tell myself I can only hit that snooze button twice. And then if I do that and I only hit that snooze button twice, then when I get out of bed, I get the nice latte because I did that. And that's a small way to start that. And once you're good at that, you're getting a latte every day because you're only hitting that snooze button twice. Well, now it's time to say, okay, I can only hit that snooze button once. I'm practicing getting good at getting right out of bed right when it happens. Scaling your life out to make things work for you. I think it's also really important in this moment to remind yourself that as you're practicing new things, you're going to suck at it. Nobody ever got really good at anything without first being really, really bad at it. And that's true for everything I can think of, including being gritty. Be easy with yourself. Be gentle, just like the plant. The moment you notice that you're sick or something's off or you're not feeling well, take the care, take the time, get yourself well. That's practice too. Consistency is a big deal here, right? You want to find a nice medium point between trying to motivate yourself to change and beating yourself up, because we don't want to beat ourselves up. We always want to make sure that we're moving towards our successes, reminding ourselves of how long we went. You wanted to go 10 days without smoking, and you did 10 days without smoking. And you said, okay, now I'm going to do 15, but at day 12, you started smoking again. Well, hey, I went 10 days. In fact, it wasn't until day 12 that I gave in. So, okay, I can do it 11 days this time. Keeping that motivated, that eye toward the reward. Just a bit more about practice. This is hearkening back to our analogy. When you start your practice, you want it to be under ideal conditions. You want as much of whatever it is you need as possible. Help, assistance, instruction, modeling, all of that stuff you want to have available and ready for you. Once you're good at it, you don't have to be an expert at the thing, but once you're good at the thing, this is the time for you to start stretching out those conditions a little bit, making sure those ideal conditions aren't always ideal. Maybe I don't have the thing I need, or maybe I push myself just a little bit further, a little bit longer. I wait some before I engage in that habit that I don't like. Once you're like an expert, this is that mastery level, trying to get really, really, really good at something. Once you're an expert, now you can stretch those conditions, whatever they be, basically as much as you want, as long as you don't break yourself, as long as you listen to your own person, right? You stay in tune to know, okay, this is hurting me. Practice at this level doesn't need to be quite as consistent, right? This is kind of how this goes. At first, you want to be really, really consistent, really stable. As you get good at it, you can practice maybe a little less or a little differently. You can start to stretch that out until it's just maintenance work. Purpose. People with a purpose in their life tend to be gritty. They tend to be able to hang on when others might give up. One of the big comforts in my life has been recognizing that I get to choose what my life means to me. Nobody gets to author that. So I can choose whatever I want. Faith, culture, personality, all of these things are really, really tied up in your purpose. What that means is if you're acting in accordance with your faith, you'll have more purpose. If you're acting in accordance with the parts of your culture that resonate with you, you'll have more purpose. If you're acting in accordance with your own personality, you'll have more purpose. The last thing I want to talk a little bit about here is hope. Hope is also really linked to our culture and our religion and our self-identity, which means the same thing that it did for purpose. As I align myself with the aspects of my culture I like, as I align myself with my beliefs or my religion, as I align my behaviors with those things, my hope increases, my purpose increases. As I live an authentic life, my hope and purpose increase. Practice helps fostering hope. As you're doing something and you're trying it over and over and over in a small way and you get better and better at it, you start to develop hope. You start to go, oh, I can do this. Oh, I do have this capability. The last thing I want to point out here, because our time's up, it just said big red thing, I know, I hear you, are the big 4 factors in fostering hope. This comes right out of palliative care. So nurses helping with people at the end of their life. They're terminal, it's not going to get better. They found that these 4 things actually massively, significantly impact the development of hope. And they are teaching yourself to monitor reality. Okay, this is my thought, but what's actually happening in the world? Checking yourself against that. The second is encouragement, both from others and from yourself. Learning how to be your own cheerleader. It's okay you win over time, you're doing great. Managing anxiety, thank you. Managing your anxiety, figuring out how do I move against those things that make me anxious. In my own therapy, I learned a nice litmus test. If I react poorly in my mind to somebody saying stop something, that's my anxiety voice, and I need to move against that because it's not going to help me. Starting to pay attention to that, you can move opposite of those. The last here is grieving, allowing yourself the time and space to process the emotions you've had, to process the experiences you've been through, and doing that from a place that's free of judgment. That's our time, so I'm going to end it here.
Thank you. Thank you very much to both of you. Our next speaker is Professor Andrew Shaw, Associate Professor of Physical Chemistry at the University of Exeter and founder of Automarker Limited. We thank you to Integra Healthcare for sponsoring these afternoon sessions, starting with Professor Shaw, who's presenting on the evolving role of point-of-care testing in prevention and positive intervention in NCDs. Let's welcome Professor Shaw.
Good afternoon, everyone. I think somebody photoshopped that picture of me. It looks much better than it does in the flesh. I'd like to talk this afternoon a bit about point-of-care technology and where I think that will take the diagnostic revolution, a change in healthcare. So I think if we're to understand a lot more about non-communicable diseases, NCDs, we're going to have to make more measurements. We're going to have to make those measurements away from the laboratory. We have to make those measurements when we need them, rather than just when it's convenient for the central laboratory to make them. And so I invented in my research group a new technology, which is now the foundation of Automarker Limited. And it takes a single blood drop from your finger and then begins to look at many things inside that blood drop. And I'll show you some of those ideas in a moment. But let's look at the blood drop for the moment. There it is on the end of your finger. You should ask, is that big enough? And sometimes it isn't. If you were to sit on the beach with a cup and fill it with water, with seawater, look into the cup, you might conclude there are no fish in the sea. If the sample is too small, then there may be some things in your blood that don't get there. So we started by learning with venous blood, that nice chunk of blood they take out of your arm at the hospital. We started learning and developing the technology, but it works. One of the things in the drop, one of the things the pandemic has told us is the drop of blood is actually really rather good. And we've learned how to analyze what's inside it. Not all things, as I say, there are still some mistakes. The pandemic was important to the evolution of Automarker because on the day the pandemic lockdown happened in London, on March the 20th, I went to St Thomas's Hospital, drove through the streets of London. It was like a disaster movie. There was nobody there at all, just our car and a few police cars. I was expecting to walk into a zombie or some such coming around the corner. That didn't happen. All the zombies are now left in Downing Street, it would appear. So it's only 2 more prime ministers to Christmas. But we went into the lab, we set up the kit, and the very first measurements we made worked. We were all very close to the computer screen watching that moment of discovery in science. It was really exciting. That's why I'm a scientist. And from that moment, we were beginning to watch people recover from SARS-CoV-2 COVID and also watching them not recover. And before we knew really what was going on, we were beginning to make a contribution. So let's see what we can do for non-communicable diseases, NCDs. We've heard a lot about them today, and we've heard a lot about how pernicious they are, how many people they're going to kill, and whether we can do something about them. There are tests we could do for cardiovascular, there are tests we could do for cancer. The chronic respiratory diseases and the ones I'm going to talk a bit about today are type 2 and type 1 diabetes. The other column on the right-hand side are somewhat less catered for in terms of testing. Rheumatoid arthritis, there are some tests. These are examples of autoimmune diseases, not really communicable, but somehow you start attacking yourself for no good reason, or maybe a good reason we yet don't understand. What about depression, for example? What about cognition? We heard a bit about psychological behavior before the break. Maybe we could measure that. That's a very interesting idea. Maybe we can put proper numbers to the feelings of unwell or feelings of stress. To do that, a finger prick device of some form is going to be important. But where are you going to do this? And this is the list of risk deaths by indications by region. You can see that there are lots of problems in the Western world, and we think we should be able to go to the doctors and get those fixed. The places where you need to make the difference are places like Africa and places like Eastern Mediterranean, where the testing and the healthcare provision is not so very good. If you wanted to go and make a difference into NCD diagnosis and intervention around the world, then you're going to have to go to stranger places. That's also a characteristic, I think, of a new successful technology. The most curious column and cell in this figure is this one here, which says, how do you not know what the alcohol consumption is in a high-income country? That must be something we can count. Maybe it's because when you go to the doctor and the doctor says, how much alcohol do you drink? The correct answer is about average, right? It doesn't say how many units. and I think that's why we don't know. We can't fill in this box. So obesity are problems, behavioral problems, all sorts of factors are things we could begin to address. Is it there? Are these things really there? This study here in Mexico between 2014 and 2018 with nearly 750,000 people revealed that pre-disease and disease condition was discovered in more than 70% of the population. So it's all there, it's happening to us, and yet we don't care about it, it's not on our radar until something happens. It's not there, it's not something we now monitor. Wellness is not something that really happens. So if we put the patient and us, when we're not a patient, at the center of this, just us at home, us in our own normal everyday life, can we make some measurements that might change that? And again, in the pandemic, we've all got used to scraping the back of our nose to get things out of our nose and all sorts of other self-testing. Maybe that psychology, that readiness to self-test, the timing is now for that to be extended. So patient-centered, retention for the control of the person and not just the patient, and we'll see whether these NCDs are something we want to change. My feeling is that some of us will try, and some of us won't bother. Some of us will try a bit more if the doctor could show you the results quickly, and still some people won't bother. But if you can choose, and you're in a position to choose, not just here, but in Uganda, in South Africa, in places where there's no medical diagnostics really, then that's a much better opportunity for the rest of the world. It is really hidden. So looking at the discovery rate in some of these other countries around the Western world, it's extraordinary. But down the right-hand side, Dominican Republic, Cuba, etc., lots of undiagnosed conditions. So the danger is we're all going to do a self-test at home, run back to the hospital, run back to your doctor and say, I've just diagnosed myself with this test, we need to do something. It's going to cause anxiety, and that will need to be managed. Some of the things that need to be changed have got to be the way we treat the numbers, what we do with those numbers later on. So revealing the hidden disease is interesting. Something at the point of care might be very useful. Something at the point of care where you need it, not just in the high-end clinic in the Cayman Island, but somewhere where it's not possible around the rest of the world. So let's identify, let's intervene. And maybe if the blood drop doesn't hurt too much, and it doesn't, maybe you can do a bit more often. Maybe you can use time analysis. You can look at how things evolve in time. That's also quite strange. Usually you just go and get a blood test, maybe get in once a year. That's hardly going to see anything. But if you can do it a bit more frequently, maybe when you need it as well, that's a bit more interesting. So the risk factors, we've heard a bit about these today. Can we measure some of these? If you look at the ones in the right, in this red column here, some of these factors around physical activity, a person's weight, and food choice, if you do intervene and it doesn't really work, and you've got your weight targets, you're trying every diet that can possibly be presented, where's the reinforcement that it's working? Where's the idea that somehow you're getting better? Not just measuring perhaps how many notches in your belt you're using. So we need to move, I think, healthcare away from break and fix, which is simply something goes wrong, you don't know what it is, you pitch up with the doctor, they make lots of measurements and start talking about your liver, start talking about the way your cardiovascular system is collapsing, there's something wrong with your heart. And at that point, you're full of regret because you wish you'd done something just that fraction earlier. So healthcare now needs to become something that can be more around when you need it, but also around when it's convenient for you, maybe. When it's convenient for you to make a measurement and see at the end of an intervention after a hard run, after an extended dieting period, does that work? So there are lots of surveillance technologies, things on your wrist for measuring your pulse. One of my directors who's massively overweight said his pulse rate was sitting down at 45, and that's probably not true. So it's really important to know that the measurements you're making are accurate, and that's a characteristic of the test that we're doing. What about the hospital at home? Is it possible for the doctor to send you home with a piece of testing technology, and that technology can report to the cloud, and the doctor can see what you're doing? Like that really interesting example from the top of the conference today of the kettle at home, judging whether your elderly father is making tea at normal times. Why do we not make more of the Internet of Things to look at hospital at home? If you have a good answer, then you can have, to a test, for example, then you can have a teleconsultation that's really founded, I think, in a bit more science, in a bit more diagnosis, a bit more accuracy. What if the first test that you made, the first diagnosis that you made, the first discussion with your doctor was the best one? Make your first best intervention. Then you don't get it wrong, then you don't get the wrong antibiotics, you don't get the wrong drugs, you don't end up in hospital a few days later on. So the best first intervention, and my contribution to this set of diagnostics is going to be some blood testing. Your blood contains lots of things floating around it. There are, of order in a healthy person, something like 380 odd different types of protein floating around in your blood. That's just if you're well and you haven't eaten. Your blood becomes really sticky if you've just eaten something. And these in the trade are called biomarkers. Existing as well is a series of single biomarkers. One thing tells me I've got a disease or not. One thing tells me I've got this disease or not. I also don't think that's true. We need to look at lots of things. We need to look at the fingerprint. And not just the fingerprint now, but we need to look at the fingerprint as it evolves in time. There are markers to tell you how well you're responding to drugs, for example. Companion diagnostics. We should do more of that, to tailor that, to see how things are working. Predictive biomarkers. Are there things that you can measure that tell you that it might go wrong sometime in the future? That's a bit more worrying. Do you really want to know those biomarkers if you really have a predisposition to something going seriously wrong? Maybe, because maybe your game is now not to just increase your lifespan. Lifespan has doubled in the last 100 years. Some people are predicting that, as we heard this morning, you might live to 150 at some point. The critical part is that you have a healthy span, a long health span, where you can do all those wine tasting hobbies that you really wanted before serious immobility or decrepidation takes over. There are safety biomarkers. How much of this drug can I use? What's safe to use? And what about exposure to various parts of our environment, etc.? All those things are important. Diagnostic biomarkers for disease are fairly obvious. Do I have disease X? Do I have disease Y? and then monitoring biomarkers, markers of surveillance. So there's quite a collection, but I think it needs to be a fingerprint. When you commit your crime in paradise, death in paradise, one of my favorite, right? So all I need to complete my visit is a murder from an extraordinary venom from a snake that's not indigenous, for example. When you commit your murder, you leave fingerprints around. The police will look for 16 marks of comparison between the fingerprint found at the crime scene and your fingerprint provided to them at the station. You don't always get those. You always get partial fingerprints as well. And then you need a forensic scientist in court to say, yes, I believe that's a fairly good match. That's your doctor. Because when we measure something, it's not going to be a yes-no. Yes-no medicine doesn't happen. Things are going to evolve in time. The fingerprint will become better in time. So we're going to choose our components carefully. And there's a group of standard tests for many opportunities. What if I add 2 more next to it in a very agile way? Maybe I could have 4 more. Does that improve our diagnostic accuracy? Does that improve our sensitivity and specificity to the disease we're looking at? No, it doesn't. Let's throw those away and keep with the 5 that we have. So moving quickly is important. So prostate cancer is this marker of PSA, a fairly inaccurate test, 70% accurate, triggers all sorts of unnecessary interventions for people that didn't have prostate cancer. If you do it over time, much more interesting. If your PSA is evolving in time, that's somewhat more accurate. So yes, no medicine doesn't work. The only time it really has worked well in the pandemic is, do I have COVID or not? And for some of the time, it wasn't right anyway. Maybe 20% of the time it wasn't right. So yes, no medicine doesn't work. Watching fingerprints evolve in time, that's where I think we can make a contribution. So this is my technology. It is in the laboratory. It's about the size of a large toaster in some way. It can take either venous blood or a finger prick of blood, and the minute it gives you answers in 7 minutes. So that's quite interesting. It's important to me that it's as good as the clinical chemistry laboratory. Actually, for many tests, we're more accurate than the clinical chemistry laboratory. And as a scientist, it's important to me that it's reported in a really standard unit, a proper metric scientifically that everybody around the world could understand. Lots of tests are reported in strange units. They need to be compared. Instruments give you different answers. So mine needs to be a precise answer, and we standardize it against the NIST standard antibodies from the US. It talks to our central servers, which I've called the human cube. And it must do that because I want the test to be performed by people that aren't laboratory clinical biochemists. It can be done by a nurse. But if you get it wrong, we're not happy with it, the cloud watches what happens and can send back a message saying, no, have another go. Didn't work quite properly. We're not happy with that result. When you're in hospital and they run a clinical chemistry test or a test of any form, somebody will say, yes, it's okay to release. We believe that result. And that's important. That validation process is important. So at the end of the day, in the lab, or in fact in real time, we watch the results from our instruments. The next exciting trick is the handheld version of the instrument. That's an iPhone 6 on the top. It'll work for some of the iPhones above that, not the ones that got much bigger, but the ones with the same form factor. You can take that home. Now when you're doing this at home, if you make a mess of the test, I'm going to send you a message saying, I don't want you to believe that there was something wrong with the measurement. Lots of controls in the instrument tell me it didn't work properly. You can trust the test. Now, if I can do that on your home, surely I can now do this in South Africa. Surely I can do this in Chile. Surely I can do it in some remote community around the world. If I can do that, that's laboratory quality testing in the middle of nowhere. That, I think, for me, is a bit of a change. That's a change in the way we can think about diagnosis. And the person making the blood test doesn't have to be very, very skilled because maybe you then use the phone for the teleconsultation afterwards. I can put some AI on the phone and say, this test result should be interpreted in this way. Here are some possibilities from the way that we've interpreted your blood result. If you're not sure with that, then have a teleconsultation. And the doctor gets a secure transfer of the information to the teleconsultation, and a proper piece of diagnostic science can then go ahead. And I get the cube. Now, it's anonymous. We're going to use blockchain to make sure it doesn't disappear. We're going to make sure that you can then access it when you need it. You can consent to us using it if you want. But I will get some view of the human cube. And that's really interesting. That's really exciting. And that's where I think the technology is going to go. That might make a difference to diagnosis. Looking for different types of fingerprints. We'll see those in the field. So if we aggregate the big data, if we pull it all together, in all big data there must be big noise. So there must be some nonsense that's there. But if there is something for big diagnosis, if there's something about the way we can intervene with people in different territories because of environmental factors, or different types of exercise, even validate certain types of dietary interventions, maybe we can begin to address NCDs. And not just NCDs as well, but if you get sick with bacterial infection with your NCD, that combination must come together. If your NCD requires you to take 11 tablets a day, then is your liver, is your body in exactly the same state? Now that's interesting. Now I'm looking at you as a person where all these measurements need to be, all these factors need to be considered. So the NCD evolves with you and evolves in time. For me, I want to start with looking at the liver. The liver is the master chemist in the body. It does absolutely everything. Massive amounts of synthesis, making proteins. It transports things around. It makes bile for digestion. If you drink too much alcohol, it comes through your liver to get rid of. If you drink caffeine, it comes through your liver to get rid of. Every drug you take is detoxified through your liver. It does everything. It's really important for waste management, absolutely everything. If anything in your life is going to see how bad it's getting, it's going to be your liver. It's going to, you can feel it, as it shows in the picture just around here. Some people can feel it getting fattier, getting lumpier. If it's healthy, it'll work well for you. As you change your lifestyle and you make your choices, this chap's going to feel it. And I think measuring the properties of the liver are going to be something that we could do at home. So non-alcoholic fatty liver disease has a pathway all the way through to an end diagnosis for the liver, where you're going to need a liver transplant. And the early phases of liver degradation are nicely reversible. So if your liver begins to show signs of NAFLD or NASH, at some point you could intervene early enough and then reverse some of this damage or limit it. If you were to know about it, that's really good. What you don't want is to come to the doctor when something is broken and your liver is sitting in this NASH state and we're into serious care, maybe even palliative care if there's no transplant available. The liver tends to get better. We tend to load it up with fat from our diet. There's even some suggestion that a fatty liver then excreting fat from the liver or leaking fat from the liver into the pancreas causes problems with making insulin and diabetes. So maybe it's the cause of that. So the liver is already aware of some of the things that are going wrong with your liver. If it becomes a bit stiff and fibrous, then you're heading on the journey to non-recovery. These are two markers here that we're going to add to our set of panels, our set of tests, that specifically point to identification of cirrhosis. So the test will have a good accuracy, and we'll explore that in a moment, from healthy through to non-reversible and maybe end-point diagnosis. If we can do that in Africa, then they get a really interesting piece of science in the local hospital that wasn't there before. So our new liver function test panel, our new fingerprint, will involve a list of enzymes, which are standardly tested in the laboratory at the moment, as is this one. These two are not really available globally yet, but we're going to put them on the chip because we have spoken to the designers. And HbA1c is a molecule that tells you how sugary your diet was. It adds a sugar molecule to your hemoglobin. If you have too much of that, you've had too much sugar in your diet. All these other enzymes leak out of damaged liver cells. And so they're not really good measures of liver function, and I will come back to that. But they are a measure of liver dysfunction. So it's going to degrade in time. That's the fingerprint. It's not quite 16 points of the fingerprint, but that's the one that we can begin to track in time. We can begin to see how useful this might be in solving the NCDs that we've been talking about. What about hyperglycemia, glucotoxicity? All things are easy to do in your diet, and they all result in liver cell damage and an increase in these enzymes in your blood. So rising trends of the leaking proteins, the leaking enzymes, are the markers of the evolving and decaying liver. Consequently, falling trends of the same markers are also important. So the trend analysis is the bit that I think is interesting, because we're all different. Normal, for me, is not well defined. until you measure it. I'm in the normal range. What does that mean? I could have doubled my liver enzyme leaking and still be within the normal range. But if you know what's normal for me, where I am in that range, then I can see how I'm going to evolve in time. So I think the analysis of us as individuals over time can see these enzymes leaking as a result of liver damage and too much sugar in our diet, and we can see it change. So that is interesting. So here's normal. This is the normal range for, let's say, one of the enzymes here, up here. And as cirrhosis takes over, then the enzyme levels begin to rise. If you've got NAFLD or chronic hepatitis, it's even higher. Alcoholic liver disease here is a much larger trend. All of these are increasing concentrations of the damaged of the enzymes in the liver from the damaged state. So it's a nicely sensitive measure. When we get to here, it's up 10,000 times above normal. So that's a really good measure. So I can see quite a lot of things changing. The other liver enzymes produce now quite a dynamic range in my fingerprint. I can see how it's going to evolve in time. So it's an interesting set of targets. But the magnitude of the dose does not predict the severity. So we might have a low problem, a low-level problem that results in some way for a large increase in the enzyme concentration. So just because you've got lots of it doesn't mean to say that you're actually in a really bad way, but it is a good way. But the trend is still important. If you reverse it and start making the liver levels, enzyme levels lower, then you're getting better. So we have on the chip a series of tests that will look really good for understanding what's going on with the liver degradation. So things like diabetes and diabetics here and non-diabetics, you can see the liver enzyme panel has a nice sensitivity on all of them, ALT, AST, GTT, gamma GT, and ALP. They are all going to rise, and that fingerprint is a nice measure of what's going wrong diabetically or getting better diabetically. So that's a very interesting idea. Now we can see that, it's sensitive, it's quite specific as well to the damage to your liver. I'll talk about something shortly that will show you a counterexample, but this is specific to liver function testing in type 2 diabetes. What if you knew that? Let me introduce you to your liver tar. Now this is, if you knew your liver function, Livy can tell you what's going on. So you can collect your data from your steps, for example. You can collect your data from your other healthcare devices, and we'll add in the liver function tests. So now you've got a real piece of chemistry to go next to your 45 beats per minute pulse rate, which is not true, but the chemistry measurement is right, and I've checked it's right, and you've checked it with the cloud to make sure it is right. Your liver app can then understand what's going on. You could take this around with you. So now it's not just about being on your own, being good in your diet. Livy is going to be with you so that if you do a good week of hard work and you make a measurement afterwards, things will have got better. You will be rewarded. And you may be even gamed. We can play these games. If you play computer games, there's a lot of fun in playing the game. Maybe we can turn the gamification of diabetes and health into something that's important. And I really want to do this with children. Now, my finger prick works really well for children because that's not a blood draw. And why can't I, through the cloud, enable a child in New Zealand to compete with a child in the Cayman Islands to improve their obesity? Why can't I play a liver game internationally with children competing with one another, all tagged against some proper liver function testing? So I think the gamification of health may work for some people and might be useful. And I think especially for children, where technology is going to be there, downloading the app, playing with Papa's phone is always going to be exciting. We can build some features into the app. We've already got to the point where you can scan a barcode on a packet of crisps, and Livy gives you a scowl because it's got too many calories in it, too much fat in it, and would give you some nudge not to eat it. Imagine I could extend that to allergy. What if there was a profile on this barcode that said, actually, there's some bits and pieces in here to which you might be allergic, consider eating something else. That's also interesting, and we'll come back to that as another NCD that doesn't really make the list, or the usual list, but it's now a rising problem. That's food allergy. So I think the game, the app, somebody with you, some AI with you all the time, might help you to make a proper change, even make a reversibility of a serious condition. So, combining serial measurements over time, changing of lifestyles, doing the hard lines, doing the gym every week, and the liver tells you you're making progress, keeps you on the straight and narrow. I think that's going to be interesting. And we'll have the liver test out with the handheld device next year for preliminary trials while we work up the game. But gamma GT is a little more detail here. Gamma GT is the one that's telling you you're drinking too much. This is 40% above normal levels from too much alcohol. It will tell you that you've had a busy weekend. It will tell you you've had a good Christmas. And maybe you know that, but then maybe you can work hard to get it to come back again. So again, Livy will be there telling you that things have not gone well. The proper measurement has told you that you can reverse these processes. Gamma GT will come down very nicely if you stay off the booze for a bit. So these things are interesting ways of looking at how we might tackle the NCD problem. Weight loss and LFT changes work really well. So these are deltas. These are 40%, 50% changes in these combinations. The entire fingerprint moves down as you begin to lose weight, and decreases by 50-odd% or so for some of the enzymes. But together, it's a nice, sensitive, and specific measure to some of those activities that you're changing in your life that might make a difference to the way your liver is responding. You can see how I could do this for the heart, or you can see how I could do this with other organs like your kidneys. I'm starting with the liver because of all the traffic, all the life goes through into the blood, goes through into your liver for detoxification, for example. So it's possible, and it's been shown in this trial in the direct trial in Edinburgh, that you can put your type 2 diabetes into remission. You can turn it round. So when you're in a clinical trial, not with my device yet, but when you're in a clinical trial, measuring those enzymes, and with the doctors watching you all the time, the patients get better. They go out of type 2 diabetes, they lose their type 2 diabetes technically into remission. The moment they come off the trial, nobody's watching them, no measurements are being made, type 2 diabetes comes back. So now I think if we can show that it works under clinical trial conditions, and we can continue to monitor potentially all the time, even if it's just a doctor taking a measurement for you when you go to the doctors for a routine checkup and saying it's going wrong, that might be sufficient to nudge you into making a change. So we can reverse type 2 diabetes. And hopefully with my technology, not just here in your clinic, but everywhere, in some of those countries where those numbers are really rather big, and we'd like to try and solve the global problem as well. But I was talking about the liver functions being measures of standard liver function tests. They're called LFTs. And they actually only measure liver leakage. They don't measure real function. One I really like is your caffeine half-life. So this tells you, when you drink a cup of coffee, the caffeine gets out of your stomach into your bloodstream. How long does it last in your bloodstream? For how long do you get the hit? And the liver's job is to take the caffeine out and make it go away, preferably before you go to bed. And it will take it out at a rate, a half-life. It will take out half the caffeine, in the case of this study here, every 6 hours. But the liver half-life varies between 2 hours and 9 hours. So do you have a 2-hour liver, or do you have a 9-hour liver? Do you take 2 double espressos just before you go to bed and it doesn't matter at all? Or do you walk through the kitchen when your wife is drinking one and you're awake all night because the caffeine has got into your bloodstream somehow? So the liver's ability to metabolize caffeine is a measure of liver function. Now, that's not measured routinely. It's hard to measure, and we need better biomarkers actually of real liver function. But the key to this experiment that I like so much as a demonstration is if you take a drug, and this is a drug, it's a serotonin inhibitor, it's a fairly large, fairly widespread use drug in depression. We're in polypharmacy. As I said earlier, some people are taking 11 drugs a day, some people are taking 5 drugs a day. They're all coming through your liver for changes, for clearing it, to get rid of it from your body. It's technically a toxin. And that's going to change your liver half-life. That's going to change the way your liver works. We don't know. Honestly, when you put 11 different types of drugs in possible combinations together, what they do to the function of your liver. So if we can find proper measures for the liver function, the actual liver's ability to do its job, then we can see how things like polypharmacy can be managed personally That's the important bit. A 2-hour liver or a 9-hour liver, maybe you can tolerate a bigger dose. That would be good to know. If it's a 2-hour liver, maybe you need a smaller dose. There's one confounding problem here, and this is measuring the burn. So those enzymes that are made in the liver, that leak from the liver, also are leaked from your muscles when you work out really hard. And so if you go to the gym, you will end up with a larger increase of these enzymes in your blood, and that will go back down to normal levels after a few days. So you can measure the burn. Maybe that's good for athletics, maybe that's good for people that are really dynamic in their exercise, and I can see a nice niche market for all the gym junkies that are going there all the time, showing how hard they're changing their body and how hard they're working things. But that confuses my diagnosis, right? So this is an example of you'd see a big rise in liver function associated with having been to the gym. Arguably, you don't have fatty liver disease if you've been to the gym, but nevertheless, that's the way you can see how a diagnostic test might get fooled by something that's fairly important. Time gets you back on your side, though, because it goes back to normal, and then we can look at your liver disease again. So measuring the burn is a bit of a counter. It's a huge problem, these NCDs, a massive problem. 41 million people each year, equivalent to 74% of all deaths globally, are responsible with NCDs. We all get other things on top of our NCDs, and if there's one thing that the pandemic is learning us, or the endemic is now teaching us rather, is that we're going to have potentially COVID frequently on top of our NCD. We're going to have the flu on top of our NCD. All these different recovery profiles are all related to the way our liver works. But the stat that I like to put alongside that is there are 107 mobile phone contracts per 100 people in the world. So they're going to have enough power. This thing in our pocket has enough power now to make my measurement. It just needs the camera and some clever nanotechnology on our chips. And then the phone can think about what it means in the short term, isolated from the cloud, and with real help and the full power of big diagnosis sitting in the human cube of data above it. So actually, this, even in Africa, where they've missed out laying copper cables for telephone lines and put in mobile phone cables, mobile phone distribution masts, everybody can then have a mobile phone, or is heading towards access to mobile phone technology, and therefore mobile computing, teleconsultation, and a new paradigm, I think, in healthcare. So this could be really important, and then we can concentrate on things like health span rather than just lifespan. We want to live for longer to do all the things that we want to do in a healthy way, managing or keeping at bay the things that are going to be terrible for us. There's some revolutions needed, and I did a clinical trial with a colleague of mine who was a colorectal surgeon, and I got this back at me. Andrew, you got to treat the patient, not the number. You're a scientist, I know better because I'm a medic. So we were doing a trial for post-operative recovery, and we were looking at a standard marker of post-operative recovery, C-reactive protein. It goes up when the knife goes in, and then if you get better, it comes back down again in a fairly known way. And I started doing some sums. Now, I could do the sums because we were making frequent measurements. Because the blood drop was taken and not a big blood draw, the patients were happy to have frequent measurements. So even over the time course of the 2 or 3 days post-operatively, I can take frequent samples every 8 hours or so. CRP doubles every 8 hours and halves every 19 hours. So you can work out whether it's going down, whether the CRP level is telling you that the underlying acute phase response, the ouch from your body, was going up or down. And so I was looking at this patient in bed 4 and got hold of my surgeon colleague and said, Mr. Surgeon, I think there's something wrong with the patient in bed 4. And he said, no, the patient wanted to go home. They were feeling good. They thought they'd recover better whilst being at home. And the CRP levels not very high, and we think they're coming down. I said, no, my new sums look really quite important, and you should give it a go. Andrew, you've got to treat the patient and not the number. So that's what happened. They were discharged, and then they were readmitted 2 days later on with a screaming C-reactive protein. They'd had a cut and shut in their bowel, and it had basically opened up and leaked into their body. They had sepsis. They were in hospital for a seriously long time, very unwell, and they got no remuneration for the hospital for getting that. So sometimes the number's going to work, and I will make sure the number's available for the doctor to dismiss and maybe treat the patient, not the number, was the right call sometimes. but it's got to be there. Also, the doctor's now going to have you walking into the surgery with one of my devices saying, hey, look, my liver function tests are looking a bit strange, or my liver function test changed. Doctors are getting bombarded all the time. Dr. Google is a big problem for them. Patients are walking out with having printed out the entire internet of something on their disease state that they've been diagnosed. And sometimes Dr. Google is better. One of the things I think is interesting is if I'm putting lots of information in my fingerprint at the doctor, how much information can I usefully give the doctor before it becomes too much? I've just seen too many dimensions, too many possibilities. So the doctor may need ultimately some support with AI, lots of information, look at comparisons. The cube has everything in it. AI can do the thinking. Hey, Mr. Surgeon, we think there's an acute phase rise here. Please think about keeping the patient in for another 8 hours. Run a quick test before discharge. Wouldn't you want the discharge test now? Do a CRP in 7 minutes before leaving the ward, and then you go, oh, actually, maybe we can save an awful lot of pain from this sepsis case. So where else? You've got your NCD, you're living with your NCD, and you're hopefully trying to manage it. And what else can you do that we can do on top of that? And what's personalized? What can we take from the philosophy of measurement, routine personal measurements, into changing the way that we manage other diseases? And so I'm looking at quite a lot of things. HIV testing in Africa could now be done. So a triple antibody test done fully quantitatively could be done as part of a series of investigations. I could put HIV alongside malaria testing or alongside dengue fever testing, for example. I think allergy is a thing now. We're getting allergic to our food. Why are we getting allergic to our food? That doesn't make very good evolutionary sense, but we are. About 6 to 10% of children have got some sort of food allergy of some form. So we're going to do some allergy testing. We've got some of that in the clinic at the moment. But what about indoor allergies, living in this hygienic environment that we're living in? What about outdoor allergies where somehow we can't walk through fields without sneezing? Where do they come from? What are the origins of these allergies? We don't know where allergy comes from. It's very complex. But again, with enough data collected and globalized, maybe big data and big diagnosis can help with that. Women's health and fertility, I'll come back to that in a moment. What about an immediate profile of somebody when they arrive in casualty? I took my little boy to casualty. He'd had a fever for a few hours. Mum was a bit upset about it, so we took him in. The triage nurse put a thermometer in his ear, said his temperature was 35 degrees, and I said, no, it isn't. And the doctor said, probably not, go and wait for a couple of hours and we'll see what. So my initial triage was obviously wrong, and my child could have deteriorated. He didn't, he woke up, he broke the fever, and we were out within a couple of hours because he didn't need anything. But you get all these horror stories of babies presenting, and they're not sure what's wrong with it. The small volume heel prick might tell you they have a screaming CRP, might tell you they've got a whole series of septic markers. So I think those are interesting opportunities where you need the answer now. It's really important to have the answer where you need it. Food allergy is on the way out, so we are in final stage testing for food allergy now with these markers. These are top 8 food allergens. And so you can get the finger prick test. You can find out those markers that are in high sufficient concentration to point towards anaphylaxis. You can get some markers in your blood that point towards protection from food allergy, and you can do that in a single consultation. We recommend at the moment you do that with the immunologist because allergy is complex, but the answers will be there. And again, we can see how things like desensitization diets, eating a little bit of peanut every now and again, might improve the protective levels, IgG levels in your blood, improve your protective fingerprint. So we can begin to do that, and we can begin to address what is an NCD that's not on the list that I mentioned at the beginning. This is what it looks like. So there are 22 components in this profile. This has got a known peanut allergy, and often what happens now is that you arrive following some peanut event, something as dangerous as anaphylaxis maybe something just like swollen in your lips. And somebody does a test for peanut allergy. Because they're done one at a time at the moment in the laboratory, that's the result you get. You can confirm your peanut allergy and begin to start therapy for it if possible. But actually, this patient here had a bit of a problem with hazelnuts, something with cashew nuts, and something around wheat that was rather interesting they didn't know about. So now you have this allergy profile. Was it a problem with the peanut in something that had wheat with it as well? Was it a problem with it being peanut butter, for example, or some peanut sandwich they'd eaten? Does allergy add up? Now, concentration of IgG doesn't point towards severity, so these just don't add up to make a result that's 3 times bigger. But now you know, so this is not just saying, oh, the history told me the patient had peanut, I did a peanut test and they did a presumptive test and they did have peanut problems. This is about having a look-see. Again, available in 7 minutes, add the other test on to give you the protective layer in 15 minutes. That's changing, that's progress. Actually, not much point taking this to Africa because food allergy is hardly known at all in Africa. It's just not there. It's a very first world problem. This is an area where I think we can make a big difference. So the baby girl starts doing a menstrual cycle in the womb. It's an amazing piece of synchronous chemistry that's going up and down. And then, of course, there are lots of people that want to try and have children, want to coordinate those processes, want to understand their menstrual cycle. And so the girls have this menstrual cycle that's going up and down. It changes in frequency a bit. It changes, and sometimes it's a bit late, sometimes it's a bit early. What are the factors that change that? Can we measure cortisone? Can we measure other factors of stress in your lifestyle? Can you measure your liver function? Can you measure the impact of a new drug on your liver? Does that affect the rate at which the liver removes estrogen from the bloodstream, and so the period cycle? Can we understand a bit more about that? Let's measure that. Let's measure it when you're well, and let's see what happens when you're feeling unwell, and see whether these things are related somehow. They must be. These are complex, dynamic chemical systems, and they're going to be sensitive to all sorts of things, especially later on in life when the menstrual cycle collapses and you go into menopause. What is the right dose of you personally to have hormone replacement therapy so that that cycle peters out gently without too much stress? That's going to depend in part on your liver, because you may be taking other drugs, you may be having a fatty liver as well. So now we get to superpose these 2 major systems in the body to understand a bit more about this. This, I think, will be really important. We'll bring this out as soon as we can, probably in a couple of years. This is an example of a marker. This did make my list of non-NCDs at the top. This is an example of a biomarker that you really need to know now, not 3 weeks later on when you can get the appointment with the doctor and say, I was a bit depressed and this is what it felt like. Wouldn't it be really good if you could measure it? There's some great theories around the inflamed brain. There are some great candidate biomarkers, but then you get problems like the American side of the Atlantic and the European side of the Atlantic don't agree on what depression means. So we're going to have real trouble working out whether the biomarkers diagnose depression accurately. So I think we need to try lots of panels. We need to look at biomarkers for mental health. But now, could you in the moment of depression, make a quick finger prick test and see whether you've got your markers of depression elevated or down? Did the drug work? It affected your liver. We've just seen how it might have affected your liver. But did the drug make you feel better? Does it correlate with something that went up or down with the biomarkers of mental health? It's way back in the research laboratory, but I think we should bring this out quickly. It's got to be the subject of a large trial base, but let's try. And we can do it when you need it. Go straight back up into the cloud, and we can begin to do maybe even a big cohort study, 1,000 people, 10,000 people, to understand how these biomarkers work. Voluntarily sending you a chip home if you happen to own one of my devices. Really interesting idea. If you're a bit depressed, maybe you shouldn't be pricking your finger. Maybe that's a bit too much of a challenge. And the area I'd like to get into is to see whether we could understand biomarkers from saliva. So maybe if you are depressed, sucking a lolly, putting it in the instrument, that's a much lower level interaction. Much better for babies, much better even for animals. The problem is we slobber a lot. Somewhere between 0.5 and 1.5 litres of saliva every day. So if I take a measurement from your mouth and your CRP level was 80, if you're in a high slobbering phase, that's going to just dilute it. It'll be a number that's reading 30. Suddenly my fingerprint depends on how thirsty you are. My fingerprint depends on how hungry you are. It's all over the place. If I can fix that, and I've got some ideas, if I can fix that, then saliva has some real advantages in non-invasive biomarker testing. And then the at-home testing really works. It will be simply sucking on a lolly that has a little encouragement on it, not sugar, but something that changes color maybe, just a bit of excitement. Squeeze the lolly into the chip, and then you get a proper measurement. Saliva must come. This dilution problem has got to be overcome, but I think we can do it. There are some ideas there that will work. And then it will work in the chip. I've already broken the saliva matrix for measuring the SARS-CoV-2 antigen, so I know how to do the chemistry. I just know how to work out the dilution factor. So saliva is going to be interesting. Companion diagnostics for chemotherapy. This is an immunotherapy molecule you get given to keep your CRP level down. Here it is. It's working in this patient. Nice high concentration in their bloodstream. No inflammation. Really nice, working properly. All these other patients here, really high concentrations of the drug. It's no longer working. They've got used to the drug. They've rejected the drug. They've mounted an immune response to the drug. And so put the companion together. You can do this at home. Optimize the dose. Report the number in. AI can watch it for you and then tell the doctor when something goes wrong. Lots of interesting ideas in companion diagnostics. We've got COVID with us at the moment, and that means COVID and fatty liver disease, COVID and the flu, COVID and bacterial infections are going to happen, and we have a problem with antibiotics. We have a real problem with the bugs working out how to get around the antibiotic, and they're not effective. There are some cases in Birmingham in the UK recently where gonorrhea no longer responds to basic antibiotics. If we measure something early, such as CRP, and this is a reasonable measure of what's going on, but you can also put some other factors alongside it. So this is a patient that arguably might have the flu, but not with a CRP level that high. That's quite suspiciously wrong. So the flu and a bacterial infection, you don't want to be sent home saying it's the flu, come back in 2 days, when you're about to develop bacterial pneumonia. So I think getting a test in front of, a well-informed test in front of every antibiotic prescription is really important. This little guy, the handheld device, is one of the 4 leading technologies for the Longitude Prize in the UK, and they asked us to put it on permanent exhibition in the Science Museum. So if you go to the Science Museum in London, you can be able to see this in the new Wellcome Medical galleries on display there. My son has to go 14 times a year. So better information in these complex scenarios, a precision understanding about what's going on, identifying patient groups, understanding critical intervention areas, speed of the diagnosis, lots of opportunity for point of care. Short-lived, we can learn diseases that may be short-lived, NCDs that are going to be around. Can we train those out of you? What can we do, for example, with this thing that's around us at the moment, COVID? I'm a bit positive about the pandemic at the moment. It looks like it's stuck in this Omicron hole. Omicron is not really the son or the daughter of Delta or the son of Beta. It jumped to Omicron, and it now looks like it's stuck down the Omicron hole. If it stays there, we may be in with a chance of this becoming a winter flu. But we made some measurements, and you can look at people's profiles, and we can look at lots of them. So I measured vaccine responses to the Wuhan, that's the initial escape version, but Alpha, Beta, Gamma, Delta, and all these other Omicron variants. And for some patients, and this is why I'm quite excited, they have protection over all variants that I've measured so far. And 75% of people have this universal response. That's really exciting because it means that we're all going to be protected. If we keep the antibody levels up, we might have got this guy in a corner. Some people, about 25% of them, have gaps in their immunity profile. They need to know that. We need to fix it. But if you don't make the measurement, then you don't know these things. So we've been testing COVID testing here in Cayman at Integra for a while, and so I can show you the immunity profile of the Cayman Islands from 475 tests. And this is the response of antibodies to the spike protein. That's the sticky out bit at the top of the virus that we need to raid antibodies to be protective. And this tells me that something like the response of antibodies from less than 10% of the initial vaccine is now left in the Cayman population. So you've only got 10% of antibodies left, which means, and this, about a third of people here are way below that. So when BQ1 comes off the boat next week, and it's likely to, quite a few Caymanians are walking around with hardly any antibody protection. So now you can go next door and get the Moderna jab, which is bivalent. This is the response to Omicron. It's even worse, right? So this threshold here, even fewer antibodies above the threshold that I think will be protective. So there is a chance now if we can keep the antibodies levels high, if the virus sticks in Omicron, then maybe we can keep it as a cold. What I don't think we want is all this viral DNA being acquired by our own DNA, sitting there as a legacy to our COVID infections. Some people think that the Black Death viral DNA sitting in our genome causes autoimmune diseases. This is a novel paper that came out just last week. So, Cayman immunity, go and have your vaccine next door. Don't see why you wouldn't do that, because you can see a cruise ship every day with a new variant for you. The reason I get excited about this is the human cube. Not only can I tell you that the test was done properly, it's a good quality number, and that number is as good in sub-Saharan Africa as it is in the Cayman Islands, as it is in London. That's really important for the fidelity of the measurements. But now I can begin to put these ideas together. If it's there in blockchain, it's not going to disappear. If it's there in blockchain, you can agree for it to be released for me to do some science with and work out what the human condition is. How does NCD and COVID infection change? What happens to your liver function when you've had COVID 3 times? What if we could make those measurements really quickly? What if I get the handheld device out there into 10,000 people's hands, and they all do a test in one day? 10,000 data points on one day, the biggest clinical trial ever performed every day. That's a really nice idea to point towards NCDs and COVID infection, NCDs and flu infection, flu and COVID together against big drug cocktails. So I think the human cube actually changes the way we do things and makes big diagnosis a big opportunity. So let's change healthcare from break and fix to wellness monitoring. Let's have a look at what's going on. Let's intervene early. Let's make some lifestyle management changes, measure the benefit of the changes against some real pieces of chemistry that says, yes, my liver's getting better because I measured it properly. And then we can see where some of these other AI learning opportunities work. And this book here by Tom Lowry, who's a bit of a futurologist at Microsoft, has some of these AI promises in it. It's not all there yet. AI has got to learn, and that's quite hard. But we could address health span, we can address lifespan, and quality life. So those changes are going to be really interesting, and I think with the right measurements, we can move to what could be the beginnings of a new healthcare revolution. So I hope that was an interesting idea. Let's see whether my technology goes somewhere, and you'll see it here in Cayman pretty quickly.
We have Building Better Health for Self. The panel will be Andrew Vincent, Founding Director of Integra Healthcare Limited, Dr. Lisa Joels from Integra, Dr. Francisco Martinez, a general practitioner at Integra, and Dr. Andrew Shaw, who made his presentation just now. I'll invite the other panel members to come on up. And we'll transition very quickly to that final panel.
Yeah, and then open up for questions. Okay, good afternoon, ladies and gentlemen. So my privilege is to be the poster boy for poor self-management for health. They were looking for a fall guy, I think, to open up a session in which we look at improving health by taking responsibility. And they wanted someone who was a good illustrator of perhaps some of the challenges that we face as human beings. And that turned out to be me. I'm not sure whether it's a privilege or a comment. So. So in theory, I should be the epitome of health. I'm relatively health-wise. I'm director of a healthcare organization, I have access to exceptional healthcare, ready access, and I think we have really good access throughout the Cayman Islands, and I should really know how to access it, given my role in healthcare. I have sufficient economic ability to be able to pay for healthcare, and I think that's an interesting question for us to discuss later on. I have middle-tier health insurance, so that's also, in theory, going to give me enough cover that I should be able to address my health. And I'm going to say I have reasonably robust lineage. And of course, we can't necessarily instill that in people, but it does mean that, in theory, I should really be the epitome of health. I have a family that tend to live into their 80s and 90s and do not seem to suffer many of the common diseases. However, then there is life, and I'm a human being. So I really like chocolate. It's very nice after dinner in the evening to sit watching a movie, eating chocolate, perhaps with a glass of wine. I enjoy my food. I think this is something that I have a lot of friends in Cayman who would say exactly the same thing. Of course, I probably don't get enough sleep because I'm a busy professional. And because I'm a busy professional, I also spend too much time in front of my computer screen. And one of the consequences of that, of course, is that I don't spend enough time in the outdoors exercising and doing things that are good for me. And so I wanted to introduce this term, health-life balance. Has anyone heard of health-life balance? Because actually we talk a lot more about work-life balance, don't we? And so I say work-life balance, everyone goes, oh yes, I know what you mean. And I think there are three dimensions to this. So we talk about work-life balance, but it's actually work-life and health. And sometimes they conflict with each other. It's a conflicting triumvirate. And if we spend more time at work, we get less exercise. Sometimes it causes us stress. It encourages a poor diet. We dive out for something unhealthy quickly at lunchtime, as opposed to really thinking about what we're putting inside us. And of course, if you're like me, self-confessed, because remember I am the poster boy for poor choices, we also enjoy more life, which can, again, contribute to a poor diet, to more indulgence, and it definitely contributes to less sleep. Of course, it adds up to less health. So for me, this became particularly important because after half a century of essentially no health problems whatsoever, not even a broken bone, no sports injuries, a few bugs, that was it, a few scrapes from falling over on a hockey pitch, I found myself being diagnosed with metabolic disease, something we've heard about over the last couple of days. And then I found myself rather suddenly under the care of the amazing Dr. Ravi in Health City for a heart complaint that came out of nowhere. And all of a sudden, my health, my responsibility, became very, very real to me. So what do? We go to our trusted professionals. We have tests. We've just heard about tests. They measure stuff. The screening that we've been talking about over the last 2 days. There are findings in that screening even. And of course, there are explanations, some of which we understand, some of which we don't understand, and some of which we don't want to understand, particularly if it conflicts with life. And then, of course, the outcome of this discussion with our trusted professionals who we've gone to tell us how to address some of these issues is they say, well, this is all very easy. What you need to do is, essentially what you need is, well, you can start by cutting out that, because you don't really need that. Oh, and that's not very good for you, so you can take that out. And of course, you want a lot less of that, you want a lot less of that, and of course, if you can get some more sleep as well, then actually we'll be on the straight and narrow. The problem is that that conflicts with us behaviorally. And I think we've got to do more to address some of the behavioral issues, not just the advice that says, look, just forget all the stuff you really, really enjoy, or that you have to do for economic security, because it's in your health interest. You'll be miserable. Is that such a good outcome? And maybe happiness is also part of this equation that needs to go onto that list. But I've got to realize that if I want a long life of walking on our beautiful Cayman beaches, for instance, with my wife, then I have to recognize that it's my health, and therefore it's my responsibility. And what I would say is, besides my wife, and maybe my dogs, nobody is going to love me and my health more than me. And therefore it is my responsibility, and I need to learn to behave as though it's my responsibility. I need to engage in better understanding, And mostly I need to step beyond my own excuses and the common ones we all know. Don't worry, I'm going to fix it before it becomes an issue. Of course, you couldn't tell me that. I needed to know that, really, just before I ended up in Health City. I'm going to eat healthier. I'm not going to be susceptible to things. I've got good lineage. I'm not going to suffer from these things, but they're all excuses, and we have to step beyond them. The other thing that I think needs addressing is the fact that I started with this epitome of health, but I can do these things. But when we're talking about the health of a nation of people, only some people have access to what I'm fortunate enough to have access to. Not everybody has the same degree of health information. Definitely not everybody has the same access to healthcare. They don't necessarily have sufficient economic ability, and of course that transfers not just in terms of access to healthcare, but also things like food choices. We heard yesterday about the CPI looking at a basket of goods, and what we heard, of course, was that all the unhealthy things stayed remarkably cheap, and all the really healthy things were becoming super expensive. Well, that's going to have a long-term impact, but it's going to have its biggest impact on the people less able to afford to make healthy choices. Many of us do not have middle-tier health insurance. That's a big issue. And I think one of the ironies is some of our basic health plans that are designed to put in place basic health actually do not invest in wellness. They simply catch you when you're sick. And maybe if we want to change the health status of a nation, what we have to do is recognize the importance of wellness and early intervention, and actually that's more important than having the safety net. We can't do anything about reasonably robust lineage. So I'm going to throw a gauntlet down, and it's a gauntlet to my colleagues, my other colleagues in healthcare. How do we ensure everybody is at least health-wise enough that they can make good choices and understand their responsibility, that it's a collective responsibility? How do we ensure that everyone has access to trusted evidence? I think if we've learned something super hard over COVID, it's that actually the misinformation that can prevail over proper information. I mean, you can go onto Facebook, just limited to the Cayman Islands, and you can find every view of COVID vaccination you could possibly ever want to. So, of course, if you're a bit skeptical anyway, you just go out and look at the evidence that suits your point of view. But it doesn't mean it's evidence-based. It's just misinformation available. We have to make sure that we address that. We need exceptional access to healthcare. So how do we create a system that gives access to healthcare irrespective of sufficient economic ability and irrespective of insurance quality? I think we've got to design healthcare better for people that want to take responsibility. So, of course, when we get sick, it's very easy to take some time off work and go and see your doctor. But how easy is it to take time off work to go and see your doctor when you're well? And doctors tend to work 9 to 5, just like everybody else. And so maybe if we want to transform health, we have to transform access so that people can address wellness when they're able to. And how do we learn to keep people well longer? That's a big challenge for us as healthcare professionals, because obviously Andrew talked about health span. The longer we keep people in good health, ultimately the better for us all it is. So with that, I'm going to hand over to my colleagues, who are now hopefully going to address some of the questions or gauntlets that I've thrown down. Thank you. I'm going to introduce Lisa Joels. Lisa Joels is an expert in women's health as an obstetrician and gynecologist with Integra Healthcare. Lisa.
Well, thank you very much for asking me to talk. You've asked me to talk about women's health for all ages, so I thought I'd focus on prevention and what modern medicine can do to help keep us well. And when I was thinking about how to start this talk, I thought about the very famous speech in As You Like It, written by William Shakespeare. And so with apologies to the bard, all the world's a stage, all the men and women merely players. They have their exits and their entrances, and one woman in her time plays many parts, her acts being 7 ages. So I thought I'd talk you through the 7 ages of woman. The first stage is the infant, but in fact, there's a couple of really rare gynecological things that can happen to newborn babies. So I'm not going to talk about that. What I'm really going to talk about is being born. So the journey from the mother's womb to the outside world is the most dangerous journey that the majority of us will make, unless we're Bear Grylls or some kind of explorer. The risk of dying during the process of being born is called an intrapartum stillbirth, and this is a terrible tragedy. The risk of dying in the UK during labour and birth is 4.1 per 1,000. But the worst place in the world is in Africa, in Sierra Leone, where the risk of dying in childbirth is 190 per 1,000 births. The difference between the two places is the caesarean section rate in the United Kingdom is running at about 30 to 35%. In Sierra Leone, it's 2%. So what they lack in large parts of the third world is access to midwifery and obstetric care. And the World Health Organization has identified this as a massive problem. So we know that worldwide, 2.6 million babies are stillborn every year. That's going to add up over the next 10 years to nearly 20 million deaths, which is horrific. And what the World Health Organization has identified is women need access to trained birth attendants, so obstetricians and midwives, and even traditional birth attendants who may not have a university-level education. By identifying and managing risks antenatally and during the birth process, we can reduce the risk of stillbirth from that terrific rate in Sierra Leone down to the first world rates at around 4 or 5%. Moving on, the second age is the whining schoolgirl in the speech. So we're talking about the preteens here, and what I wanted to focus here is about prevention. So the HPV vaccine is one of the most amazing health changes that has happened in the last 20 years. So this has been available since 2006 in Australia, 2007 in the US, 2008 in the UK. And it's best if girls are vaccinated at age 12 to 13, because that's before they become sexually active in the vast majority of cases. And we know if they're vaccinated before they're ever exposed to the virus, that we get a reduction in HPV infection. So the prevalence of HPV infection is about 30% of the population. With HPV vaccine, that falls to 2%. And what that translates into is an 87% reduction in cervical cancer. That's massive. And the HPV infection causes precancerous changes. So in the UK, they did a study in 2019, and by June 2019, they had seen 450 fewer cervical cancers. Now, this has an incidence of about 3,300 per year in the UK, with about 1,100 deaths per annum for cervical cancer in the UK. So that's a significant reduction. But look at the other figure. 17,000 fewer severe precancers. Now, those severe precancers can be treated, but the treatment is invasive, it's difficult, and it can leave long-term health problems. So a reduction in 17,000. Think about the suffering that's reduced, but also think about the healthcare costs that are reduced. So what we are now finding is that cervical cancer is extremely preventable with 4 things: HPV vaccination, cervical screening, stopping smoking, and treating precancers. We now think we can treat 99% of all cervical cancers, and this is going to be almost eradicated for girls born after the 1st of September 1995. The third age, the lover. So we're talking about adolescence. So this is the phase of puberty, when those girls' bodies are going through changes. There's changes to their body, but there's also changes to their brain and changes to their emotions, and part of that is their sexuality. I want to talk about teenage pregnancy. So teenage pregnancy, including the older teenagers, so the 18 and 19-year-old, make a massive difference to a woman's educational attainment and to her life choices and the kind of job that she's going to get. So women who don't complete their education and don't go on to apprenticeships, college, or university are usually stuck in low-paid minimum wage jobs forever. And there's a really interesting study from the United States which showed that 90% of girls who don't have a teenage pregnancy get their high school diploma and graduate by the age of 18. But with those girls who have a teenage pregnancy, only 50% of them get that high school diploma by age 22. So that's going to make a massive difference to the type of jobs they're going to get. The babies born to those teenage mothers have an increased risk of being born preterm and being low birth weight. But shockingly, they also have a significantly higher chance of dying in the first year of life. And they're also more vulnerable to accidents and behavioral problems long term. So it's not just the mum that suffers, the children suffer too. And so what we need to focus on in terms of prevention for this stage of the girl's life is preventing that pregnancy. And what we should be pushing the girls towards is long-acting contraception, the fit and forget. So that's either the intrauterine devices or, and it's usually more acceptable for the younger teenagers, the subdermal implant, which goes into the non-dominant arm. It's very easy to fit. It takes about 5 minutes in clinic under a local anesthetic. And we are then increasing the life choices that those women had. And we'd actually heard that message earlier today about educational attainment. So the fourth age, Shakespeare describes as a soldier, and this is a bit of a battleground. These are women that are establishing themselves in their peer group, they're finding their life partner, they're establishing themselves in their careers, and also they're wanting to start a family. So this is a really busy phase of their life. So what we should be focusing on for this group of patients is optimizing their health for pregnancy. And one of the really preventable conditions is spina bifida. So spina bifida is where the spine or the skull doesn't form completely and can lead to babies not surviving. But a lot of babies that do survive also survive with a lot of handicap and a lot of problems. And it can be prevented by taking folic acid. Now, as you can see from the little picture on the right-hand side of your screen, you can get folic acid from a wide range of vegetables, delicious vegetables, but you'd have to eat 4 or 5 portions of sprouts or cabbage a day, every single day, to get the same amount of folic acid that you need, which you could just take a pill for. So we should be making sure that women are educated that before they stop their contraception, they should be taking folic acid so the levels are high in their system. But we should also take this as an opportunity to look at their wider health, to optimize their health, to help them to address the issues of weight and body mass index. And we've heard a lot about that. Some really interesting talks earlier today. We should be supporting them with diet and exercise. We should be making sure they're on adequate vitamin D. Vitamin D is going to be a bit of a theme here, and we actually heard it earlier today. And all of us in this room should be on vitamin D, because although we live in a sunny Caribbean island, I put it to you, we all work for a living. We don't go and lie on the beach. And we wear factor 50 sun cream when we do go outside. So actually, most of us are vitamin D deficient, and we should be just taking our sunshine vitamin every day. But this is a real opportunity for the woman to have a health check with her OBGYN, to review medications, to make sure that she's on medication that is safe for pregnancy if she needs that medication for other medical problems that she has, for dealing with health concerns, and for making sure her screening is up to date so that her body goes into pregnancy in the best frame that it can. The fifth age is called the justice, as Shakespeare put it. So this is middle age. Now, this is when you realize that the woman really is the linchpin of the family, okay? This is the squeezed generation. This will be the woman that's at the peak of her career, who's also managing a husband who's at the peak of his career, just starting to come into his comorbidities. She may have teenage children going through all the teenage angst, but also taking all those really important exams with all the stress that that causes. And she's got aging parents as well that she needs to deal with. So the mother is the linchpin of the family, and her health, therefore, is a key priority, and she often puts it last. So with those family pressures and her mental health issues, we need to be supporting the women in middle age. We need to be making sure that they have their cervical smears up to date, that when they get to the appropriate time according to their family risks, that they start having mammograms, and that their wellness checks include looking for blood pressure issues, checking body mass index and optimizing that where possible, and looking at their heart health and their bone health. Moving on, the sixth age, the menopause and beyond. So this is a really important time. The ovaries stop working and stop producing estrogen, but the woman's body keeps on producing testosterone. So the woman will notice her body changing, her periods will stop. Great. However, she'll start getting hot flushes, she'll start putting weight on around the middle. And the main symptoms of the menopause are hot flushes, night sweats, which lead to sleep disruption, which leads to fatigue, which leads to being exhausted the whole time. It can lead to brain fog, anxiety. There are about 34, 35 recognized symptoms of the menopause, so it's not just about hot flushes. And 80% of women will get symptoms, but the good news is only 20% of those have severe symptoms. And for the vast majority of people, those symptoms last for 2 to 3 years. There are a small number of women where it goes on long term, but for most people, it's 2 to 3 years. And the wonder drug here is hormone replacement therapy. Okay, it is literally putting back bioidentical hormones that the woman is missing, and it can tide her over that short period of time. Now, there's been a lot in the press over the last 20 years about HRT, the bad boy that's causing breast cancer. Actually, it's been badly misrepresented, and the risk of breast cancer only starts to rise after 5 years of use of HRT. And so, as you can see, if a woman's only going to have symptoms for a couple of years, we can tide her over with a short course of hormone replacement therapy, ease her into the menopause, and then take her off it. And what people don't talk about is the health benefits of HRT. It controls symptoms. They get their brains back, their brain fog goes, they're not fatigued, they're not snapping at the kids and the husband. They can make decisions at work again. There are long-term health benefits. There is reduced cancers. So there is a reduction in colon cancer and pancreatic cancer, and a really important impact on bone health, which I'll come back to in a minute. Another really important screening, though, is postmenopausal bleeding. So we need to really educate women that if they do experience bleeding after they've had their menopause, that this can be a sign of something serious. Now, there's a 10% risk of cancer of the lining of the womb, endometrial cancer, in women with postmenopausal bleeding. So that means 90% don't have it, but you've got to look for it. So they need to know that this is an important thing to bring to the attention of their OBGYN. Moving on to the 7th age, the last scene of all, old age. And one of the really important things here is osteoporosis. So there is this concept of a fracture threshold. So our bone density goes up and peaks in our early 20s, and thereafter it gradually declines. But once you go through the menopause and lose estrogen, that decline speeds up, and there comes a fracture threshold at which a small fall, a minimal trauma, will cause a fracture of a bone. The other the other important thing there is 1 in 4 people age 65 will fall. And part of that is about muscle. So there's something called sarcopenia, which is where proximal muscles are lost. So this is the muscles in the arms and the upper legs, the thighs. And there can be some issues with balance and gait, which means that older people are more likely to fall. And if they fall, they're more likely to have a fracture. The rule of thirds with hip fractures is really quite shocking. So for women over the age of 75 with a hip fracture, 1/3 will recover and go home. 1/3 will recover and have to go into long-term care and never return to independent living. And 1/3 will die from their fracture. So really startling statistics. So prevention of osteoporosis is a really important thing. And you can see from that X-ray the difference between normal bone, which looks good and strong like a piece of coral, and that osteoporotic bone, where it's just fragile, and you can see that's got no strength in it at all. So how can we prevent that? So we need to educate people. We're back to vitamin D, the sunshine vitamin. It's really important for bone health. But we also need to be doing impact exercise. That's really good for maintaining bone strength. And that doesn't just have to be jogging and running, because that can be really hard on your joints. It can be just doing a decent amount of walking each day, or dancing, or doing Keep Fit. Anything that's impact exercise will keep bone health going normally. And hormone replacement also will have an impact because you're putting back natural bioidentical estrogen. You are maintaining bone integrity. And you can screen for this using a DEXA scan. It's a very simple bone density scan. So I hope I've demonstrated to you that we do have a responsibility to ourselves to maintain our wellness through our life, and that prevention is definitely better than cure. So by combining wellness checks with your GP and with your obstetrician and gynecologist, we should be looking at optimizing women's health at every stage of their life. Women should be engaging with screening programs for cervical screening, breast cancer screening, and heart disease screening. And we need to take ownership of our own health and well-being with diet and exercise and mental health awareness. Thank you for your attention.
So I'd like to introduce Dr. Martinez. Dr. Martinez is a GP and one of the founding directors of Integra Healthcare, who's going to talk about the difficult subject of men's health.
Thank you. Hello, everybody. Good afternoon. I can see this talk is not about rum tasting, because I hardly see men here. It's about health. when you talk about health, normally you see female listening. This is why Lisa has such an intelligent audience, because they take care of their health. Men doesn't take care of their health. So it's a challenge to, this is the one to advance. If you are wondering which is the weaker sex, it's not females, it's men, because they live less and they get sick more. So men are more likely to have heart disease, stroke, diabetes. Women are more likely to have arthritis and depression. Maybe depression is linked to the husband having a stroke, heart disease. And it's a problem that is not seen in one place, it's in the whole world. I practiced medicine in Spain, UK, and Cayman. It's the same everywhere. It doesn't matter the culture. There are many, many articles, papers about the main use of healthcare. All of them shows that men goes much less than women to the doctor. And there are many theories, no? The main ones of why goes back to the origins, no? When the man used to go hunting, the woman used to stay taking care of the children back in the cave, providing food, taking care of the diseases of them, and then the man came in the evening, throw there the food, and that's it. Also, this role, even with the society changed, is so inside of us that nowadays any pediatrician can tell you who goes to the doctor with the child, to the pediatrician, mainly the mother. And who goes to the gynecologist, because women start early with things like menstrual periods that can have problems. They go to the gynecologist. They get pregnant, they have to go to the gynecologist. Men doesn't go through that, so they are not exposed to the healthcare. It's very rare. Sometimes they go with the wife for the scans or something, but they never go for themselves, no? So they don't have we don't have a culture of taking care of our health, of going to the doctor, going to the clinic. Consequences. Here you have the graphic, no? In diabetes, avoiding the doctor makes that we have more diabetes than women. Why? Because if you don't catch the diabetes early, it progresses worse. If you don't have a constant relationship with a doctor, nobody is telling you about good habits, telling you, oh, you should do this, you should go to the gym. And when you say go to the gym, normally who tells you that has no time is the man. The woman goes to work, wake up early in the morning, run, goes home, pick up the children from the school, do the homework with them, prepare the dinner, and the one who has no time for the gym or for running is the man that goes home after work and sit down in a couch watching TV, or with the friends for a drink. So heart disease, that is, apart from cancer, is the main killer in the first world. More men die of heart disease. You can see the statistics there of the coronary heart disease being the top cause of death for men. And we come back to the same. They never sit down with a professional that can ask questions and find the problems when they are starting. Because we men tend to think that many things happen and will disappear by themselves, no? We don't pay importance. So this is why I say the solution for these things is go to your GP, chat, because what you think is nothing, someone can tell you is the beginning of something. And your GP can inform you about risk factors, the ones you can prevent, can ask you, did your dad die of a heart attack, and start in an early prevention, can convince to quit smoking. Unfortunately, with women, when they copy habits from men, it's bad for them. In the 60s, women started to smoke, and lung cancer was very low in women, very high in men, and started to rise. So never behave like a man. Cancer. Cancer is the second leading cause of death among American men. I will say that among all men in the first world. The main reason for years was smoking a habit, no? Then we have skin cancer, sometimes because people has a profession that is outside, in outdoors. But the main times, and you will see here in the beach, is a woman using cream, sun cream, wearing clothes to cover, and a man playing the, well, nothing happens to me. So because if I put a cream, I'm not as man as I'm supposed to be. We have the prostate cancer that is unique in men, and unfortunately in Afro-Caribbean population, can appear as early as in the 30s, what is very strange to see in a Caucasian. So again, it's a cancer that is very easy to treat. Go early, have your checkup, chat with your doctor, tell the history of your family, do a prostate exam, do a PSA. If we catch it early, we can cure it, because oncology has advanced more than ever. Now the secret of surviving a cancer is early detection. And we have the colorectal and lung cancer we talked before. Colorectal cancer, go to the doctor, tell them, again, the family history, and if not, start in a prevention screening program, doing your colonoscopy. Has been always after 50. Now they are starting to recommend it after 45. And of course, if you have a dad, a sister, a brother with a colon cancer, before, to see where you are. If you catch a colon cancer at the early beginning, it's easy to resolve. If you wait, you can die or have terrible consequences, no, in your life. Diabetes, we were talking before, no? Women has more belly fat. Even we don't have a reduction in estrogens, we have many other reasons, no? We move less. Just taking care of the kids is an exercise, okay? And moving around home, cooking dinner, is an exercise. While you are doing that, the man is sitting, drinking a beer, watching the TV. And belly fat is absolutely associated to diabetes 2 and to cardiovascular risk. How do you prevent that? Because the secret is prevention, it's not treatment. You prevent it, going to the doctor. The doctor will look at you, will give you good advices, and can check something so cheap and easy like the HbA1c that Professor Shaw was saying before. And you can catch a pre-diabetes when you can reverse it, easily reverse it with lifestyle changes. You don't need a single drug for that. But if you don't go, I have seen people here that comes when they need insulin from the beginning, and they have severe complications in eyes, kidney, and circulation. I saw a case of a poor Jamaican guy. The first time he goes to the doctor, he goes to hospital to have the foot amputated. So this can be only done by a man that see the foot destroyed and never go to the doctor. Then we have something that is only for men, no? That is erectile dysfunction. Erectile dysfunction is related with many things: age, diabetes, hypertension, medications. can produce problems at home, no? The men can feel frustrated, suffer psychological problems, and if it is a young person, cannot have a child, no? So why don't we go to the doctor to ask him? There is a collection of drugs to stop it that works perfectly. And they work so good that I did a tour in Miami through the canals to see the mansions of the main actors and famous people. And the biggest one was of the guy who discovered Viagra. So this is how useful it is. HPV and other STIs. This is a big problem for men and for the woman living with him. So if you hide the possibility of having an STI, in the past they used to be called STDs, but we don't want to call it disease anymore because it's a stigma. No? You can get cured of many of them. So we call it now sexually transmitted infections. We have the human papillomavirus that we can get a vaccine, is indicated for men from the teenage and before a person turns 26, and in some cases, even later. The human papillomavirus can resolve by itself, but if it doesn't, and you don't catch it, and you pass it to your partner, she can have a cancer, cervix cancer, okay? And men can have penile cancer, genital warts. And in other STIs, as syphilis, you give penicillin 3-4 courses, it's gone. But if you wait, you have a very advanced syphilis that can affect even your brain, can produce dementia, can affect the nerves in the body. And then we have the life-threatening ones, no? HIV, hepatitis B. So these two can kill you. You need a treatment. And of course, you should never pass it to anyone else. So the only way to stop the spreading and to prevent the problems that these infections can produce is to go to the doctor and check it. If you had a risk relationship, be brave. You were brave to do it. Be brave to go to the doctor and tell him. He will not tell anyone. And he will do the test and he will advise you what to do. And mainly he will tell you, you need to tell your wife. No, because I have seen cases here where the wife has been transmitted the disease by the husband, by a husband cheating. So go to the doctor. The doctor is not going to go to the police, to the preacher, or to your wife. He's going to give you a good advice and a diagnosis. And he's going to tell you how to prevent it. You want to continue having this. I'm not judging, no? If you are planning to continue doing this, I will tell you, use a condom. No, don't bring anything. Low testosterone. Now, testosterone in the last 10, 15 years is very popular, no? That picture can give an idea of something that maybe in a 50 years old is not going to happen, no? He will not look like the optimal testosterone guy, but he will need many hours in the gym. But testosterone, there has been so much controversy in the United States. You have T clinics dedicated only to testosterone. So the prevalence of low testosterone, of course, like many things, grows with age. So 12% in men in their 50s, 1960s, 28 in the 70s, and almost half of the people who is 80. In all the discussions in the last years about the testosterone replacement, when do we offer replacement? When we, in this case, Professor Shaw was telling we treat numbers. In this case, we treat patient, but we need a number, because if we don't have the number, we must be for another reason. So when a patient is symptomatic, has a low sexual drive, can have erectile dysfunction, feels tired, fatigue, is increasing obesity, is having very weak muscles, is the time that we give a hormone replacement, because this is a hormone replacement like the ones Dr. Joels is giving to the woman. Probably this is the thing that men comes to ask for more. During the past, testosterone was said to produce prostate cancer. That has been in multiple studies refused. No? Testosterone replacement doesn't increase the chances of having prostate cancer. There are discussions if testosterone replacement can increase the size of the prostate. Still not clear. And there is a nice discussion about the cardiovascular, because some studies tell us that replacing the testosterone artificially will reduce the chances of having a stroke, a heart attack. There were other studies saying that you can increase it. But the problem with the studies who says that you increase it is that they were done in people over 75, whose risk of stroke and heart attack is higher by age. There are ways of replacement, injections and gels mainly. There is an oral one, but has more side effects in liver. And I will say the main thing to control when you go to testosterone replacement is testosterone has the capacity, the ability of increasing the red blood cells. So you need to check the number of red blood cells. If they go very high, you stop for a while. And to increase the PSA. Recently, I had a patient that his PSA went to 9. We stopped the testosterone for a month, back to 1, normal. Why? Because he was overdosed. He decided by himself to apply twice the amount of the gel I prescribed. So, because he was feeling that he was going to the gym, and he was feeling stronger, because testosterone makes you feel that, no? Makes you feel generally better. Depression. Depression, again, we are going to the stigma. No man likes to say he's sad, he's going through a bad time, this is for women. And it's not true. It's real that women suffer more depression than men. There are many reasons, some of them physiological, other ones cultural, because women are not treated as sane as men, not yet. We are still trying. But men experience depression. The ways how they show, they are not going to tell, normally they don't tell the wife of the partner, I'm sad, I don't want to do anything, I would like to stay in bed. No, they get irritable, anger, they will blame the partner of anything. So it can become a problem of even, in extreme cases, domestic abuse. So we need to keep the man away from depression. How? Go to the doctor. There are fantastic medications to put in 3 weeks the mood of a person in a normal level. And chatting, chatting with your doctor, and telling everything you are feeling to try to control it, anxiety, depression. So what I recommend, there are many females here, is that your partners, when you see them behaving like that, recommend them to go to the doctor. Maybe there is a depression behind. And it can be treatable as 3-4 weeks to see the results. And this is the thank you for listening to me, okay?
So I'm learning something. I think I've actually got a pre-optimal testosterone body. It's got nothing to do with my lifestyle after all. So I'm going to welcome, actually, before I welcome Professor Shaw back up, I want to really ask a couple of questions. So do you get the impression that from a healthcare perspective, we actually have a lot of the answers in terms of knowing what to do? Yeah. So who then, this is kind of a leading question because I've kind of set it up, but do we have a healthcare issue or a behavioral issue then in addressing our health? Yeah, so yeah, it's a behavioral issue, isn't it? So I'm going to invite Professor Shaw up to talk about, actually, although he's going to talk about technology, I actually think he's going to talk about behavior. So Professor Shaw.
Have you changed the slide deck? So I think many of the stories we've just heard have the opportunity for measurement and my technology to make a difference. So if you are a man, maybe it's easier for you to make a measurement at home and come up with something that says you're depressed or your testosterone levels are falling. Maybe it's easier for you to do that on your own. Maybe it's easier for you to then take a teleconsultation. Maybe we can nudge the boys into doing some better healthcare. But it is important that you get the right tests. We need to learn to develop the right tests. They can be expensive. They're going to go off to the laboratory. They can be, yes, not point-of-care tests at all. And they are, in my mind, some of them are really quite bad with not giving the right answer. But now, I'm going to give you the right answer. Not just here, but everywhere. In the bathroom, in the bedroom, wherever you make the test. So fully quantitative, big profile of what's going on. I think it's really important to understand, if you're doing hormone replacement therapy, that you knew what your hormones were before the therapy was required. That make the transition better. So let's profile things properly. Let's use what the science can do to make the doctors, empower the doctors to make better clinical decisions. So what? What if the consultation is anywhere? I think it's really important that we get used to nudging different types of behavior. The consultation can be in Africa. Teleconsultation will happen everywhere now. I think my children will probably go to their doctor via video call much more frequently in the future than we attended. What about doing something in the ambulance? The best first decision means you can do the test. Maybe when you pitch up at the ambulance at the hospital, the ambulance has already made the test for you. They've made the diagnosis, the data have come back from the ambulance to the hospital. Everybody's ready for you, the right team is waiting for you, the decision's been made. In the emergency department as well, I think blood tests are very rarely available in time. Some of them are, but I think more of them can be done. But I think in the GP consultation, which in the UK is only 11 minutes, you've got to get in, get your test result, get the diagnosis and get out again. The care pathways are tricky, but all of them require, I think, the ability to give the right test result when you need it at the right time. And it's complex. You've seen this idea that I have, the idea that you can make the test at home and I can check that it's a good one, check that you did the test properly. Then I've got the data in the cube and I can give that to the doctor properly and the teleconsultation then becomes properly informed. Maybe the boys are going to be better at doing it. First of all, it's a toy. Boys and toys work quite well. Expensive toy, even better. So maybe we can play with our toy. Maybe the gamification is an interesting motivator. Maybe we can do what's more, do much more through the idea that the data go into a game and you start to play it. Maybe these are different. Maybe even a testosterone-ridden game where you can encourage the boys to participate. So what we seem to be unable to address is this massive problem around the globe. I don't know whether I've got the answer yet, but maybe I have a chance. Maybe if you can see the right data at the right time with the right information, maybe there is a chance to do this. Why not simply address what we may do, what we can do, and at least not cost us a fortune? Let's have the test at a reasonable sort of price. Let's do it frequently. Let's do it when you want to do it. Let's have a go at this solution to the problem, which is an amazing inability to get the test results when you need them. So the bias is all behavioral. We picked it up. This corner of the room shouted out behavioral. You're absolutely right. There are lots of problems here associated with the availability of the test. the limited attention span we have. You want to go into the GP consultation, you now want the answer. Gen Z, Generation Zers are going to want to sit on the sofa, mail away their blood test, get the answer back to their app without having to go anywhere near the doctor if they don't need to. But I think if you can order the blood test and get the result in the way that you order the pizza, then there's a way of getting the behavioral activity on your side. I do think learned helplessness bias. I mean, I think there's some questions about boys needing to be taken to the surgery by their wives. I think there's something around that we can change again, maybe empowering with a different way of collecting the data, a different way of, if you're involved in the process of collecting the data. And these things then become interesting ideas. So lots of different biases, this is 9-dimensional here, that change by having a different way of receiving the data and giving the data to you when you need it. So let's revise the paradigm, let's change, make something different. Patient attends to wellness, for a wellness screening, already that's novel. Some people with executive benefits get wellness screening. The big panel of blood tests are taken annually. Very rarely does anybody else do that. Maybe you would do that if it was possible at home. Doing a chip once every 3 months or something, once every 6 months in the bathroom at home, not an amazing problem. So a wellness screen, find out what's normal for me, find out where I am now. And you've just heard all these stats that we've been hearing about the diseases in both boys and girls, just get worse with age. As you get older, you just experience life more, you pick up mistakes, you pick up exposure to sunlight, you pick up exposure to the environment, and age just ticks on. So if you know what's good now, then you can begin to see what happens as you get a bit older. Diabetes panel. At the, when you arrive at the consultation commences, you've got the data in the hand, you know what's normal for you, you know what's on your records, maybe share that with your blockchain. The results are identified from the fatty liver disease, consistent with the diabetes, and then you get an immediate diagnosis. You're in the door, you get the answer, or you make the measurement at home, you get the teleconsultation, you get the answer, and off you go. That sort of need to get things moving, to get the world working on your side is quite strong. All this within a single consultation, why not? If you turn up in a really bolshy mood and want antibiotics, I can say no, the test doesn't allow that to be prescribed. Patients comply with antimicrobial resistance stewardship. They understand that if you don't get the test, you don't get the antibiotics. So I think we can change this. This is the paradigm. This is what we need to do. Get the answers that you need when you need them. So we can begin to eliminate some of these biases at the top here. And we can begin to eliminate, in fact, all of them. We're going to be less defensive about things. We're going to be more acceptance and discussion because the data are there. It's going to be quite hard to say no to something if it's there. What if you are a man and you're depressed and yet you won't tell anybody about it? But the idea of a biomarker panel for mental health might point to depression. It's going to be hard to deny at some point, to deny the test result. So maybe we can get over some of these acceptance discussions. And we can begin to trust the immediate results as we get them. All of these things may be addressed by just having the right answer at the right time for you, nudged maybe by some gamification, nudged by some testosterone reward. All of these are really interesting ideas that might change the way we get the paradigm of the new paradigm right. So, from the dark, we know that so many people, in that Mexican study I showed earlier, so many people have no idea whether in some pre-diabetic state or some pre-NCD state. From that ignorance, by a simple set of tests, routinely changing the culture a bit, leading to intervention, all in a single consultation, and we have to eat more of these lovely vegetables. So I think that sets you up from what's the problem, doc? Something's wrong there. What do I do, and how do I fix it? Even better if we know a bit about you and what's normal for you and where you've come from, so know what the changes are. So ignorance to intervention in a single consultation, I think that's where we need to be. This is really exciting. If there is a way of getting out of something as complex as type 2 diabetes by some simple testing, by a teleconsultation, by a nudge, by a gamification, by a colleague that you're competing with, by a class in which children are competing with one another, why we're not engaged in some sort of route to remission that would result in elimination or for even young children, type 2 diabetes. And if you've got type 2 diabetes beginning at the age of 8, there's a boy in my son's class who is nearly spherical, and he really needs to work much harder to get his weight under control. And I think if you could engage in a game, nudge him to be a bit more engaged in the process, then we stand a better chance of making a difference. So, lots of benefits globally, benefits that we're not going to see in the Western world, but globally, telehealth, no travel, best possible management, multi-professional approach. We can engage all sorts of different people in the process of managing the condition as it presents, from the doctor, the physician, through to the diabetes nurse. All of them are now empowered to make the measurement and make the transition. All of this is self-reinforcing. Maybe you feel better because you're doing something about your health. Maybe if you make a quiet measurement somewhere and see it's going better, maybe you feel a bit stronger as that manhunter again. So all these self-reinforcing processes, I think, are encouraging. But on your own terms, with the right number in your hand, I think these are interesting ideas. So improved access to healthcare internationally, into every corner of the planet, into every nook and creek, every restaurant, every hospital. In all of these places can now have proper diagnostic accuracy. It's you as well. The personalization is critical. That allergy profile I showed earlier, the immunity profile I showed earlier, you just need to know where you are, and then you can do something about it. I think there's a lot of data going to get collected. A lot of data about you will be collected, and I think we'll have to learn to do some AI machine learning. I think that will be really exciting. It's not there yet, but I think it has the opportunity to make a difference. Diagnostic and predictive algorithms can then be invented, giving the doctor decision-making at the point in the ward at night when they've done 55 patients, they're a bit tired, they're under stress. Maybe the AI can help make some of those mistakes less likely. And how many diseases could we tackle at once? Can we tackle all of them? But you've got your NCD with your COVID infection, you've got your NCD with your food allergies. Everything is linked in this really amazing piece of chemistry that is our bodies. So that's my conclusion. That's where I think we might take healthcare.
So thank you very much, everybody. We wanted to have a little bit of a discussion about some of these issues, because obviously this is about tackling things like NCDs, unhealthy behavior, fixing me, a variety of other healthcare challenges that we have. So can I just start by asking if there are any questions of any of us at this point, or comments? So I want to open up a question for Dr. Martinez. So one of the things that Andrew proposed was being able to go from, okay, you've finally been dragged to the doctor by your wife. My wife is somewhere in the audience. She knows this only too well. And you sit down and you manage to run a test, maybe on Andrew's machine, and the information suddenly is at your fingertips while you're sat there with the individual. What do you think is the impact of being able to have a conversation before that man has a chance to run out the door that actually deals with perhaps the health issues that the information is giving them? How does that change your approach to? I've got a mosquito here. I'll have another disease in a minute. How does that change your approach to managing us difficult men?
Obviously, if you have the results immediately, so I mean 7 minutes or 8, 10, you use that time of waiting for the results to continue the education of the patient, and before he's running away, that is what normally they do, you give him the results, the treatment if needed, or the advice. What normally happens is that they do the blood test, and in 3-4 days, even 2, you call them back, and they are at the office. So in the last times I have changed. When I see something that I don't like in the blood test, I don't call. I tell the nurse to book an appointment, a free appointment. I don't charge for it. But I prefer to have the person in my face, so I can use different techniques. No? With a woman, it's very easy because they follow the instructions normally. With a man, you need to scare them. And you need to scare them in a way that is important for them. No? Normally, Sometimes I say, okay, you are an immigrant in this country, you are working here for saving money for going back to Jamaica, Philippines. Do you want to go back in a coffin and your family enjoying the money? Or do you prefer to come back in a nice plane and enjoy the money there with? If it is a local, I say the same, no? Normally I use an example. If you follow this, you will be enjoying the beautiful Cayman many years. If you don't follow this, you will be enjoying Cemetery Beach, that is beautiful from outside, not from inside, right? Because they don't see many people. No, there is a problem with when people has no education, it's more difficult to understand, no? And you need to be clear with them, because if not, they don't do it. I have prescribed medication for diabetes, and they take it for a month, and that's it. They don't come back. The next time they come back, they cannot see. I was a very good friend of Dr. Mani. He used to tell me that he presented in a congress in Miami of ophthalmology, and in any place, normally for glaucoma, it's a disease you prescribe drops, and if they don't work, you do the operation. In many men, he used to do the operation as a first, because he knew he was giving the drops, and they never come back until they are blind. So the approach, I know if I take out any of the women here, and if you don't use these drops, you will be blind. The first thing you think is, what are my children going to do with me blind? And then you appreciate to see it. A man forgets, and the next day is something very sad, but it is what it is, no? And depends also no, a lot on the education. So education is super important.
Many of us have obviously, well, all of us have had older relatives, of course, at some point in our lives. It makes us universally the same. But a question that I wanted to... Oh, there's a question down here. Let's do this first. Mm-hmm.
Mm-hmm. That being said, one reoccurring theme that people have been talking about, and even since yesterday, has been obviously pre-screening, prevention, shall I say. And as you alluded to in your presentation earlier, with taking time off when you're not sick to prevent you from being sick. One of the things that I wanted to ask the panel is, with respect to healthcare, with respect to insurance, with respect to being proactive, being preventive, normally that's not covered until you are sick, until you have to go to the doctor. So where do you see that changing? Again, like you said, education is key. Taking those incentives, not being afraid to go when you're not feeling well. But again, where do you see that changing? Because it's a reoccurring theme, and everyone has mentioned it. Everyone said, you know what, go get checked before you get sick. Go before, you have to. But the thing is that we don't really have that luxury to do that, because you're not covered. Your insurance won't cover it. The healthcare won't cover it unless you actually have a need to go there. And then God forbid if you actually do have something, then that just gets the ball rolling again. So I wanted to ask the panel, what can we get from this, or taking from this, along with the Ministry of Health and Wellness, along with all of the other, with the Health Services Authority and Doctors Express and hospital and all of those people, where can we actually come to that crossroads where you would encourage people and maybe even compensate them for taking the initiative and going to get pre-preventative care prior to this. And similar to what Lisa had said, and with respect to her presentation, numbers don't lie, stats don't lie. And we see that, women that are getting HPV care and born on or before 1995, it's almost all gone. But again, that's preventative. So it's taking that initiative to do that. So I just wanted to get your thoughts on that. And I am hoping that out of this, and this is why I love these type of conferences, out of this, that people will recognize this is an ongoing theme. How can we address that, and how can we encourage people to go, go get checked before you need to get checked, is what I'm saying.
Thank you. I think you're raising an incredibly important issue, and I'm going to make a couple of comments, and I'm going to hand over to Dr. Martinez for a couple of comments as well. First of all, I think there's some good news. I think there's a growing recognition that if we never address wellness, we will increasingly be unable to afford sickness. And I know that's recognized by the ministry from, obviously, Ms. Turner's introduction yesterday and some of the talks that we've had, which is good news, because if we're not even talking about that issue of how do we focus on wellness, then nothing is happening in wellness. I think obviously making the costs of wellness lower is part of that, because sometimes that's seen as prohibitive. I think we have to reset our normal behavior. Our normal behavior is to wait until we're sick. And so in some respects, we could say that maybe the structure of the insurance policies that we have is a function of what's our long-term historic behavior. Maybe we've all got to change that. If we were demanding of the insurance companies that wellness was a heavier focus, and we would go and use it if they did it, they're trying to cope with the back end, which is the ever-increasing disease burden. And of course, they're faced with what I think is a real Hobson's choice, because as the disease burden goes up and the costs of healthcare go up, then obviously what they have to do is raise the price of the policies. Arguably, there's even less room in there for wellness stuff each time they're carrying a bigger disease burden. But there's another problem as well. Because of our economic circumstances as individuals, the more the premiums go up, it's not that we do without health insurance. We go down in levels of cover, and actually we end up with less and less wellness cover. Because obviously something like BritK Absolute Premium has lots of wellness in it, and the BritK SHIC, and this is not a comment about BritK, just in case anyone was thinking, but the BritK SHIC plan has relatively low wellness cover. So I think there's a lot of complex issues here, but I think there is a focus on it, and we are starting to see a shift.
Humans, we tend to think in the short term, okay? When you have a job and you are the CFO of an insurance company, of any company, okay, they will check your economical results every year. And increasing the wellness is not going to give economical results in 3 years. It's going to give it in the long term. So the only way I see to do it is to change the mentality. Maybe, I always thought some ideas, no? If someone doesn't use the wellness in the policy, the next year he has a extra cost. So you force the people to use the wellness. To have a basic wellness is not so expensive, because to have a visit with a doctor, check for cholesterol, diabetes, high blood pressure, we are covering the main reasons that are making HSA to have dialysis. That is super expensive. We are covering the main reasons why the people has a stroke being 50 and has a disability. But to make someone that is under pressure every year, like a CFO, over the results, thinking in results in 10 years, we don't see the benefit of prevention in the short term. So we should focus more in wellness prevention than in sickness. I don't say that we don't have to cover sickness. We need to. But maybe in 20 years we are having less sickness because the people is better care from the 20s. And when they reach 50s, that is when things happen. They are not smoking. They try to drink moderately. They know how is their cholesterol, blood pressure, and diabetes. And they do some advice about cancer. And the woman do the pap smears, the mammogram, the man starts doing the PSA, the smokers do a low-dose CT scan, but the basic that you have to do when you are 30 is so cheap and easy that we cannot afford in the society to not have it done.
Thank you. We've got time for one more question. There's a question at the back.
Yes, just a comment here. As a primary care physician, and I am seeing patients who come in, you know. The thing is, one of the things I think that is missing here is health promotion. We have to make patients know that they are responsible for their health and they have to be a partner in their health and wellness, okay? I'm a great critic of the insurance companies that give you 2 visits per year, especially if you have a chronic disease. But guess what? If you took your responsibility for your health and know that, well, I'm going to go to the doctor, I'm going to have my screening test, I'm going to see what is wrong with me or what is not wrong with me. The doctor will write you a day sick leave, which is covered by your company, okay? You don't wait until when you're not feeling well before you come. If you only have 2 visits per year, you say, well, at this time, the 1st of March, I'm going, on my birthday, I'm going in, I'm going to get all my screening tests which are allowed me. But some persons do not believe that they really are partners in their health and wellness. And they're waiting until they're ill to go to the doctor for someone to tell them that there's something wrong. I think we need to do more public service announcements and more health promotion. Thank you.
Thank you very much. I mean, I think that's. I think that's a comment that we all recognise, and I think it's not just obviously the health promotion; it's also the reliable health information, because we're all subject to health influence and health information from so many sources, and it's not always right. And maybe that's a challenge to us as healthcare organisations and public health systems, is in increasing that so that people learn to trust the information that is actually helpful to them. I do think perhaps my wife paid you to remind me about the self-responsibility. And of course, that's really where I want to leave things off this afternoon, is that for all of these things, many of these things take time to change. But as individuals, we could take a decision today to change something that we're doing tomorrow and start to have an impact on it, whether it's a simple visit to an OBGYN or to a GP or getting a test for something that you think, well, you know, maybe I've got a bit of a family history around this, maybe it's better to know than not know. But it starts with a decision from self. And I think that's the principle that we really wanted to get across, is better health for self. Starts with self, but it's going to involve actually a whole system getting behind that principle if we really want to change it for a nation. Thank you.
Thank you very much, Andrew. Also, thanks to Professor Andrew Shaw, Dr. Lisa Joels, and Dr. Francisco Martinez. Thank you very much for that enlightening panel. This brings us to the end of today's proceedings. We'd like to thank you for being here, and we look forward to having you join us tomorrow as we wrap things up. Have a good evening.